Good morning, one and all. It's our great pleasure to welcome you all to the conference. Let us begin this enriching experience together. It's our pleasure to introduce Dr. Aparna, who is our clinical director, neonatologist at KIMS Cuddles, Kondapur unit. I request Dr. Aparna ma'am onto the stage. Madam is going to discuss on volume ventilation, why, in, whom and how.
Slides from here. So good morning and welcome again. Once again, welcome on behalf of the team, and we shall be discussing about volume ventilation. We know that this is one of the recent modes of ventilation and more often used in pediatric and adult ventilation, and these days adapted more and more into neonatal ventilation. Can we have the slides, please? The presentation? Okay, thank you. I'm sure most of you who are here are ventilating newborns, and you are aware of the basic concepts of respiratory mechanics and pressure control modes of ventilation. So with that assumption, we decided to have the more advanced modes of ventilation. So I hope all of you are used to ventilating newborns. Yes, most of you? Okay. So in this presentation, we'll try to keep it over like 15 minutes. We will be discussing the following headings. First of all, why volume ventilation, where we will be discussing the differences between Volutrauma versus barotrauma. And secondly, why this sudden interest in volume ventilation in newborns. Thirdly, we will try to discuss whether it is important for us to change our practice to volume ventilation, the pros and cons of volume targeted modes of ventilation. And lastly, we'll discuss whether there is enough evidence to change. Now we'll begin with the first question on why volume ventilation. So we all know that traditionally in pressure control modes of ventilation, the ventilator is destined to deliver a fixed peak inspiratory pressure, and based on the compliance of the baby's lungs, the tidal volume keeps varying with each breath, right? When the baby's compliance is better, like post-surfactant, the tidal volume delivered would be higher. And when the baby's compliance is low, like in stiff lungs with RDS, the tidal volume delivered with the same pressures is going to be lower. In volume ventilation, traditionally, which is a norm in adult and pediatric ventilation in older children, what we generally do is try and deliver a fixed preset tidal volume with each ventilator breath, in contrast to the TCPLV mode or time cycle pressure limited modes of ventilation, where we deliver a set peak inspiratory pressure with each ventilator breaths. Banu, I think we can switch off the compressor now because we will be only needing it for the workstations. It's creating a lot of sound. So let us look at the pressure volume loop in a traditional pressure limited ventilation. So you all know that pressure volume loop has pressure on the x-axis and the volume on the y-axis. So you know that we have a preset peak inflation pressure. So the first breath you had a tidal volume, which is represented by the green loop. In the second breath with the same PIP, because the compliance of the lung improved, the tidal volume increased, and you can see it with the yellow loop. And in the third breath, represented by the pink loop, because the compliance dropped for whatever reason, maybe because stiff lungs, RDS, or the baby had worsening consolidation, fluid due to pulmonary edema. In all these conditions, of course, this would not happen dramatically in one breath, but over a period of time, these conditions can reduce the compliance of the lung. You see that the tidal volume has dropped dramatically. So despite setting the peak inflation pressure at a certain fixed level, we have no control over the tidal volume that is achieved. It is going to vary breath to breath, day to day, and even perhaps baby to baby based on the compliance of the lung. So this change in compliance happens in various conditions like post-surfactant therapy, rapid changes in the functional residual capacity. So even if you have given a sustained inflation or increase the FRC by some maneuver, the dynamic compliance of the lung is going to suddenly change and you can have a variation in the tidal volume delivered. And this can be detrimental, especially for a preterm baby where you know that hyperventilation or high tidal volumes are associated with carbon dioxide washout, hypocarbia, which can lead to cerebral vasoconstriction and periventricular white matter injury. In contrast, when you do volume ventilation, we are able to have a certain control or we are able to fix the tidal volume, and irrespective of the changes in compliance, what the ventilator is going to do is to change the peak inflation pressure based on the compliance in order to ensure that the baby ends up getting the same tidal volume. So as we saw in the previous example, when the baby's compliance dropped or when the compliance of the lung was poor, as seen in the pink color graphic, the ventilator still managed to give the same tidal volume but by increasing the PIP required. Whereas when compliance was better or when compliance was high, you can see with the yellow loop how the tidal volume could be reached with a lower peak inflation pressure. So constant tidal volume is delivered irrespective of changes in compliance, and this is the key principle of volume ventilation. And why are we so interested in Volutrauma? So this classical study by Dreyfus et al., which was done in rodent lungs, when rodent lungs were ventilated with 3 different modes of ventilation, they used one mode which had high pressures and also high tidal volume. So they ventilated the rodent with high pressures and they didn't strap the chest wall, so the rodent also ended up getting high tidal volume. In the second mode, which is represented by the yellow bars, they used low pressure. So they tried to cut down barotrauma by using negative pressure ventilation, but the chest was still unstrapped, so the rodent still had high tidal volume. And in the third mode, what they did was they gave high pressure, positive pressure ventilation, but they strapped the chest wall of the rodent and tried to ensure that the tidal volume delivered was low. And what they found were all these markers of lung injury. So whatever you see on those 3 variables on top, the albumin percentage leaking from the alveoli, all these parameters represent, they are markers of lung injury. So you see that the lung injury was maximum with the high pressure as well as the high tidal volume modes, and it was significantly lower when the tidal volume was reduced by strapping the chest wall. So this very classical animal study gave rise to the concept that Volutrauma probably is as or much more damaging than barotrauma when you talk about the variables leading to ventilator-induced lung injury. So although neonatologists knew that Volutrauma is harmful and trying to achieve a constant tidal volume is beneficial, until recently there were a lot of technical pitfalls which made volume ventilation difficult or impractical. And what were these pitfalls? One is the fact that we use extremely small tidal volumes in newborns. So if you are ventilating, say, a 800 gram baby, what would be the tidal volume? Anyone? What is the usual tidal volume on a ventilated baby? 4 to 6 or 5 to 6 ml per kg. So let's say 6 ml per kg for a 800 gram baby would be 4.8 ml. Right? So these are extremely small tidal volumes for traditional flow sensors to measure. So this was becoming difficult to measure with the old microprocessors, and also the fact that neonatal ventilation is generally done with uncuffed endotracheal tubes, which gives rise to a lot of peritubal leak. This also makes the estimation of tidal volume difficult because you would have significant leak, especially during inspiration, where with the uncuffed tube you would have some volume that is lost around the peritubal area. So these technical difficulties prevented us from using volume modes, although we knew the benefits or although we knew the harms of Volutrauma. But these technical pitfalls have now been overcome by newer and better microprocessors. You will be seeing in the stations today how with the current generation microprocessors and flow sensors, we are able to measure tidal volumes of up to 0.1 ml. So you can deliver a volume as precise as a single decimal point. So even the tiniest of tiny tidal volumes now we are able to measure. In addition, we are also able to estimate the leak around the endotracheal tube, and newer modes of volume ventilation are able to give leak compensation. So if you know, for example, 30% of the tidal volume was lost due to peritubal leak during inspiration, this has suddenly become dim. Yeah. This can be compensated using leak compensation techniques. In addition, the other big problem was there was significant loss of volume even in the circuits, because some of the times, a lot of us would have ended up ventilating with adult circuits which have huge dead spaces. And when you look at the newborn's tidal volume, which is around 4 or 5 ml, and compare it with the circuit losses end up being much more. So with the advent of flow sensors which are able to measure the volume at the proximal airway or at the place where you actually deliver the ventilation to the baby rather than at the ventilator end, we are also able to more effectively measure the tidal volume that is actually reaching the baby. So I hope so far we have all convinced ourselves that volutrauma is as or more hazardous than barotrauma, hence the role of volume ventilation where we are able to achieve constant tidal volume. And 2, we have understood what were the earlier practical pitfalls in doing volume ventilation and how we have been able to overcome these. Now, are we ready to change completely to volume ventilation, which means you no longer control pressure as the control variable or limiting variable in each breath, and are you ready to change completely over to volume ventilation where you only control the tidal volume in each breath? So let's see this. This is a pressure time scalar of pressure on the y-axis and time on the x-axis. So let's see how it looks with a typical pressure limited breath, which is represented by the blue colored pressure time scalar. And on the right side, you have a volume limited breath represented as the red color scalar. So what is the difference? You see that in the pressure limited breath, there is a almost early or an instant rise of the pressure to the plateau or the peak pressure, whereas in the volume limited breath, there is a slow incremental increase in the pressure to the PIP. This is also called as a fin-shaped pressure time scalar, and this is one of the problems with completely changing over to volume ventilation. So because here volume is your driving variable, the rise in the pressure gradually to PIP happens over the inspiratory time and doesn't happen instantly as you see in the pressure time scalar. So if this happens, what is going to happen to the mean airway pressure in volume ventilation? Is it lower or higher? It's going to be lower because of the net area under the curve being lesser in volume limited modes of ventilation, and this technically can be an issue in babies with stiff lungs like RVS and can compromise on MAP. Also, when you look at the flow time scalars in pressure versus volume limited modes of ventilation, you have an instant rise in flow to the peak inspiratory flow rate in the pressure limited breaths, whereas you have a plateau shaped flow time scalar in the volume limited breaths, which kind of compromises the baby of that rapid increase in flow that the baby wants at the beginning of inspiration. And this can lead to something called as flow starvation. So a square wave flow pattern, which you see in volume limited modes of ventilation, can lead to a constant tidal volume delivery, but can be associated with the disadvantage of having something called flow starvation, wherein babies require that highest pressure, highest flow to be delivered in the beginning of inspiration, which doesn't happen with the typical volume limited modes. Also, the other problem with volume limited modes is that they can technically lead to inhomogeneous or dissimilar ventilation, wherein the areas of the lung which are better compliant will automatically get more tidal volume delivered selectively. So when X ml of tidal volume has to be delivered into the lungs and you have certain areas which are stiff, certain areas which are more compliant, obviously the ventilation will kind of happen preferentially in areas which are more compliant, and this can also compromise the areas of the lung which are atelectatic. So I'll perhaps skip this slide which explains why you find the decremental flow scalar in the pressure control modes and why not in volume control modes. So we discussed this part wherein the volume limited modes of ventilation will deliver constant tidal volume irrespective of change in the compliance of the lung, but it removes our control over the peak pressure. So we traditionally as neonatologists have always been taught physiologically that you operate at a certain range of peak pressures. Mild disease 14, 15, 16 PIP, moderate disease maybe 18 to 20, severe lung disease 20, 24 or maybe 25. And more than 25, 26, we have always been taught we should consider other modes like high frequency oscillation. So removing this control over pressure is like removing a certain, control from our hands, and we kind of feel lost because we seem to have no control at all over pressure. And hence we have a hybrid mode wherein we have some control over pressure and some control also over the tidal volume, which is called as volume targeted ventilation, which is what we traditionally follow in newborn babies. So VTV modes are those modes where every breath is a pressure limited breath, but this pressure is decided by the tidal volume or the compliance of the baby in the previous breath. In other words, the baby's compliance or the tidal volume achieved in the previous breath or previous few breaths determines the PIP that we are going to deliver in the current breath. So based on the ventilator mode and the ventilator algorithm, different types or different algorithms are followed to adjust the peak pressure, but the peak pressure in every pressure limited breath is essentially adjusted based on the compliance or the exhaled or the inhaled tidal volume of the previous breath or few breaths. So this is essentially a hybrid mode. You have different modes or different names based on the ventilator that we use. We have volume guarantee, which is patented by Draeger, and we have PRVC from Mackay Servo-I. We also have other modes like VAPS and TTV. TTV is available with SLE, and VAPS is available with the VIP bird. So I'll not go into the details of all the different modes because that is beyond the scope of one lecture. Let me just briefly discuss about volume guarantee. So volume guarantee is one of the most commonly used volume targeted modes of ventilation available with Draeger, both Babylog as well as with Draeger VN600. So this is not a standalone mode. It has to be combined either with SIMV, assist control or pressure support mode of ventilation. So every breath is still a pressure limited, either time or flow cycled mode of ventilation. So it's going to be time cycled if it is SIMV or SIPPV. It will be flow cycled whether if it is PSV. The physician basically sets the tidal volume. So you are going to decide a tidal volume, but you don't set a PIP. Rather, a P max, a PIP max is set to limit the peak pressure. So you still don't completely lose control over the peak pressure. All the other parameters are set based on the mode of ventilation. So for example, if you're doing SIMV with volume guarantee, you are still going to set PEEP, I time, rate, FiO2, flow if the ventilator allows you to set flow. If you're using PTV or SIPPV, you are not going to set the rate. All the breaths of the baby which are above the trigger level are going to be supported. So what volume guarantee does is, it uses the exhaled tidal volume of the previous breath to adjust the PIP of the next breath. Now in case tidal volume that we have achieved is more than 30% of the set tidal volume or more than 130%, right? The inspiration is going to be abruptly terminated and the ventilator will cycle to exhalation, right? This is like an immediate alarm system or protective system to avoid hyperventilation. So the moment you have, so for example, set 5 ml, 130% of 5 ml is 6.5 ml. So if the tidal volume in this breath crosses 6.5 ml, it will abruptly terminate that breath and cycle to exhalation. If in case tidal volume is low, the correction is not that rapid, but it will eventually increase the peak pressure, but only in increments of 3 centimeters of water per breath in order to still adjust or reach the tidal volume. So again, you have set 5 ml, but you ended up achieving only 3 ml in this breath. So which means you are only at 60% of the set tidal volume. So what do we have to do? We have to increase the PIP. The ventilator calculates, supposing the PIP increment is 5, that is needed to reach 5 ml. It won't do it in one breath. It will only increase 3 centimeters in the next breath. In the subsequent breaths, based on the tidal volume achieved, it is going to decide whether to increase further or to deliver the same PIP. So the reaction to hyperventilation is very rapid, but the response to hypoventilation is more slow, which is a protective mechanism to prevent lung injury. So let's see kind of a practical way where volume guarantee works. So this is just a graph comparing assist control versus SIMV with volume guarantee. In general, when you add volume guarantee, you can see that the fluctuations in the tidal volume are fairly minimal and CO2 washout is also kept to the least possible. But there are some challenges even with volume guarantee. This can happen when there are rapid changes in the baby's spontaneous inspiratory drive, because this leads to negative pressure and can lead to some dampening of the PIP that is being assessed. So even if the PIP that was required was 11, you might end up seeing 9 or 8 sometimes, because it gets kind of changed or modified because of the baby's negative pressure breaths. And intra-breath measurements, adjustments may not be possible until unless there is significant hyperventilation. So these are different types of trigger sensors, which I'll probably skip for the time being. Now, do we have evidence to change to volume ventilation? Yes, it has been seen that volume targeted modes of ventilation significantly reduce the duration of ventilation and the risk of Ehrlich syndromes, as well as hypocapnia and periventricular leukomalacia. They also significantly reduce the risk of brain injury as assessed by grade 3 or grade 4 IVH and severe grades of periventricular leukomalacia. There is also a significant reduction in the combined outcome of mortality and BPD, which has been shown in Cochrane meta-analysis as well as other systematic reviews. Now, I'll finish with these practical tips on volume guarantee. So when you typically do VG, you always have to add on to another mode. It is always best to try and add on to assist control, because all the breaths will be assist breaths and VG will be applicable to each breath. If you are adding on to SIMV, VG will function only for the control breaths or the mandatory breaths, and the assist breaths may not be accounted. So sometimes you may end up having 2 assist breaths in between a couple of mandatory breaths, and the adjustment based on the VG might follow after 2 breaths. So this might make the practical functioning of VG more difficult. When you start with the tidal volume, try to set with 4 to 6 ml per kg. The smaller the baby, higher must be the tidal volume in terms of ml per kg. And the P max that is set must be similar to the PIP of conventional ventilation, and a rough rule is that it must be at least 3 to 4 centimeters of water higher than the working PIP. So if you start with volume guarantee and you are seeing that the average pressure requirement is around 18, you may set the PIP max at 21, 22. PEEP will essentially depend upon the FRC of the lung that you are dealing with. So in a baby with RDS or atelectasis, you start with a higher PEEP, and in a baby with normal lungs, you begin with normal adequate PEEP. And all the other settings, including TI and rate, will be set similar to the conventional pressure control modes of ventilation. So these are some guidelines for setting the initial volume and for setting the PIP max. And whenever we see a low VT alarm, one has to always go back and see what was the reason for the low tidal volume, whether it was excessive peritubal leak or dropping compliance or a pneumothorax, rather than then just switching off the alarm or probably trying to change the alarm settings. So these are some recommendations on how to wean from volume ventilation. So obviously we will start weaning the tidal volume and not the PIP here, because weaning PIP is not meaningful. It is eventually going to translate into reduction in PIP when you reduce the volume automatically. And try to not use volume ventilation when you have excessive peritubal leak more than 40%. So I'll not discuss the other modes for want of time, and I'll hand over to the next speaker. If there are any 1 or 2 quick questions, we can take them. Rest we can take in the workstations. Mike, Vinay? Series.
Do you use PSV mode alone? Are you using it?
Yes, we do use PSV
with or
alone.
without volume guarantee? Are you using it?
Yeah, we do use PSV alone as well. It can be combined with volume guarantee as well. In fact, PSV with volume guarantee will give complete control to the baby for PIP, eye time, rate, most of the parameters. So essentially only PEEP is set by us. Most of the other parameters are set by the baby. PEEP and FiO2 will be controlled by us. PIP, eye time, rate, everything will be controlled by the baby. We do use, however, PSV without volume guarantee as well once in a while.
Okay. Thank you.
Thank you. So I welcome the next speaker, Dr. Babu Madarkar, Chief Neonatologist and Clinical Director at KIMS Cuddles, Secunderabad, for his session.
I think I'll be comfortable here. So why did you ask that question? I have some background thought about
using PSV alone. Most of the units they are not using. Even the literature says, but I don't know the experience of Aparna ma'am. But we are not using PSV alone.
Yeah, PSV alone we use in pediatric patients, less in neonatology because the chances of apneas are more. But then in baby who's recovering, last days,
Yeah.
in volume guarantee mode can be used.
Weaning mode.
So just to interact, what is Pmax? Which ma'am was saying? What is Pmax? Maximum set pressure. It is like beyond that point, the ventilation, the pressure should not reach. Basically, it is a protective mechanism. Yes, slight bit. So the topic given to me is high frequency ventilation with volume guarantee. So high frequency ventilation per se is a complicated topic. Volume guarantee is additional complication. When we combine, it becomes multiples of complications. But I'll try to make it as simple as possible. I'm very sure by the end of today's whole days, that's what we are discussing. And by end of today's, my 15-20 minutes talk, I think some delta difference in thought process will happen. So we have learned volume guarantee mode of ventilation. It is not protective only for against barotrauma, volutrauma. Those things are definitely there. In addition, in neonatology, it is beneficial in decreasing many things, whether it is mortality, IVH of all grades, grade 3, grade 4 IVH, pneumothorax, PVL, so many things. So volume guarantee now we know. So we have to use volume guarantee. That is a gold standard. Volume guarantee in association with assist control mode of ventilation is the gold standard. We have to use. In our units we are using it. Now, coming to a little bit about high frequency ventilation, I'll just give a brief, and then we'll go to the next part. So when we discuss about volume guarantee, is it possible for us to do in high frequency mode of ventilation? What is the tidal volume in high frequency? Is it possible for us to do it? If it is possible, is it going to change the outcome of a baby? So these things we'll learn. But before that, what are the main parameters that we know of in high frequency ventilation? Yeah. Mean airway pressure. Yeah. We have only these 5: mean airway pressure, amplitude, frequency, IE, and FiO2. Very simple. So you don't have to go in detail of all of these things. Only 5 things. FiO2, any ventilator will have. So basically we have only 4: MAP, amplitude, frequency, and IE and IE ratios. So one thing, when we are offering pressure in conventional mode of ventilation, I think in conventional mode of ventilation, pressure that we are offering to the upper airways is completely transmitted to the alveoli. Same pressures. In high frequency oscillatory mode of ventilation, we are not speaking about other modes of ventilation. It's only oscillatory. Jet and interrupters we don't use. The pressures, they keep on coming down. There is attrition of pressure, but end result is little different. The amount of pressure that we are generating at the alveoli is much less. But it's okay. We are only doing dead ventilation, dead space ventilation. We are not doing active ventilation. That is okay. So park this thought in one part of your corner. We'll move to the other part. Now, if you want to influence oxygenation, what are the parameters that we have in our hand in HFO? What are the parameters? One is MAP. Very obviously, it is FiO2. FiO2, if you increase, oxygenation will increase. Quite obvious. With respect to MAP, in conventional mode of ventilation, what is MAP? What is if you are on conventional mode of ventilation, if you want to increase oxygenation, what do we do? Increase PIP, increase PWP, increase TI. Eventually, we are increasing the MAP. And as a corollary, what is happening? We are also fiddling with PaCO2. There is, when you are increasing MAP, PaCO2 comes down. But in high frequency ventilation, MAP is only for oxygenation. It doesn't have anything to do with PaCO2s. Okay. So these are the two things for oxygenation. Now when we come to CO2, if you want to remove CO2, if there is accumulation of CO2 happening, if you want to remove, how do we do in high frequency ventilation? Increase the amplitude. What will happen? As you're increasing the amplitude, so it is showing here, as you're increasing the amplitude, there is increase of tidal volume, which we'll discuss, and then there is PCO2 falling down. And opposite also happens when we want to, the other opposite also can happen. Now, with respect to this is tidal volume across the map. So that is one stroke volume, tidal volume, active and passive, inspiration, expiration. So if we want to increase the area, complete area, the yellow area under curve, what are the mechanisms? Either you increase the height or increase the width, isn't it? How to increase the height? By increasing the amplitude. How to increase the width? By decreasing the frequency, isn't it? Not increasing frequency, no need to confuse. So when you are decreasing frequency, we are actually increasing the tidal volume, which is how you are washing out. The PaCO2. So tidal volume, VTHF means in high frequency. Tidal volume increases if you increase amplitude or if you decrease the frequency. So other things are also there. Just I'm trying to keep it as basic as it is, so as to make sure that we learn many things. Now, CO2 removal. If you want to remove CO2 in conventional mode of ventilation, what do? We increase the minute ventilation. So minute ventilation, how do we do? Either by increasing the rates or increasing the maps. Okay. In high frequency ventilation, we have to get used to a concept of diffusion coefficient. Okay. So what is the diffusion coefficient? So this detection, sequential numbers and all don't get confused. dCO2 is diffusion coefficient. The formula for that is tidal volume square into frequency. Okay. So for lower tidal volume, lower dCO2 values, just remember these two sentences. Whenever there is lower dCO2 value, there is CO2 retention, and when you do the blood gas, there is higher PaCO2 value. When there is higher dCO2 value, there is CO2 washout, lower PaCO2 in the blood gas. So high dCO2, higher PaCO2. Sorry, low dCO2, higher PaCO2. Higher dCO2, lower PaCO2. Okay. So where is this? How to calculate? Don't have to worry. It comes in most of the ventilators. This number directly comes. We don't have to worry. Okay. So one issue with high frequency ventilation is that when we are fiddling with frequency, for example, you decrease one frequency, there is a whole lot of change in PaCO2 that happens. You increase or decrease amplitude, lot of change, lot of fluctuation in carbon dioxide values. So if you see this carbon dioxide, hypocarbia, hypercarbia, hypoxia, hyperoxia, of all these, if you place them in decreasing order with respect to the ill effect that it can cause to the baby, most detrimental one is hypocarbia. Hypocarbia causes most damage. Then it is hypoxia. Then it is hyperoxia. Least is hypercarbia. So hypocarbia causes a lot of damage to the baby. So this fluctuation keeps on happening. So we have to figure out a way by which this fluctuation doesn't happen. So what is that way? That way is tidal volume guaranteeing, tidal volume controlling. What is that way? That way is we have to make sure that tidal volumes are guaranteed and specific, and there is no great fluctuation in PaCO2 levels. That is done by stabilizing the diffusion coefficients. Now, what madam has told is that in conventional mode of ventilation, if you want to guarantee the volumes, what you will do is, the tidal volume is set, it is constant. Your pressures are fluctuating. In routine ventilation that we see, the pressures are set, tidal volume keeps on fluctuating. This is the crux. Likewise, in high frequency ventilation, amplitude keeps on fluctuating against the set tidal volume. So here it is amplitude, there it is pressures. Okay. Now if you see the the screen, this is DCO2, this is the delta P. Routine ventilation, routine high frequency ventilation, we are setting the delta P and DCO2, which is the measure of tidal volume. It keeps on fluctuating. What we have to do, we have to set this and let this fluctuate. So this is what is about volume guaranteeing in high frequency ventilation. So now, so what actually happens is when we are, when the frequency is on lower side, tidal volume, as we have discussed, because the width increases, tidal volume increases, isn't it? And as the frequency is increasing, the tidal volume decreases, which is not good for the baby. So what we'll do, we guarantee the tidal volume, irrespective of the change in frequency, the tidal volume remains the same, isn't it? Simple. It is simple. Just try to assimilate things and match things, join the points. So what is that tidal volume? How much do we have to set? So tidal volume, normal tidal volume is 4 to 6. Here we keep it around 1/3. So there are so many studies, so many observations, they say it is 1/3. That is the dead space. We keep it around 2 ml per kilo. For a smaller baby, we keep little big higher. Bigger babies, we keep little lower. So this also we know. We always, when we discuss about this PV loop, we always discuss about balloon. As we keep on inflating balloon, initially there is certain amount of resistance. It doesn't inflate, doesn't get inflated. And after a certain point of time, there is certain give way. It keeps on inflating. After it has inflated, you try to leave it. There is certain amount of resistance even for deflation. That is how the graph goes up. And suddenly it gives away and comes back to the base point. So this is the best point, the green mark where we have, this is the best point for ventilation. So the principle of high frequency ventilation is based on this. We have to offer MAP, recruit the lungs, de-recruit and re-recruit. Then we will reach this. So this is the principle behind setting MAP. So we want to ventilate the baby to offer best possible support. Now, so there are many studies with respect to benefit of this. Basically, in addition to so many benefits that we have learned before, it is also helpful in decreasing death, BPD and other things. So practical guidelines, how do we have to do? First, when we have the situation of putting baby on volume guarantee mode of high frequency ventilation, set MAP as usual. Then we have to follow principle of recruitment, de-recruitment, re-recruitment. Increase the pressure of MAP as compared to the previous mode and try to decrease to as low as possible and again increase by 2 more. Okay. Then we are setting the amplitude upper limit. Just like we had this Pmax setting, we have upper limit of amplitude setting here. This is upper limit. The fluctuation should not go beyond this. Then we have tidal volumes. Usually we keep it around 2 ml per kilo. Then set. Amplitude keeps on getting adjusted. And we do a blood gas in a half an hour. Once blood gas is done, if things are set within normal limits, we don't touch the baby. We need not do repeat blood gases. Only DCO2 monitoring is sufficient for us. We don't have to do. That is so simple, so easy in real scenarios. So we have to see, are we reaching tidal volume appropriately or not? If tidal volumes are reached appropriately, then what is the amplitude that we are reaching? We have to make a note of it. If the tidal volumes are not reached, we have to do certain corrections, circuit issues, secretions, and all those things. So aim should be to achieve highest frequency and make sure that lowest tidal volume with space for amplitude is available. Basically, we have to offer highest frequency as much as possible. That is most protective. Set MAP, then amplitude max we set, then tidal volume we have to set. Try to increase frequency to a upper limit. At certain point, there is a give way. When we are increasing, tidal volume keeps on falling. So that set we have to keep and leave it at that place, isn't it? Only 4 points. Set map, then amplitude, highest amplitude. Then we are setting tidal volumes and try to fiddle with frequency, try to keep it on higher side. Okay? So frequencies 8, 10, 12. Smaller baby is higher frequency, bigger baby is lower frequency. Okay? We have to do blood gas in half an hour. Then other thing, these things we know. If there is hypoxia, what we do? Increase FiO2 or increase MAP by 1 or 2. If there is hyperoxia, opposite of it. In case of hypercarbia, what do we do? If it is volume guarantee mode, we are actually increasing the tidal volumes or decreasing the frequency. We have learned this. Opposite we have to do in hypocarbia. So don't worry about IE ratios. IE ratio 1 to 1:2, 1:1, it's all same for these scenarios. It doesn't have much role to play. Only these two things. For hypercarbia, we are increasing the tidal volume that is setting or decreasing the frequency. These only two things we have to do. So troubleshooting, not much requirement. So one more thing, the 2 points I asked you to keep in your mind. One was that thing, second one was DCO2. Third thing, so we know that the DCO2, the formula is tidal volume square into frequency. So whenever we are increasing the frequency, what is happening? Tidal volume is coming down. Here, tidal volume square into frequency, overall DCO2 is coming further low. Okay? So which is how increasing frequency will cause the CO2 to get retained. In conventional ventilation, what is happening? Increased frequency, CO2 washout. In high frequency ventilation, increased frequency, there is opposite of that thing, where there is CO2 retention. But in volume guarantee mode, this tidal volume is constant. So whatever change in things that you're doing in frequency is not affecting the tidal volume. Okay, the tidal volume is constant. So whatever change is happening is only in frequency. So here the concept is same like as it is in conventional mode. So conventional mode, increase frequency, CO2 washout. Normal high frequency ventilation, increase frequency, CO2 retention. In volume guarantee plus HFOV, increase frequency, CO2 washout. So everything is based on this formula, constant. So tidal volume square into frequency is equal to DCO2. Okay, so if you are not able to remember, just you remember one thing about conventional ventilation. Everybody knows about it. Increased frequency, CO2 washout. Opposite happens in high frequency ventilation. Same thing happens in high frequency ventilation with volume guarantee mode. Okay, so after that, it is very, very easy. We have this DCO2 levels set at 40 to 80. That is the standard normal in the ventilators. So if it is going below, it is hyperventilation. If it is going above, it is hyperventilation. So after that, it is like it does auto weaning by itself. We don't have to change the settings. Nothing has to be done. Because when the baby is improving, tidal volumes are set. Amplitudes, they keep on coming down by themselves. We only have to come down on amplitude, the maps. If the baby is stabilized, then come down on map and extubate the baby. Very simple. It's like auto weaning process. So summary is tidal volume can be fixed in the high frequency mode of ventilation. We have to use low tidal volumes in premature infants. Highest frequency that we can be achieved, which is around 12, up to 15 also we can go. Try to maintain CO2 levels. All that we are speaking here is to make sure that CO2s are within normal limits, and we have to try to achieve lowest tidal volume with highest frequency. So I think when we are coming to the workstations, these things will be more simplified, can be more easily discussed. So thank you very much. So any questions, please ask.
Any questions?
Okay. So when we come to the workstations, we'll discuss. When we have hands-on experience of it, then again, it will be more convincing. Thank you.
Thank you, sir, for your informative and engaging presentation. Your insights into high-frequency volume, ventilation with volume. Next, we are call up Dr. B. Bhavani Deepthi ma'am. She is our senior consultant, neonatologist and pediatrician at KIMS Cuddles, Gachibowli unit. Over to you, ma'am.
Good morning all. A warm welcome to all the delegates and faculty. So today the topic for discussion given to me is surfactant therapy in sick neonates. So as treating residents and treating doctors, one of the expensive medicines we use in neonatology is the surfactant therapy. So to reiterate, when do we use it, how do we use it, why do we use it? Later then I'll talk about the recent updates. So as you all know, surfactant is mainly composed, 80 to 90% of it is lipids, out of which phosphatidylinositol, phosphatidylcholine, phosphatidylglycerol are the main components. Phosphatidylcholine, that the DPCC, dipalmitoyl phosphatidylcholine, along with the surfactant proteins SP, B and C, they are involved in lowering the surface tension of the alveoli. Whereas the proteins SP, A and D are mainly involved in establishing innate immune response. They attack the bacteria and they establish the lung immune response mainly. So keeping surfactant aside, there are various influencers, be the maternal conditions or the neonatal conditions per se, which can change the effect of surfactant therapy in the neonatology. So mother getting affected with maternal hypertension amounting to PIH, causing IUGR in the baby. Mother getting affected with hypothyroidism or maternal uncontrolled or poorly controlled gestational diabetes, or presence of chorioamnionitis in the mother. These factors can influence the surfactant therapy, as well as the neonatal conditions like RH isoimmunization, multiple pregnancy, the second one, the last baby, or the male gender, or having issues with insulin resistance or the androgens also are shown to affect surfactant in neonates. So starting from the delivery room to NICU, there are at least some prerequisites that are necessary to be done so that the surfactant delivery and the effect of surfactant goes very well to the newborns. So starting from the delivery room, first thing, taking care of the temperature plays an important role, even though I haven't mentioned it here. So taking care of the temperature in the labor room or the OT. After that, taking necessary precautions for the safe delivery of ELBW or VLBW, whoever is about to be there. So all the coming to the antenatal corticosteroids, which serves as the main step here. So all the pregnant mothers who are at risk of imminent delivery, starting from 23 plus 6 weeks to 33 plus 6 weeks, according to the guidelines, should be given antenatal corticosteroids. The last dose, that is the second dose, at least 24 hours apart between two doses, and 24 hours after the last dose will give the maximum effect. However, even the 6 hours period is also enough for the steroids to act and surfactant to get a better outcome. So these steroids are as such shown to reduce the risk of all the neonatal complications more, reducing the mortality or the combined outcome of death or BPD. So in the delivery room, taking care of the golden hour concept in the neonatology helps a lot, even with respect to the surfactant delivery and in the combined outcome of death or BPD. First point, as I already mentioned, taking care of the temperature, ensuring that there is a radiant warmer to nurse the baby, taking care of the plastic bags or polyethylene wraps, or if there is an availability exothermic mattress or even the baby warmer or even the embracer, and provision of blended humidified oxygen along with the pulse oximeter, and of course trained personnel need not be told already, we are already there. And second is starting the delivery room CPAP as soon as the baby is born. That is the concept of recruitment before you give surfactant, not the prophylactic surfactant. Here is what I'm trying to imply. So in the NICU, for example, if the baby has been stabilized in the delivery room or even the labor room, after that is done, so always a backup ventilator should be available. We have provided delivery room CPAP and also the surfactant administered within 1 hour of the birth. See that there is a facility for a backup ventilator. In case there is Ensure or LISA failure, backup ventilator facility should be available. In case there is no possibility like that, it is safer to transport the baby to a level 3 or level 4 NICU, or even safe and best would be the in utero transfer to ensure better outcome of the baby. So coming to the timing of the surfactant. So there was initial school of thought where prophylactic surfactant was administered initially, but now we resort to rescue therapy, and more early rescue is the preferred strategy because of better resource utilization, avoiding prophylactic surfactant. In fact, prophylactic was shown to increase the incidence of air leaks or even the BPD. So coming to the late rescue, it decreases the need for surfactant use anytime during the hospital stay by almost 33%, and it's also shown to reduce the duration of mechanical ventilation as well as the days, and also it is shown to have better outcomes over the combined effect of death of BPD. So the NNF CPG guidelines 2021 clearly gives a recommendation: early rescue surfactant should be used in neonates within 2 hours after birth. So there are various treatment thresholds, like which FiO2 should I give surfactant, which PEEP should I give surfactant. So it clearly shows PEEP, we start with a delivery room CPAP of around more than 6 centimeters and FiO2 of 30% according to the standard NRP in case the baby is born below 34 weeks. So coming to the newer ways, is it the Ensure, or is it, initially we started with intubating ventilation. Later we devised a new method called Ensure, where we intubate, give surfactant and extubate. But however, intubation itself can cause Rohini and the trauma that's caused by the endotracheal tube, apart from the baro and Volutraumas that we already spoke about. So as such, even the flow of gases during the positive pressure ventilation that we give, while we give Ensure or the mechanical ventilation, has shown to change the inflammatory pathway or the cytokines that are released during this process, and they are implicated in the pathogenesis of BPD further. So this is a newer way, you must have already known about this. This is a newer way of surfactant administration where different catheters, initially they started using the feeding tube. They used even the angiocatheter, which is 16 French, and later the LISA catheter, which has a memory, is available and it is being used widely. So some of us would be using it, some of us do not, but today we have separate workstation for it, and I will be discussing certain points related to that as well. So various techniques were used for this LISA, be it Colon method or take care method or the Hobart method. The prerequisites for LISA, the initial technique where it was employed was, they used the Magel forceps to incorporate the feeding catheter into the larynx, and then usage of sedatives also was there, so that the less of reflux or less of cough would be there. And then after taking care of the non-pharmacological measures, then initially used surfactant was the porcine lavage, where poractant was used. The problem, one of the main problems that we always encounter during LISA is the cough, reflux or the bradycardia episodes. So as you can see, the adverse effects during LISA are occurrence of one of the main reasons for failure of LISA is the occurrence of bradycardia, occurrence of desaturation, occurrence of cough or reflux. So success rate on the first attempt is between 72 to 95%, whereas the frequency of saturation or bradycardias or need for rescue PPVs by aborting the procedure also is very high. However, there are various RCTs which evaluated LISA versus the Ensure or surfactant through endotracheal tube. it has been shown to be of grave benefit, and it is promising in cases of outcomes such as decreased incidence of BPD or decreased incidence of air leaks, decreased incidence of intubation within 72 hours of life, or even the decreased need for the PDA's medical management. However, both INSURE and LISA do not give the pre-medication, more importance to the pre-medication or the timeout for each procedure that we do. This ENSURE, the enhanced ENSURE, integrates the respiratory principles into it and gives us clear-cut time frame as well as recruitment of the alveoli before giving the surfactant. So it addresses the duration, monitoring as well as usage of sedation or analgesia during the procedure. So here, first we start with the preparation of equipment check. After that, we administer sedation. Some of the units do practice analgesia or sedation during LISA as well, but some do not. But in ENSURE, the enhanced ENSURE clearly gives us principles of what kind of sedative that we use and what is the timeout for each time of intubation. So the propofol 1 mg per kg is given. It's diluted with normal saline and given. Later, the intubation is done, which is confirmed by ETCO2 monitoring, and recruitment is done with volume guarantee ventilation. That is, tidal volumes of 4 to 6 ml per kg, ideally 5 ml per kg is given so that recruitment is proper before giving the surfactant. So it is clear, it has a clear-cut delineation where not just giving surfactant after intubation, but recruit the baby's lungs so that the surfactant gets deposited homogeneously into each and every part of the lung. There is the next technique which was devised, intubate, recruit, surfactant and extubate, where the concept of high frequency ventilation is used for recruiting the baby instead of volume guarantee ventilation. However, the INREC LISA trials are still going on, results are awaited, where two arms are compared. The first arm, surfactant is given by INRECSURE, the intubate, recruitment and surfactant and extubation. The other arm is just the LISA. So results are awaited. The problem with INSURE is there are certain problems that make the INSURE fail. Like we won't be able to extubate, or we need the continuation of mechanical ventilation, is most importantly VLBW or ELBW babies. And inability to recruit the lungs before surfactant, that can cause failure to extubate and failure of INSURE also. And if there is any hemodynamic impairment, for example, baby was born in a very stormy condition where we are unable to extubate after the surfactant. Second is, if the severity of RDS is very high, that just one dose of surfactant and extubation cannot be enough. So the INRECSURE, some of the trials where INRECSURE was compared are, and they have shown a clear-cut benefit where in-hospital mortality or the days of mechanical ventilation was significantly less in the neonates who received INRECSURE, as well as the incidence of pneumothorax and pulmonary interstitial emphysema also was less, and even the severe grades of intraventricular hemorrhage also was very less in babies where intubation, recruitment, surfactant and extubation was done compared to just the INSURE. So even the LISA or even INSURE or INREC LISA do not actually qualify to be calling it as a less invasive, actually speaking less invasive surfactant, because there is a tube that is getting inside the baby's vocal cords, and just the flow of gases or even that can inside the cytokine inflammatory response, and that can cause BPD further. So the most non-invasive or the less invasive way of delivering surfactant will always be a usage of nebulized surfactant. However, the evidence is still lacking pertaining to the type of the surfactant that needs to be used, the size of particles that can give clear installation into the airways, also the type of device. Previously, the jet nebulizer was used to deliver surfactant. However, it didn't show promising results. Currently, there are trials where NEO-INSPIRE trial, to be precise, where a vibrating membrane nebulizer is being used to take surfactant, and it converts surfactant into 3 to 4 micrometers of nanoparticles, and it starts deposition of surfactant into the baby's airways. However, the trial results are pending, and it is going to compare the outcomes of death or BPD versus the nebulized surfactant versus the other non-invasive method we talk about is LISA. The trial results are about to come. So the surfactant that they used was Survanta, and they used vibrating membrane nebulizer. Still the guidelines pertaining to which type of nebulizer is used or the dose of surfactant how much needs to be used, as well as the outcomes are still yet to come. So another type of interface where the trained health personnel, for example, is not available, and it could be done in any ICUs, is using a supraglottic airway or the laryngeal mask airway. So these advantage of LMA is it requires less technical skill. It can be applied by even in a places where there is resource constrained settings with limited skilled manpower. The problem, however, the problem with LMA is it is very difficult. Even with 1 French of LMA, it is very difficult to be placed in less than 28 weeks of gestation, and there is always a problem with delivery because how the deposition goes through LMA is always a question. So this is a trial, SALSA, surfactant administration through laryngeal or supraglottic airways. The schema, how the supraglottic airway is placed and how the recruitment is done and how the surfactant is administered has been given clearly in their protocol. Interested people can go through that. I am not focusing much on it because of the want of time. So NNF CPG 2021, however, doesn't recommend LMA for surfactant installation in preterm neonates less than 37 weeks. So what about the repeated doses? Is 1 dose enough? When do we need to give the second dose is the next question. So there are manufacturer recommendations for the porcine lavage as well as the bovine lavage. However, a neonate who has at least requirement of MAP more than 7 and FiO2 requirement more than 30 or 40 above becomes the ideal candidate for repeating the surfactant dose. However, a lower threshold can be given to neonates if there is concurrent sepsis or asphyxia along with RDS. So the manufacturer recommendation is poractant, that is the Curosurf that we use. The dose usually given is 200 mg per kg that can be repeated at 12 hourly intervals for 2 doses. And the Biractant, that is the Survanta that we use, it can be given maximum up to 4 doses. This is the manufacturer recommendation. Usually, ideally in clinical setting 2 to 3 doses is the maximum that we give. We shall limit 2 to 3, not more than that. So what about the other category of babies where they actually do not suffer from severe respiratory distress syndrome, like the late term 34 to 36 weeks or the early term 36 to 37 weeks? So they also do require surfactant in certain scenarios. The concept of focus, that is the bedside lung ultrasound, can help in giving us a clear picture whether it's the transient tachypnea of newborn or the respiratory distress syndrome per se, where there is actual necessity for surfactant, which can actually help the baby in decreasing the need for CPAP or ventilation. So in this category of patients, FiO2 requirement more than 40% and with a PEEP of more than 7 centimeters, NNF CPG 2021 clearly gives a recommendation to go ahead with early rescue surfactant or maximum late rescue. However, NNF clearly suggests that there is no role for surfactant in neonates, be it preterms or terms, who have crossed the age of 72 hours. So one of the new things is administering intratracheal budesonide along with the surfactant. So systemic corticosteroids always have many side effects, more so in case of ELBWs and VLBWs. So in this scenario, intratracheal budesonide has been tried and it has shown promising results actually. Yes, of course, there are trials, plus trial, where it is concluded that there is very little or no effect of instilling budesonide along with the surfactant. But however, I was in the unit where we were giving budesonide, intratracheal budesonide plus surfactant. It's actually, only thing is sterility has to be taken care, because the dose of budesonide that we administer along with surfactant is 0.25 mg per kg plus 100 to 200 mg. If we take Surfactant, it is 100 mg per kg. We mix it and we give it in aliquots in a very phased manner. So this is an meta-analysis of around 8 RCTs combined with a sample size of around 2,000 patients, where the forest plot shows a clear-cut preponderance or clear-cut favoritism towards using intratracheal budesonide plus surfactant therapy versus surfactant alone. It has shown to reduce the incidence of bronchopulmonary dysplasia by almost 28%, mortality by around 27%, the incidence of pulmonary hemorrhage by a very significant percent, around 42%, and also the incidence of PDA by around 26%. So the dose was 0.25 mg per kg plus 100 mg per kg phospholipids of Surfactant versus Surfactant alone. So currently NNF CPG, it gives an guideline. It may not be used as an adjunct in treating neonates with less than 34 weeks. Basically, we are waiting for more evidence to incorporate budesonide, because in our setting where it is used over a wide array of places, sterility needs to be taken care of. So coming to other set of babies, the term babies, where surfactant could be a promising entity, in meconium aspiration syndromes, where bolus therapy versus surfactant lavage was seen. The incidence of meconium stained liquor is 9 to 20%, whereas the incidence of MAS is only 3 to 5%. In the LMICs like one of ours, surfactant therapy gives a promising role in reducing the need for ECMO or the ventilation, because only certain units are equipped with usage of inhaled nitric oxide or ECMO. So compared to surfactant lavage versus bolus therapy, both have been used. The concerns with the lavage is it requires a lot of surfactant. It is a big impediment on the cost, as well as mixing of the surfactant requires dilution of it, and it requires a laborious procedure up to 1 to 1.5 hours. That's why surfactant lavage, even though in studies it was better compared to the bolus, however, we follow the bolus treatment, bolus therapy of surfactant administration in severe MAS babies, which is shown to reduce the need for ECMO. In neonates where oxygenation index is crossing 15% and there is an impending need for ECMO, surfactant therapy has actually clearly given a clear benefit. It also may be considered in late term and term neonates with high OI, where severe bacterial pneumonia that could cause surfactant deficiency, like as in blood aspiration or the aspiration pneumonia or the congenital bacterial pneumonia also, surfactant has shown to be a great role. So in neonates where pulmonary hemorrhage is one of the conditions and that is causing the morbidity, surfactant also has shown to be of promising role. However, not just the surfactant, along with it high frequency ventilation for recruitment and the treatment of the other concurrent factors like coagulopathy or the infection and the hemodynamic instability, the shock due to either hypovolemia or the sepsis, if taken care of, surfactant also has shown to reduce the AADO2 as well as improvement in OIs. So to summarize, in preterm neonates, it gives a better results rather than surfactant alone if the golden hour management is addressed carefully, because if hypothermia is taken care of, hypocarbia or hypercarbia, as well as hyperoxia and hypoxia, all of them if taken care of, surfactant alone can improve the combined outcome of death or BPD. So late term and early term neonates also do benefit from surfactant therapy in certain situations. Incorporation of LISA is still a learning curve. Some of us and most of us need to have a learning curve with it and then try to incorporate. So LISA catheter alone is not mandatory. It could just be done with a feeding tube as such. So only thing is you just need to have the learning curve for it. Second is it also appears promising in conditions other than the RDS due to prematurity like severe MAS or in pulmonary hemorrhage. Thank you. So we are open for discussion. Any doubts? Yes, yes.
So we generally take in a syringe surfactant, right? So we have to take same the budesonide ampules we get out.
Yes. So we dilute it sterilely, we mix it with surfactant and then give in aliquots. Yes, yes. Dilute the budesonide with NS and then dilute it, then mix it with the surfactant. 0.2, usually we maximum 1 to 0.5 ml. As we have the limit of too much of surfactant can cause an issue. So this Neo-inspired trial was actually the main sample size was 25 to 28 weeks. Their focus was to improve the outcome of death or BPD in those small babies. And majority of the times, it was poractant alpha. However, in this category of babies, Surfactant was used. The problem with Surfactant is the volume. CuroSurf has good amount of phospholipids, like 200 mg per kg, so that almost is 1 ml has 25 mg there. But Surfactant will have little less, so directly the volume of surfactant that we give will be very high. So the dilution needed for budesonide should always be less than 0.5 or 1 ml max. And then dilute it with surfactant and go ahead with, yes, yes, you mix everything and go ahead. So this was basically to alleviate the side effects that can be caused due to systemic corticosteroids. Intratracheal budesonide was tried. Any other doubts? Over to Arvinda.
Thank you, Dr. Bhavani Deepthi, for that enlightening session on surfactant use in neonates. So now we will move on to the workstations. So I request all the participants to divide yourselves in 3 groups so that we have 4 workstations. The first one is bedside echocardiography, basics and views in the library. This is on the right hand side when you go out. Second one is pulmonary graphics, here only in yoga hall. Third one, high frequency ventilation and Nava in yoga hall. And ECMO in neonates will be in the VC room on the left hand side. So all the workstations have been pasted on a paper outside the rooms so that you can navigate easily. So can I request all the participants to lift their hands? Yeah. So now just we'll start from there, like 1. You will be going to the number 1 workstation. So that is in the library. Okay, 1, then you 2, 3, then again 1, yeah. 2, 2. Who is the next person? 2, 3. Then from back side, 1, Ayub 2, Dr. Subbareddy 3. Then this side, 1, 2, 3. Any others this side? 1, okay, 2 and 3. Just tell your own numbers so that you will not forget. 3, 1. Okay. So, yes, ma'am, we'll begin.
So tea is going to be served in the workstations. So I think we can straight away split for the workstations. But before we go on, it's our duty to actually thank all the faculty. And can we distribute their certificates? So we are going to call upon our faculty, and I request Dr. Aravinda to get their certificates and kindly distribute to them. I'll begin by calling Dr. Babu. Please come on to the dais. So please give a big round of applause. We are distributing the faculty certificates, and we sincerely thank all our faculty. Aravinda, can you kindly... Thank you, Dr. Babu. Dr. Bhavani Deepthi, please join us. Consultant neonatologist at KIMS, Gachibowli. We have Dr. Naveed from consultant neonatologist from KIMS Kurnool. I request Dr. Vishwa to join us for giving away few certificates. Thank you, Dr. Naveed, for coming all the way from Kurnool. Dr. Linga Reddy, who is a neonatologist and faculty at OVC Deccan Medical College, as well as Princess Esra Hospital. Thank you, sir. I'll request Linga Reddy sir to stay back and kindly give away certificates to our team, sir. Dr. Vishwanath Nandiala, Dr. Aravinda Lochani, Dr. Amit Kumar and Dr. Pranita, consultants from our team. I request you all to join us one by one. Please give them a big round of applause. All of them have worked very hard for the workshops and the workstations. So, Dr. Vishwanath Nandiala from KIMS Kondapur team, Dr. Aravinda Lochani, Dr. Pranita and Dr. Amit Kumar, all of them consultants at our unit here. Linga Reddy sir, meere ivali antariki. May I request Dr. Babu to please join us and felicitate some of our faculty, because we will not get a chance to probably meet everyone together. Dr. Pranita, Dr. Amit.
Just Amit sir onto the stage. Sir.
Request Dr. Guru Prasad, who has come from KIMS Vizag, consultant neonatologist and pediatrician there. Thank you for joining us, Guru Prasad. Dr. Sindhu. We request Dr. Sahiti to please join us. She is consultant neonatologist at KIMS Guntur.
I request Aparna ma'am onto the stage. I request all our consultants onto the stage. Sindhu ma'am, onto the stage. Dr. Sindhu Maru ma'am. Dr. Sonali ma'am, please join onto the stage. Dr. Sonali ma'am. Dr. Panibhushan sir.
So I hope the faculty are clear with the workstations. Echo will be done by Dr. Amit and Dr. Arvinda, and I request both of you to take care of the station and the library. So group number one again, can you raise your hands? Yeah, you all will be going to the library, which is on the right side for the first station on Echo. Station 2 is going to be on pulmonary graphics. Who are doing pulmonary graphics? Dr. Bhavani and Dr. Lingareddy sir will be doing pulmonary graphics. So this station is right on your right probably. Those of you who are facing us, it's the station here, the SLE station. Bhavani and Dr. Lingareddy sir are going to do this. So group number 2 will go to pulmonary graphics. Group number 3, please go to HFO and Nava, which is right behind you on the other side, on my right side. Yeah. Dr. Babu and Dr. Guruprasad will be doing HFO and nitric. The 4th station is ECMO, which is in the VC room. As of now, none of you will be coming there. Now, after you finish the rotation, each rotation is going to be 30 minutes. Group 1 will move to station 2, group 2 will move to station 3, and group 3 will move to station 4, which is ECMO, right? So you will all be moving clockwise. So now 1 go to station 1, 2 will go to station 2, 3 will go to 3. After half an hour, +1, +1, +1, right? And then so on. So it will be going on clockwise. Thank you. So after 2 hours, we will be breaking for lunch.
This one?
Is the display of the setting as well as some calculation. So you might be knowing so many calculations just done by the ventilator, and it will display. Depending upon that, you can change your ventilator settings to give it most appropriate pressures and so the inspiratory hold, set the inspiratory time.
Each and every loop. Okay. I am clearly audible. Yeah. Yes. So, for a pulmonary graphics to be seen, అసలు ఫస్ట్ గ్రాఫిక్స్ అనేది వెంటిలేటర్ మీద రావాలి, కరెక్ట్గా కనిపిస్తుందా లేదా చూడటానికి వీ నీడ్ వాట్ ఈస్ కాల్డ్ మాట్లాడడం. ఇవన్నీ ఎట్లా అంటే ప్రాక్సిమల్ బేబీకి దగ్గరగా ఉండాలి అండ్ మోస్ట్ సెన్సిటివ్ ఉండాలి. Okay, so this sensor that we use here is a hot wire anemometer where 2 platinum wires.
Sometime we can switch off when you are explaining.
Compressor.
No, when she is explaining graph, then you stop.
To 1 minute I'll start off.
లేదు కాకపోతే మనమే దూరంగా పోతే బాగుండేదేమో. జస్ట్ ఆఫ్ హియర్.
So, sense, it's fine if you can hear them also. So, proximal sensor ఉన్నప్పుడు, so this different hot wire anemometer ఉంటుంది, then pneumotachograph ఉంటుంది, even you have the EADI, electrical activity of the diaphragm. So, that you have a separate station, there we can discuss how is it placed, what are the troubleshooting, everything. ఇప్పుడు ఇందులో ఉన్న particular sensor is hot wire anemometer where 2 platinum rods are kept and one rod is marked. One rod will be marked. When the flow of gases flows from one rod to another rod, the change in the temperature will be taken as it will be taken care of. Understood? That's why I am taking enough time on the flow sensor. Without flow sensor, volume limited ventilation is not possible. Even in synchronized NIPPV, SNIPPV, flow sensor is mandatory. How do we synchronize the ventilator with the baby? This is the mediator for us. Flow sensor is the mediator. That's why it's very important that we calibrate the flow sensor before we start using it, and it's very important that you keep it also very sterile. Connect it in the right way. So coming to pulmonary graphics, there are 2 types. Okay. First is the waveforms, pressure, flow, volume. The 3 variables: pressure, flow and volume. Okay, everything is calibrated against the time. So these are the measured things, and the PV and the flow volume will be the calculated. So compliance gani, volume over time gani, volume and flow gani, these are all calculated. These are the measured things. Through the flow sensor, flow is measured. Through the flow sensor, volume is measured. Through the flow sensor, pressure is measured. Got it? So these are the basic information you get. Okay, so indulo depending on the type of the ventilation, ante the mode of ventilation, pressure will change. So like first talk lo volume pressure limited ventilation is what we usually use. Pressure is the limit for us. So limits could be pressure or flow or volume. For us, pressure limit in NICU we use only pressure limit. However, we guarantee the volume because volume limited is used only in pediatrics, not in neonates. Okay, but we guarantee the volume of each breath that we deliver, so that we avoid the volutrauma and decrease the risk of pneumothorax. Okay, so this is a pressure limited ventilation kada. So pressure curve will always be a square shape. That means this is the ippudu manam MAP curve తీసుకుంటే this will be the trigger first ikkada. So మీరు చూసుకుంటే it's always the starting point is always above the baseline చూడండి. That means PWP is always there. And ఇక్కడ మనం ఒకవేళ ఫ్లో చూసుకున్నట్టయితే, see this doesn't have spontaneous breath. This currently the baby is not moving. So negative deflection తో స్టార్ట్ అయిందంటే, because I moved this, ఇక్కడ చూడండి చిన్న నెగిటివ్ డిఫ్లెక్షన్ తో స్టార్ట్ అవుతుంది ఫ్లో. దట్ మీన్స్ ఇట్ ఈస్ ద స్పాంటేనియస్ బ్రెత్ వేర్ ఫ్లో ఇస్ బికమింగ్ ద ట్రిగ్గర్. ఓకే, దిస్ ఈస్ ద పైన పార్ట్ చూస్తే లిమిట్. ఓకే, ఏది లిమిట్? ప్రెషర్ లిమిటెడ్ వెంటిలేషన్. వాల్యూమ్ లిమిటెడ్ వాల్యూమ్, బట్ వీ విల్ బి కన్ఫైనింగ్ our talk to pressure limited ventilation. And what is the other variable here? Cycling. Okay, which one will cycle? Either it could be time or it could be flow cycle ventilation. Ante TI, for example, inspiratory time తీసుకుంటే ఈ పర్టిక్యులర్ 0.3 seconds or 0.4 seconds వరకు ఇన్స్పిరేషన్, later it cycles into expiration for that cycle. Got it? So the phase variables are trigger, limit and cycle. Okay, so square wave pattern లో pressure waveform ఉంటుంది. Flow or volume వచ్చేసేసి flow will be little like a triangle in case of pressure limited ventilation. It will be reverse in case of volume. Like మార్నింగ్ మనం డిస్కస్ చేసుకున్నాం, వాల్యూమ్లో ప్రెషర్ విల్ బీ లైక్ అ ట్రయాంగిల్, వాల్యూమ్ విల్ బీ లైక్ అ స్క్వేర్, బికాస్ వీఆర్ లిమిటింగ్ ద వాల్యూమ్ ఆఫ్ ఈచ్ బ్రెత్ పర్ ఈచ్ సైకిల్.
Pressure limited means your pressure is fixed. So you will have a
square.
If you ventilate on volume control, you will have a square of value and pressure will not be this will not be like this. As madam is saying, it will be like this, and your volume will be like this.
Reverse అవుతుంది shape to remember. But either ways we will be using only pressure limited with a guarantee in the volume, that's all. Okay, so ఇక్కడ చూస్తే coming to pressure is simple. We start with PWP, we go to PIP, stay there till the end of inspiration and cycle off to expiration. Simple, square wave అయిపోయింది. ఇక్కడ ఫ్లో కానీ వాల్యూమ్ ఫస్ట్ ఫ్లోకి వచ్చేస్తే ఏమవుతుంది, ఇట్ స్టార్ట్స్ స్పాంటేనియస్ బ్రెత్ అయితే నెగిటివ్ డిఫ్లెక్షన్, అదర్వైజ్ ద వెంటిలేటర్ విల్ స్టార్ట్ ద బ్రెత్, యూ గో అప్ టు పీక్ ఇన్స్పిరేటరీ ఫ్లో, యూ కమ్ డౌన్. Okay, you once the end of TI, it is supposed to flow is supposed to come to the baseline and culminate with expiration. So if there ikkada chudandi oka small gap kanipistundi, inspiratory hold antam, that means there is the ventilator is still in inspiration but there is no flow of gas. Inspiratory hold or zero flow is what we call. Then the expiration will start. So ante deen ardham entante TI is becoming too long. అంటే baby or the ventilator finished the inspiration but still we are in inspiration, flow ఆగిపోయింది అయినా కూడా TI కంప్లీట్ చేయాలి కాబట్టి we are still in inspiration, flow is zero but still we didn't cycle to expiration. So that zero flow can form a dead part of the ventilation. Understand? So that clear ఇందాక సార్ చెప్పినట్టు TI TE సెట్ చేయడంలో flow and time graph will help you.
Should come directly like this. Should come a negative directly following the positive.
Direct.
If you have a straight line means you have an inspiratory zone. So you need to decrease the high time.
And second is the flow cycle ventilation. So for example, PSV is partly flow cycle ventilation kada. So how does it change in PSV is, so each and every ventilator the flow manam aa limit ni set cheyochu. Like for example 5 to 20% is the usual number where the inspiration cycles off into expiration. Ante flow inspiration nunchi expiration loki vellipovali. So sometimes what happens, 5 or less than 5 వరకు తీసుకెళ్తే ఏమవుతుందంటే ventilator will be still in inspiration and baby will start exhaling. There is asynchronic. సో అక్కడ TIని మనం సెట్ చేయాల్సి వస్తుంది. సో ఫ్లో సైకిల్ వెంటిలేషన్ అవుతే ఏమవుతుందంటే ఇట్ వన్స్ దట్ drops down to 15 or 20%. Like this ventilator usually 15 to 20% is the flow limit. Once the flow drops to that, it invariably changes cycles off into expiration. Okay, flow sensitive is even better because rather than time, flow cycle ventilation will be a better option. What happened to Kumar?
Yes. Apnea time is very important.
हो गया ना, अभी आप हो गया सर आपका now like 0.5 to 3 but just to start with one. Basically how you titrate is based on your this Nava. Suppose once you start in Nava level and then seeing what is the peak. My target is to be maintain between 10 to 15. Suppose it is going above 15, then I have to increase my Nava. If it is going below 5 or below 10, that means I am giving too much of support. I don't need to give that much support. I will come down on Nava.
Which parameter are we titrating now?
No, only one parameter. Peak. Peak is nothing but the want of baby. It should not be so much. It should be between 10 to 15. If you are keeping the baby comfortable.
TE వరకు from inspiration to the point end of inspiration to the end of expiration will be TE. So what happens here, ikkada when you descend down, when the end part of the expiratory curve doesn't reach the baseline, ante it is leaking out before the time ends itself. TE అయిపోయే లోపటే flow is leaking out. అర్థమవుతుందా? సో లీక్ ఒక గ్రాఫ్, ట్రాపింగ్ ఒక గ్రాఫ్. You understand? Of course, in compliance loop, PV and flow volume లో కూడా కనిపిస్తుంది. I'll show you just to keep you informed చెప్తున్నాను ఇప్పుడే. మేజర్ థింగ్స్ దట్ వి సీ అంటే దీని గురించి ఐ విల్ థియరీ చెప్పినా మీకు ఎక్కదు, బట్ బెడ్ సైడ్ వెన్ యూ వాంట్ టు యాక్చువల్లీ చెక్ ఈ బేబీకి ఎయిర్ ట్రాపింగ్ ఉందా, లేకపోతే అంటే నేను ఎక్కువ పీపిస్తున్నానా, ఇన్అడ్వర్టెంట్ పీపిస్తున్నానా నేను, ఆర్ ఈ బేబీకి సర్ఫాక్టెంటే ఉంది, యూ గేవ్ వెరీ హై ప్రెషర్ సార్, సారీ మెకోనియం ఆస్పిరేషనే ఉంది, వెరీ హై ప్రెషర్స్, దెర్ ఇస్ అ హై రిస్క్ ఆఫ్ హ్యావింగ్ నిమోథొరాక్స్. సో లీక్ ఉందా లేదా చూసుకోవటానికి how many x-rays will we get? Suddenly there is a deterioration. You go back and check the graphics. At that point, if you see the graphics, then you will understand ki leak avutunda, trap avutunda, how is the compliance of the lung. Like she said, post surfactant compliance better avutunda leda. You got it? So major ga ee graphs to volumes scalars to this is the major thing. Like, and one of the వెరీ మోస్ట్ ఇంపార్టెంట్ పాయింట్ ఏంటి అని అంటే అసలు వెంటిలేటర్ పనిచేస్తుందా లేదా అని చెప్పే మెయిన్ గ్రాఫ్ ప్రెషర్. సో యాజ్ సూన్ యాజ్ ద వెంటిలేటర్ ఇస్ ఆన్, ఫ్లో అండ్ వాల్యూమ్ విల్ నాట్ టెల్ యూ ఇఫ్ ద వెంటిలేటర్ ఇస్ వర్కింగ్ ఫైన్ ఆర్ నాట్. ప్రెషర్ గ్రాఫ్ కరెక్ట్గా వస్తుందా లేదా, ప్రెషర్ గ్రాఫ్ పడిందంటేనే వెంటిలేటర్ ఇస్ వర్కింగ్. సో ట్రబుల్ షూటింగ్లో యూ విల్ ఆల్వేస్ టాక్ అబౌట్ డోప్, బట్ వెంటిలేటర్ పని చేయకపోతే ఇట్స్ నాట్ సర్క్యూట్, సర్క్యూట్ ఈస్ ఫైన్, వెంటిలేటరే కంప్రెసర్ సరిగ్గా పనిచేయట్లేదు, ప్రెషరే డెలివర్ అవ్వట్లేదు అంటే understood. So you can say this simple thing to the staff also, amma pressure graph etla ostundi. You got it okay. Now moving on to the loops. Okay, so first one is the pressure volume, pressure here on x-axis, volume on the y-axis. So basically this is called the compliance loop, where the amount of change in the volume per change in the pressure is the estimate that we take. So static compliance, dynamic compliance, leave all of that. How is it useful to us anedi chuddam. So there are 2 points here, lower inflection point and upper inflection point. So lower inflection point enta pressure వైపుకి డిఫ్లెక్ట్ అవుతుంది అంటే, if the hysteresis or the slope center point of the 2 points ఎక్కడైతే స్టార్ట్ అవుతుందో అది రైట్కి వెళ్ళిపోతుంది అంటే కంప్లైన్స్ ఇస్ గోయింగ్ డౌన్. ఇఫ్ ఇట్ ఈస్ షిఫ్టింగ్ టు లెఫ్ట్ టువర్డ్స్ ద వాల్యూమ్ కర్వ్, ఇట్ మీన్స్ కంప్లైన్స్ ఇస్ గెటింగ్ బెటర్. దట్స్ వాట్ యూ చెక్ ఆఫ్టర్ గివింగ్ సర్ఫాక్టెంట్. అండర్స్టాండ్? ఓకే. సో దిస్ ఆల్సో యాజ్ యూ సీ, మనము ఇక్కడ జీరోతో స్టార్ట్ అవ్వట్లా, పీడబ్ల్యూపీ పైననే స్టార్ట్ అవుతున్నాం. యూజువలీ లోవర్ ఇన్ఫ్లెక్షన్ పాయింట్ విల్ బీ అరౌండ్ ఆర్ అబౌవ్ పీ. అబౌవ్ అంటే ఇక్కడ నుంచి స్టార్ట్ అవుతున్నాం, కొంచెం పైకి వెళ్ళినాక ఇక్కడ ఉంటుంది. ఎల్ఐపి లోవర్ ఇన్ఫ్లెక్షన్ పాయింట్. లేదు చెప్తాం, చెప్పండి. సో యూ ఫస్ట్ స్టార్ట్ చేసేటప్పుడు క్లాక్ వైజ్ యాంటీ క్లాక్ వైజ్ ఈచ్ వెంటిలేటర్ విల్ హ్యావ్ డిఫరెంట్ ఇదనమాట. సో ఇది ఈ వెంటిలేటర్కి ఎస్ఎల్ఈకి దిస్ ఇస్ ద ఇన్స్పిరేటరీ అండ్ దట్ ఈస్ ద ఎక్స్పిరేటరీ వాల్. ఓకే. సో ఇక్కడ ఫస్ట్ ఒక లోవర్ ఇన్ఫ్లెక్షన్ పాయింట్ అంటే ఇక్కడ ఒకటి, పైన అప్పర్ ఇన్ఫ్లెక్షన్ పాయింట్ అని రెండు ఉంటాయి. సో టిల్ దెన్ ద ఏరియా బిట్వీన్ ద టూ, కింద పార్ట్కి పై పార్ట్కి, ద మిడిల్ పార్ట్ ఈస్ ద బెస్ట్ ఏరియా దట్ వీఆర్ సపోజ్ టు వెంటిలేట్ ద లంగ్. అంటే మ్యాక్సిమం చేంజ్ ఇన్ వాల్యూమ్ అకర్స్ విత్ మినిమం చేంజ్ ఇన్ ప్రెషర్. ద కంప్లైన్స్ కర్వ్, ఫర్ ఎగ్జాంపుల్ ఇది ఇక్కడ ఎల్ఐపి అనుకుంటే, ఇది పిఐపి అనుకుంటే, ఈ పార్ట్ వరకు జస్ట్ ద మిడిల్ ఆర్ 70% ఆఫ్ దట్ పార్ట్, ఆ ఏరియాలోనే ఆ ప్రెషర్లోనే మనకి మ్యాక్సిమం బెనిఫిట్ వస్తుంది.
ఇలా చూడండి, దిస్ ఇస్ ఓపెనింగ్ ప్రెషర్ అని ఉంది కదా, ది ఓపెనింగ్ ప్రెషర్ ఇస్ ఈక్వల్ టు
లోవర్ ఇన్ఫ్లెక్షన్ పాయింట్,
ది పాయింట్ వేర్ ది మ్యాక్సిమం ఆల్వేలై ఆర్ ది ఫోర్స్. సో దట్ ప్రెషర్ యూ హావ్ టు, and the maximum pressure is where when you are increasing the pressure, the volume will increase. At a certain point, if you increase the pressure also, the volume will not increase, but it go like a
beaking వస్తుంది,
flat parallel one. That is what is called as here you are supposed to decrease your pressure. The other point you can see here is closing pressure. This closing pressure means when you are decreasing the pressure, there will be sudden change in the value. That point is called your
closing pressure.
So your opening pressure will be in between your FRC and closing pressure. Once your closing pressure is becoming lesser than your FRC, then it will be. తెలుస్తున్నాయి కదా 3 points. This is very very important.
సో ఈ కంప్లైన్స్ లూప్లో దిస్ ఇస్ వాట్. సో వెంటిలేటర్ అసిస్టెడ్ బ్రెత్ అనుకోండి. సో యూజువల్గా దిస్ ఈజ్ హౌ, అంటే ఇప్పుడు యాక్చువల్లీ బెస్ట్ కంప్లైన్స్ నడుస్తుంది. స్లోప్ ఈజ్ వెరీ గుడ్. If it is a spontaneous breath, it will be towards the leftmost. It will start around the volume. Baby spontaneous breath అనుకోండి. So మీరు SIMV plus pressure support అనుకోండి with ventilator. Some of the breaths could be ఇట్లు తిరుగుతూ ఉంటారు around the volume. So that's a spontaneous breath, clockwise and anti-clockwise. So ఇందులో ఏంటంటే like he said, opening pressure to closing pressure. And second is if we are touching that C20/C, static compliance ante dynamic is the center part where we started opening up the airways and we are causing a major change with small change in pressure. Ante koncham pressure 1 point 2 points tone tidal volume getting delivered is becoming more. That is the best part. Okay, once we go to that place where change in pressure is actually not causing change in volume. అంటే ప్రెషర్ చేంజ్ చేస్తున్నాం 28కి వెళ్తున్నాం 30కి వెళ్తున్నాం స్టిల్ ద టైడల్ వాల్యూమ్ ఈజ్ ఓన్లీ ఎట్ 5.2 ml per kg అనుకోండి. దట్ మీన్స్ రిక్రూట్మెంట్ కరెక్ట్గా లేదు. వీఆర్ సపోజ్ టు కమ్ డౌన్ ఆన్ ద ప్రెషర్స్, ట్రై అదర్ వేస్ ఆఫ్ రిక్రూటింగ్. గివ్ సర్ఫాక్టెంట్, రిమూవ్ ద సెక్రీషన్స్, గివ్ సర్ఫాక్టెంట్, గివ్ మోర్ ఆఫ్ పీప్ or change the mode of ventilation. All of this ఇది చూసుకోవాలి. లేకపోతే if you push on at the beaking effect we may cause a air leak. Okay, second is coming to the yes ikkade
complaint చెప్పండి. You can see lot of things in
PV loop.
Suppose your ET has out, it will tell you. Suppose the complaints you have given your surfactant, how the complaint changes. ఏమవుతుంది, ఇది డ్రాప్ ఏమవుతుంది, అప్పుడు మీకు complaints అంతా చేంజ్ అవుతుంది. Complaints పెరిగింది కదా surfactant.
Towards will we go towards left or will we go towards right? Complaints పెరిగింది post surfactant. Towards
Suppose say this is hystrix, you know na, the space between the inspiratory limb and inspiratory. Suppose that is increased, what is it?
it is expanding. Ante for example towards the
It is coming like this. This denote
resistance, increased resistance. For example, it is towards the pressure, it is the increased inspiratory resistance. If the hystrixis is increasing towards the volume, it is expiratory resistance. Until like for example meconium aspiration undi, increased expiratory resistance undi. So then the volume will be different. Towards volume, this side, towards the left side, expiratory loop will be bulged.
Suppose if it is like this, previously it was like this, we have given surfactant, it became like this.
Compliance towards the left.
What it says?
Indulone
It's like this. Stage, this one
starting stage
starting stage. where
on
surfactant is
RDS
not
without
used.
surfactant.
We have ventilated, we have given the surfactant. So how it change? So it will become like
Flat to left,
that
left side.
that you can change check your complaints. Of course, beeping you saw that.
And you can actually demonstrate leak also here. If expiration, if it is falling short,
See,
leak kuda kanipistadi.
this will not touch.
So it is not going
this
back
one
to the
is not
baseline.
touching the baseline, that indicates it's leak.
Okay, and trapping is better here. Trapping and air leak are actually better here. Flow volume loop lo better ones.
This is what is called as figure 8 shape. Figure of 8. What it denotes? Suppose if you are getting your PV loop like this, what it denotes? Air hunger. That means
Flow
the
starvation.
Flow, yeah, flow starvation. So whatever the flow you have set up there, usually 5 to 10 you will set up. Suppose if it is 5 liters per minute, you need to increase the flow in the ventilator.
So for example, see these modern ventilators you need not set flow, but for a baby log dragger you need to change the flow. CPAP 5 liters,
5 minutes more.
ventilation 8 liters, HFO 50 liters. If whatever that you said, it is not adequate to the, like for a small baby this is still okay. For a large baby HFO ante you may have to increase more. Ventilation 10 liters kuda pettalsi ravochu. So there you will set. Till it is set on its own. This will set, the ventilator itself will set depending on the mode. Okay, so coming back to flow volume loop. So ivi anni kuda manaki ikkada kanipistayi. Compliance you may not see much with the flow volume loop. PV loop is for compliance, dictip. So ikkada first inspiration start.
This is volume, this is pressure in PV loop. Here,
X-axis
this
flow.
is volume, This is flow.
The axis will change.
Axis will
So volume in the y-axis and pressure in the x-axis for PV, starting from which, let us go, time ledani I was rushing. So on the x-axis, it is the volume, reverse also. Y-axis, it will be the flow. Okay. So in this loop, you can see air trapping and air leak. Some other things also.
Don't confuse. Some ventilator will give you this is inspiratory, this is expiratory, or sometimes it may be this is expiratory or this is inspiratory. You need to find.
Basically, clock and anti-clock will be different with each ventilator. Most of them would be inspiration,
Inspiratory upwards and
anti-clockwise expiration, and most of them untadi. Before you decide, ఒకసారి చూసుకోవాలి. So for example, ikkada clockwise వెళ్ళినప్పుడు ఇది inspiration. So peak inspiration కి వెళ్తుంది, flow is coming down to baseline. Again, after TI, it is going into scaling into expiration. So ikkada the expiration end also has to reach the point where inspiration starts. Okay, in case we are running short, we are reaching the baseline before, ante which is the condition there?
You understand what madam is telling?
Expiration loop start అయింది. Okay, instead of reaching to this point where inspiration started, it stopped here only, ముందే ఆగిపోయింది. Yes. So volume is
Lost.
leaking.
There is some leak.
Leak అవుతుంది.
How much volume entered into the inspiration is not coming out in the expiration.
It is
That
leaking
means
somewhere.
The leak is somewhere.
Okay. Second, air trapping. మెకోనియం ప్లగ్ ఎయిర్ ట్రాపింగ్ అవుతుంది. అప్పుడు ఏమవుతుంది? It doesn't go to the baseline. Instead, it will stay here. అంటే ఇంకా ఎయిర్ మిగిలిపోయింది. It is not reaching expiration. It is not reaching the end point of zero in the expiration.
It will come like
And ఇక్కడికి వస్తుంది. It will touch the
not touch
y-axis.
the baseline.
Instead of going to x, it will touch the y-axis. Trap. Air is getting trapped. Okay. Other things. Two more very important conditions you could see. మీరు surfactant ఇచ్చారు. Okay. Surfactant ఇచ్చారు. After like 1.5 hour, suddenly you get a call from NICU saying baby is desaturating. Dope నే ఫాలో అయ్యారు అనుకోండి. ఇప్పుడు డిస్ప్లేస్ చేసి చూసుకుంటే యూ కెన్ సీ యు ఆర్ వెరీ షూర్ డిస్ప్లేస్ అవ్వలేదు, ఈటీ కరెక్ట్గానే ఉంది. దెన్ నెక్స్ట్ ఈజ్ అబ్స్ట్రక్షన్ అంటే సెక్రిషన్స్. ఎలా, హౌ విల్ యూ ఫైండ్ అవుట్ ఇన్ ఫ్లో వాల్యూమ్? ఎస్, సెరేషన్స్, సెరేటెడ్ ప్యాటర్న్ ఉంటుంది. ఓకే,
So sometimes it may be in inspiratory phase or expiratory.
expression, secretions
There are
తెలుస్తుంది.
secretions.
Once you clear it, it will go back to its nice form. And another problem where baby has tracheal rings, the vascular ring gani, tracheomalacia gani, bronchomalacia, any form of obstruction. So how will you have it? It's a scooped pattern anamata. Ante it will see this point is the peak expiration. ఇది ఎలాగైతే చెప్తున్నాను సార్, స్కూప్ ఎలాగైతే ఇది పీక్ ఇన్స్పిరేషనో ఇది ఎక్స్పిరేషన్ అవుతుంది. సో స్కూప్ వస్తుంది. దిస్ PFR విల్ డిక్రీజ్ అండ్ ఇట్ విల్ వెరీ స్లోలీ టచ్ ద బేస్. సో TE ఈజ్ ప్రొలాంగ్. అది మనకి ఫ్లో వాల్యూమ్లో కూడా అక్కడ
When you have secretions, scooping వచ్చింది అంటే you have obstruction in a particular
In the
place.
airway.
Particular place. No? Total airway inspiratory ఉందనుకో.
ఆల్మోస్ట్ ఓవర్, డన్.
Suppose if you have inspiratory
Obstruction.
what happens? Suppose you have upper airway obstruction. You will have an inspiratory obstruction. What happens to the
ఫ్లో వాల్యూమ్లో
flow volume loop? So you have this one, no?
Paina.
Suppose if you have an inspiratory obstruction, this will come nearer to the like
సో
this.
PIFR will come down.
Here you can see. The upper one is narrow.
Coming,
narrow.
the
It
peak
will come into-
inspiratory is not reaching, so it is
gap
coming
gap
down.
is there. Suppose if you have
Expiration.
lower respiratory obstruction, usually there will be expiratory obstruction. Then
So
the
ikkada PFR down అయిపోతుంది.
lower one will come down. Suppose if you have both obstructions, it will change its shape like this.
సో వాల్యూమ్ ఇట్ సెల్ఫ్ ఈజ్ వెరీ లో. సో ఇదే ఈ బ్రాంకో రెస్పాన్స్ టు బ్రాంకో డైలేటర్ కూడా వన్స్ యూ గివ్ నెబులైజేషన్.
Low volume low. It has come like this. What it indicates. Don't read. Don't read. Huh? Your ED has gone. It is not in situ. So you have to reinterpret.
వాల్యూమే కనపడట్లేదు కదా, ఇన్స్పిరేషనే ఎండ్ కాలేదు. అండ్ సెకండ్ థింగ్, ఈ పర్టికులర్ వెంటిలేటర్లో మీరు చూస్తే కనుక, సో మోడ్కే వెళ్ళామనుకోండి, ఫ్లో సెన్సర్ కరెక్ట్గా ఉంటే ఓకే, ఇక్కడ మీకు లీక్ కనిపిస్తుంది. ఫర్ ఎగ్జాంపుల్ ఈటీ ట్యూబ్ ఈజ్ గెటింగ్ డిస్లాజ్డ్ అప్, అంటే T3 T2 టు T3 ఉండాల్సింది T1కి వెళ్ళిపోయింది ఫర్ ఎనీ రీజన్, ట్రాక్షన్ వచ్చిందా ఏమొచ్చిందా, ఇక్కడ లీక్ పెరిగిపోతుంది. అండ్ ఇక్కడ క్లియర్గా చూపిస్తుంది హై పేషెంట్ లీక్. సో ఇఫ్ యూ చెక్ ద గ్రాఫిక్స్, ఫ్లోనే వెళ్ళట్లేదు లోపలికి. ఇన్స్పిరేషన్ ఈజ్ నాట్ ఎండింగ్ ఓన్లీ బికాస్ ఫ్లో ఆఫ్ గ్యాస్ ఓన్లీ ఈజ్ నాట్ హ్యాపెనింగ్ ఇన్ సైడ్. సింపుల్, అర్థమవుతుందా? సో కమింగ్ టు ద ఫ్లో వాల్యూమ్ లూప్, ఓకే, ఫ్లో ఇప్పుడు చూడండి, ఫ్లో వాల్యూమ్లో చూస్తే ఏంటంటే దిస్ వన్ యూ కెన్ చెక్ హియర్ ఆల్సో. ఓకే, ఇక్కడ ఫర్ ఎగ్జాంపుల్ పిఎఫ్, ఐఎమ్ టాకింగ్ అబౌట్ బ్రాంకో కన్స్ట్రిక్షన్ ఫర్ ఎనీ రీజన్, ట్రాకియో ఆర్ బ్రాంకోమలేసియా ఉందనుకోండి, యూ కెన్ సీ ద సేమ్ థింగ్ హియర్ ఆల్సో. అంటే పిఎఫ్ఆర్ రీచ్ అవ్వట్లా, దిస్ వన్ ఈజ్ సపోజ్ టు బీ ఇంకా కొంచెం బిలో వచ్చి ఇట్ విల్ టచ్ ద బేస్ లైన్ ఎట్ ద ఎండ్ ఆఫ్ టీ, అంటే టీ ప్రొలాంగ్ అవ్వదు. ద సేమ్ థింగ్ యూ కెన్ సీ ఇన్ ద ఫ్లో వాల్యూమ్, ఫ్లో వర్సెస్ టైం లో కూడా కనిపిస్తుంది. అంటే ప్రెషర్ అండ్ స్కేలర్ యూ కెన్ మ్యాచ్ బోత్ అండ్ దెన్ డిసైడ్కి ఇది ఏమైనా ఎయిర్వే అబ్స్ట్రక్షన్ ఉందా. ఇఫ్ ఐ ట్రై ఎ నెబులైజేషన్, హౌ ఈస్ ద గ్రాఫిక్స్ పోస్ట్ నెబులైజేషన్, ఈజ్ ఇట్ గెటింగ్ బెటర్ ఆర్ నో?
In connection with the
ఇక్కడ ఉంటుంది C20/Cనే ఉంటుంది యాక్చువల్. ఇదిగోండి 0.9. సో 1.2 to 2.5 is the usual value. కొంచెం తక్కువ.
You can assess the
resistance or low compliance lung, or is it BP lung or post meconium lung, లేకపోతే compliance less lung.
complaints of the lung in its important.
ఇంత థియరీ అడిగితే కష్టం.
It is 80, but we in the ventilators we teach from 4 to 6. You should know the figures. That's all important.
Okay, second is one of the other important factor is ఈ మనము వీటికి వెళ్తే వేవ్ ఫార్మ్స్ స్కేలర్ గ్రాఫిక్స్కి వెళ్తే, if we are trying to synchronize babies and ventilator breath అనుకోండి, now baby is about to be extubated, we are synchronizing between both.
What is this called as? This one. Line has come like this and it is going up now. What is that called?
ఈ కింద లైన్ this much is PWP.
It is like this. Can you make it like this?
అంటే the rise of pressure.
So
It's
there will be a setting where you can change that curve. If you need a sudden rise of pressure, you can put it straight. If you want it to be gradual, you can change it like this.
like how pressure limited and volume limited ventilation, where volume limit ఉన్నప్పుడు sudden increase in pressure will be there, and that is what we were discussing in the talk, that sudden increase in pressure is also can be detrimental to the arteries. In the intracerebral pressure regulation will be an issue. Vasoconstriction అయితే it can cause IVH or it can amount to PVL.
You calculate your eye time. Suppose if you are starting a ventilator, you want to calculate approximate eye time. How will you calculate? There's a like the all postgraduate teaching is like how many weeks point.
Gestational age initially
eye time is
weeks. How many weeks of gestation?
Three time constants. Time constant is the air which goes from
The time required to equilibrate the pressure between the
goes to
both
the
areas.
value. So time constant will deliver 99%. So we take 3 time constants of high time. You can calculate that also.
Time
That is
constant అంటే వీళ్ళకి కొంచెం too much into theory అంటే
how many of you you were using this graphics previously, you were looking at graphics.
Like surfactant, okay, yes, madam చెప్పారు. Do you like మీరున్నారు మీరు బెడ్ సైడ్ డ్యూటీ చేసినప్పుడు సెక్రిషన్స్ ఉన్నాయి ఆర్ బేబీస్ డిటీరియేటింగ్, దెన్ do you go back and check the graphics? Like
both are fellows, both are fellows. So this is particularly for you people. They will come up.
sir, any other doubts you have? Initially we start that, but as the age increases, weeks but
It is
it
not
will
just
change.
stationary. It depends upon
More.
Time constant is equal to compliance into resistance. Compliance resistance will be usually there will not be much change in any way, but your compliance changes. Suppose if you have a RDS in a 28 meter, the compliance will decrease, so the time constant decreases. So you need a lesser height as a baby. Lesser weeks, time constant will come.
సో మనము ఈవెన్ దట్ ఫర్ ఈజ్ ఆఫ్ క్యాల్కులేషన్ అట్లా చెప్పాం కానీ దేర్ ఈస్ అ పాయింట్ వేర్ 0.26 తగ్గించాం. సెకండ్ థింగ్ ఈజ్ ఎన్ఐవి పెట్టినప్పుడు ఇట్ బికమ్స్ 0.35 అండ్ అబవ్ పెట్టాలి ఎన్ఐవి. బేబీ ఫర్ ఎగ్జాంపుల్ యూ ఆర్ వెంటిలేటింగ్ 26 వీకర్, సింపుల్. సో యూ స్టార్ట్ విత్ అట్లీస్ట్ 0.26, సో యూ గో అట్లీస్ట్ 0.28 ఈజ్ బెటర్.
Things will change in NIV. You need to keep at least 15 PIP and almost 0.45 to 5 of
0.35 మినిమం. అంటే చిన్న బేబీ అవుతే వి స్టార్ట్ విత్
Don't
0.35.
compare this
With,
NIV with invasive, because we go up to 7 or 8 P in NIV. You can't go.
Invasive, we usually in India very less people
we
practice
restrict
P for
ourselves
7
for
or 8.
6. Rarely we go for 7.
7 వెళ్తాము, కొన్ని యూనిట్స్లో చేస్తారు 7 కూడా.
I think you have to move. Thank you, sir. If you have any queries, you can ask
not
any
now,
one
you
of
can
us
come back later
at,
also.
what you call lunch time or something. ఏది మొన్న ఒక బేబీని డిశ్చార్జ్ చేశారా? Pulmonary, small babies discharge.
5.
మీరే ఎక్స్ప్లెయిన్ చేస్తారా? ఏం ఎక్స్ప్లెయిన్ చేస్తారా? మామూలు మీరే చెప్తుంటారా? అలా ఏం చెప్తారు. అటు సైడ్ వెళ్ళారా కొద్దిగా? అటు సైడ్ ఉన్నాను సార్. ఇంకొకటి సార్
What did you learn there? Pulmonary graphics. Oh, why is it required? You're setting PIP, PWP, everything. Why is it required? Complaints, it will become a number. Complaints will become. Why do you need to do? So basically, whatever you're delivering, is it really delivered or not? That will be shown by the graphics. Is it interesting? That is interesting. So to make it interesting, you need to have background physiological knowledge about lungs. So now we have more interesting session here. We are discussing about the Nava and high frequency ventilation. So we discuss about this in the. So what is the difference between adult ventilator and neonatal ventilator? Now when you pass out, when you are establishing your hospital, what will you look for in a ventilator when you want to set it to pediatric or a neonatal population? Yeah.
Come friend.
కొంచెం అది ఆఫ్ చేయండి, ట్రాక్టర్ ఆన్ చేయండి సార్, ఆఫ్ చేయండి సార్. She went there only to do that thing. So in adults, what is the tidal volume? Normal tidal volume in adults? 500, 600. So let's suppose we have kept setting of 600 tidal volume. If it is generating 597 or 605, any difference will happen to patient? No much difference. That difference that we are speaking now, 5 ml, 6 ml, itself is a tidal volume here, isn't it? So it has to be very fine. So first difference is, it has to be, like you said, it has to be very fine in detecting those volumes of flows. 1 ml gone here, 1 ml gone here, then whole baby collapses. So how do we do that? Flow sensor. Flow sensor has to be as nearer as to the baby. So first difference is, flow sensor in adult ventilation is near the ventilator. In neonates, it is near the navel. Okay. Second issue that comes is coordination. Baby is breathing out, ventilator is breathing in, and opposite also happening. There is no coordination. If there is discoordination that is happening, asynchronous, then whole concept gets into fail. So we have these flow sensors. What are the flow sensors that we know of? Yeah. Huh? Yeah. The
So this one.
pressure. Yeah.
Hot wire anemometer.
Anemometer, the one which we use, dual orifice. So basically what it does is, flow is detected by the ventilator. So most important part of whole ventilation is the flow sensor. If flow sensor is not there, the ventilator is waste for an unit. It has to be best. So we are trying to identify the best way to prevent that asynchrony. One of the best ways to prevent that asynchrony is Nava. What is Nava? Neurally adjusted.
Ventilatory.
B is
Ventilatory assist.
assist. So now we'll discuss about Nava. Second part will be simpler part, which is high frequency.
So okay, I'll be rushing. Hey sir, I'll be rushing very fast. Okay, you basically have some idea. So whenever a baby wants to breathe, so what happens? There is an impulse coming from the brain. It goes from the respiratory center to the diaphragm through phrenic nerve. Once the electrical activity goes, that electrical impulse goes to, then there is a negative pressure generating air which will draw the air into the lungs. Once this air is being drawn, that is what our conventional, whatever the flow sensor we are having or pressure sensor we are having, it is detecting that flow. Suppose by chance you see, if baby is not able to, diaphragm muscle is weak, or because of some problem in the flow sensor or something, if baby is not able to generate that small flow, then there is definitely asynchrony happening and there is no respiratory effort happening. That is number one. Second point, in these flow sensors, they are very sensitive. Suppose there is a small water droplet or something which can trigger your, it can be misinterpreted as baby having flow and it can generate a breath when actually baby is not needing to breathe in. Okay. So apart from, there are different types of triggers. So which is the best trigger? Is that if you insert a chip into the brain and you see that whenever baby wants to breathe, that impulse is coming and you catch that impulse and that is connected to the ventilator, that is the best trigger. That is not possible. Next best is to get the activity from the diaphragm. We cannot do it invisibly. We cannot put the electrode in the diaphragm. We do it in a non-invasive way. So there is a way to pick the electrical activity of the diaphragm and synchronize it with the ventilator. That if whenever baby wants to breathe, if there is impulse coming to the diaphragm, whenever the diaphragm is contracting itself, ventilator will give. So this is we are achieving the best synchron. That is in Nava. So in the Nava, first thing is what are the things you need? You need is a specialized ventilator which has this Nava module. It is actually patented, is currently present in this Mackie ventilators only. Okay, that is first thing. Second, there is a specialized electrode needed to pick up the electrical activity. So that is achieved through, this is called as, there is a specialized feeding tube for this. There is a specialized feeding tube which has electrodes in here. Okay, there are 9 electrodes here. Once you are putting it, like a OG tube or NG tube, once you put it, when you properly position, I will show you how to position. When you properly position, it starts collecting the electrical activity of the diaphragm. That is number one. So this is important. There are different sizes based on the weight and based on the length you need. Nasal, ear, NEX, nose, earlobe and xiphisternum. You calculate the length and you give it to the machine and you tell which size, based on the weight it will tell you this size and you fix it with that length. Based on your putting OG or NG, the machine will tell you that you do it, first step. Once you put it, second step is to know whether we have properly positioned or not. For that, in the machine, once you start putting this, it will show you a module where there are electrodes, where there are ECG graph showing and the electrical activity of the diaphragm graph showing. It is shown like this. There is a window. Once we start, there is 1, 2, 3, 4 channels showing and this is the electrical activity graph showing. So once you are putting, if you are properly positioning, these are electrodes, there are 9 electrodes here. I will show here also. So the pink color should come in the second and third. That is the proper position. Okay, if it is coming up, that means you are too deep. If it is coming low, you are too out. So you need to position based on that. First of all, no, if you properly position only, everything works. This is the most critical important step for proper position. And suppose there are conditions where you are properly positioned, but there is no electrical activity recording. What could be the cause? So baby is not wanting to breathe. That means like you have severely hypocarbic or CO2 washout happened, or severe paralytic agents or severe sedatives they have given, that baby is not wanting to breathe. Or there is severe HIE where there is severe brain damage. That is one. Or second thing, there is some injury to phrenic nerve. Phrenic nerve injury happened. There is no impulse. Okay, then those times it cannot be there. And there are some conditions where you can't use this. Where when you are not able to put a OG tube, where fistula, esophageal atresia, there are conditions where diaphragmatic hernia, where there is diaphragm is not in a proper position and detecting this is not possible. Those conditions you cannot use. Otherwise, all these conditions you can use. Then this is the best trigger you have. So this can be used for both invasive ventilation as well as non-invasive ventilation. Both you can use. Okay. So that is one thing. So once you have connected this, what you are trying to catch, the electrical activity of the diaphragm. So that is called as EADI, electrical activity of the diaphragm. So once this graph comes, this graph has two parts: EADA peak, EADA minimum. Like EADA, what do you call? Like a peak, we call minimum, like peak and a minimum value. Suppose the lung condition is not good and baby wants to breathe more. Means it has to breathe more, no, to generate more tidal volume and all. Then the EADA activity will become more. Suppose there are some normal values like 5 to 15 is normal. Suppose it is coming 25 or 30, that means lung is bad and baby wants to breathe more, so that is why it is getting more electrical activity. Okay, that is one thing. So if you are getting more electrical activity, the support you have to give is more or less? Support to the baby, you have to give more support. So EADA ఏంటి అంటే ఎంత కష్టపడుతుందంటే అంత EADA ఎక్కువ ఉంటుంది. సో మన బేబీని కామ్ చేసి దాన్ని నార్మల్ లెవెల్కి తీసుకురావాలి అంటే మీరు సపోర్ట్ బయట నుంచి ప్రొవైడ్ చేయాలి. ఆ సపోర్ట్ అంటే ద ట్రాన్స్లేషన్, దెర్ ఇస్ సమ్ ఫ్యాక్టర్ విచ్ హౌ మచ్ సపోర్ట్ యూ హ్యావ్ టు గివ్ టు ద baby, that is called as Nava level. Okay, that is called as Nava level. Your target is, there is some arbitrary, like you start with 0.5, you start with 1 Nava level, and then you slowly titrate so that your EADA peak will start coming to normal. అర్థమైందని చెప్పి, that is for EADA peak. There is something called EADA minimum also. That minimum means in the resting condition what diaphragm is doing, like the tonic contraction of the diaphragm. So why is it needed? Why the diaphragm should contract even in the resting position? To maintain the functional residual capacity. Suppose EADA minimum kuda value undi, it should be less than 5 and suppose it is becoming more than 5 or 6, ante even in resting muscle is trying to contract because it is trying to establish the functional residual capacity. That means your PEEP is less, PEEP support level, PEEP penchant. So EADA minimum, if it is more than 5, you have to increase your PEEP. Suppose if your EADA peak is going to 0, that means diaphragm is not at all working even in the resting condition also. That means you are giving more PEEP, so the diaphragm is not needed to contract. So at that time you reduce your PEEP. So this is what is. And there is one more setting called as apnea time. So this diaphragm contraction we put initially for 2 seconds. And 2 seconds, if there is no impulse, the machine will go to backup. Backup will be our conventional ventilation. Okay, got it? With this basic knowledge, now we will go and we will see that. Okay?
We start the basic ventilation.
So this is the normal ventilation. Okay? So this is normal ventilation, we know. Okay? Pressure, flow, volume. This one leave it. Okay, this is our conventional ventilation. Now I want to go and see, I want to start Nava. So once we inserting electrodes and all.
So first you go to the EDI and Nava. First you have to select that which catheter we have to put. So there is a calculation tools in there. So if the baby is below 55 centimeters, then your weight is that 0.5 to 1.5 kg. That time you have to go for a 6 French 49.
Simple. There are two tubes, 6 French and 8 French. In 8 French there is 50 centimeters, 100 centimeters. For preterm baby general we go for 6 French. For term baby we go general for 8 French. 50 centimeters only we go. So we calculate the nose, next means nose, ear lobule, xiphisternum. You enter the value. Then it will ask which type you are putting. OG you are putting, NG you are putting. You have to put that. Then it will tell, you fix that at this much centimeter, it will tell. So you have to put that level at the level of the mouth. That is the basic. First you put that. Then again you check whether it has to be adjusted. Some adjustments has to be done based on, I showed you, that we will see.
Nasal or oral we can set, and now we put the inches measurement.
So 18
So
centimeter.
it is showing up to 24, you have to insert. Now EDA catheter position will be like this screen, and then you take the catheter and we need to connect to this module. Okay.
This module is actually connected to ventilator. Okay. And this one you
Now while inserting we have to follow this graph. At which location it is?
see, there are electrodes. You see here 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. So you have to, the proper positioning is you should see these pink things in these two. అర్థమైందా నేను చెప్పింది? ఈ రెండింటి పింక్ ఉంటేనే కరెక్ట్ అన్నట్టు. Suppose you see this is above like that, then that pink will come above. That means you have to push inside. Got it? See, that is also mentioned here. You see. Okay, if it is, sorry. If it is coming up, pull up. If it's coming down, push down. Simple. You remember like that.
పింక్ లైన్ అది
మధ్యలో ఉండాలి. 2, 3లో పింక్ ఉండాలి. ఓకే. You can use it that for giving feeding tube, and this one is
దీంట్లో ఇవ్వచ్చు ఫీడ్.
one thing is it can be used as a feeding tube. This is not MRI compatible. Okay. You have to remove when you want to do MRI. Number one. Second is it can be used maximum for 5 to 7 days only. Cost is 18,000. Okay. Cost is 18,000. Okay. So slightly costly.
No, 18,000 only for usage of probe, not the
7
ventilator.
days. 7 days.
So before that I hope your baby will come out from the ventilator. That is the idea.
Software connect చేసి చూపిస్తున్నారు.
Okay. So
వెంటిలేటర్ పెడితే ఇట్ హ్యాస్ టు బి దేర్ ఫర్ నిజంగా ఎలక్ట్రికల్ యాక్టివ్ రాదు కదా.
okay, now we have inserted the catheter, position is right, and now it shows that the pressure graph we will run the Nava. So this is actually patient graph it is coming. What is the patient?
I may बताता हूँ. So basically what he is trying to do is I have put this EADA this thing, but I didn't on the Nava mode in the ventilator. I am just checking whether my electrical activity and patient what the ventilator is giving is matching or not. You see, this is the diaphragmatic activity. That means diaphragm is trying to contract. Our babies want to breathe, but the ventilator is not giving the breath. There is no synchrony. There is no synchrony happening here.
This is how baby will be fighting, struggling.
So there are different scenarios here. Like whenever baby wants to breathe, ventilator is not giving, or whenever baby wants to inhale, ventilator is exhaling, or the trigger is not sufficient. Like it is not giving proper pressure that support the baby. Now we will see once we start an Nava how this graph will change. The ideal thing is with this pressure graph also should match. So here, see here the parameters what we are fixing is Nava level. Generally for non-invasive we put 0.5. For invasive we put 1. We just start with that and we see the EADA and you will see. Suppose your EADA is coming 17, 18, 19, 20, you increase our Nava level. Then once it is coming down and it is going below 5, then you decrease our Nava level. So that is the basic. You start with 1 and then you increase or decrease. This is called as trigger. Trigger is that minimum is there, no? Minimum say it will be generally 0.5 above. The trigger, then only it will act as a trigger. So these are all baselines, and we also have a backup. By chance, suppose this tube came out, or OG tube came out, or baby has went into paralysis or something happened, then it goes into conventional ventilation. That is the backup ventilation. And there is something called apnea time. Generally, when the disease condition is bad, we set it at 2 seconds. Then 2 seconds lo baby electrical activity rale diaphragm nunchi ante it goes off for backup ventilation. Once disease is improving, how we will step down on Nava is, first thing is you will come down on Nava level. సో నావా లెవెల్ తగ్గించుకుంటూ వస్తుంది. దెన్ ఆల్సో ఈఏడిఐ ఎలక్ట్రికల్ యాక్టివిటీ ఆఫ్ పీక్ నార్మల్గానే మెయింటైన్ అవుతుందంటే అంత సపోర్ట్ అవసరం లేదు బేబీకి. దట్ ఈస్ ఫస్ట్ స్టెప్. సెకండ్ స్టెప్ యాప్నియా టైం పెంచుకుంటూ వెళ్తాం, అంటే 5 seconds వచ్చినప్పుడు వెయిట్ చేయాలని. సో దిస్ ఇస్ హౌ వీఆర్ టేపరింగ్. సో నావా కెన్ యూస్ బోత్ ఫర్ ఇన్వేజివ్ అండ్ నాన్ ఇన్వేజివ్, అంటే వెంటిలేటెడ్ నాన్ వెంటిలేటెడ్లో యూస్ చేసి. వెంటిలేటెడ్లో యూస్ చేసినప్పుడు వన్స్ యూ హ్యావ్ సీన్ దట్ ఈఏడి ఎంత బాగా వచ్చింది, లంగ్ కండిషన్ ఇంప్రూవ్ అయిపోయింది అంటే యూ కెన్ జస్ట్ చేంజ్ ఇట్ టు సేమ్ ఇంటూ నాన్ ఇన్వేజివ్ అండ్ యూ కెన్ జస్ట్ సేమ్ థింగ్. ఇదే మనం యూస్ చేసుకుంటాం. ఓకే. So you put Nava now, you see, so this is in with synchrony or not, and baby want to breathe, machine is given, so the good synchrony is there. Then అప్పుడు మీరు చూసుకోవాల్సింది ఏంటంటే ఈ పీక్ అలా స్లోగా తగ్గుతుందా లేదా అనేది మనం చూసుకోవాలి. మన టార్గెట్ ఏంటి టు మేక్ ద కీప్ ద పీక్ లెవెల్ ఇస్ 10 to 15. ఓకే. సపోజ్ ఐ విల్ గివ్ సమ్ scenarios fastly. Suppose your peak is coming 20, then what you will do? Increase the Nava level, finish. If it is coming as 7, 8, decrease the Nava level, finish. If EADA minimum, it should be less than 5. Suppose it is coming 7, 8, what you will do? Minimum మే ఎక్కువ వస్తుందంటే డైఫ్రామ్ రెస్ట్లో కూడా వర్క్ చేయాల్సి వస్తుందంటే ప్రాపర్గా పీప్ ప్రొవైడ్ చేయట్లేదు. సో పీప్ ఇంక్రీజ్ చేస్తాం. సపోజ్ ఇట్ ఈస్ బికెమ్ 0, మినిమం అసలు 0 వచ్చిందంటే అసలు మనం వర్క్ చేయనివ్వట్లేదు, కొంచెం మీరు ఏం చేయాలి అంటే కొంచెం పీప్ తగ్గియండి, కొంచెం రెసిడ్యూల్ చేయాలి. దట్ ఈస్ ఫినిష్. నెక్స్ట్, డోంట్ వరీ అబౌట్ ది టైడల్ వాల్యూమ్. జనరల్గా మనం ఇన్ యూనిట్స్ వీఆర్ వరీడ్ అబౌట్ ద టైడల్ వాల్యూమ్. సో బేసికలీ వాట్ దే ఆర్ క్లైమింగ్ ఈస్ వన్స్ యూ ఆర్ పుట్టింగ్ దిస్ peak, you are adjusting this electrical activity diaphragm, that itself will help that to baby ki enta kavalo anta baby తీసుకోగలుగుతుంది, యూనిఫామ్ టైడల్ వాల్యూమ్ మెయింటైన్ చేయగలుగుతాము. బట్ ఇఫ్ సపోజ్ యూ ఆర్ హ్యావింగ్ మోర్ టైడల్ వాల్యూమ్స్, that means you are giving more Nava level, you can slightly come down on Nava level and see, or you are not achieving the enough tidal volumes, you can slightly increase Nava levels. So main entante our target is EDA, and you are based on Nava level you are titrating it. Okay.
Other one parameter is that
that will detect as breath problems that can there in normal ventilator also. No, it doesn't change. It will change only when there is no effort, no acurrent activity. I detect change the baby hiccup effort. It is like it's a diaphragmatic contraction for this. वो लोग पूछ रहे हैं आज बच्चे को हिकअप आता है, हिकअप मतलब डायफ्रामेटिक कॉन्ट्रैक्शन है ना, वो फास्ट कॉन्ट्रैक्ट हो जाते हैं, तो ये सब फटाफट दे देते हैं ना, उसको कोई सोल्यूशन नहीं करके बोल रहे. मैं बोल रहा हूँ ये नॉर्मल वेंटिलेटर में भी नहीं है, इसमें भी नहीं है. हाँ.
and another parameter is important is the pressure defect. So suddenly if the Nava EDA peak is increasing, the ventilator will deliver the more pressure. For the safety purpose, you have to set the peak. So whatever values you are setting, -5 decrease. Maximum it will be the now the 35.
చెక్ పాయింట్ లాగా, అంటే సమ్టైమ్స్ వీ డోంట్ గో వి పుట్ పీ పీక్, అలాగే ఇందులో కూడా పీ పీక్ సెట్ చేసి పెట్టుకోండి. ఎంత అంటే బేబీకి బాగా బ్రీచ్ చేయాలనిపించినా సరే అంత మించి జనరల్గా ఇవ్వదు.
Similarly the volume targeted mode, the alarm settings is important. No.
That is the disadvantage, because for volume you have to calculate, no? You need flow sensor. You cannot, the disadvantage is this, you cannot have a volume target.
Yeah, this itself is a flow sensor. We don't have additional flow sensor.
Even after extubation also, you can monitor this.
Like other uses are, you put that, sometimes the other uses are like sedation also they are assessing. Suppose how much అంటే ఎఫర్ట్స్ వస్తున్నాయా లేదా ఆఫ్టర్ పోస్ట్ సెడేషన్ అది చూసుకోవడానికి యూస్ చేస్తున్నారు. దెన్ జస్ట్ ఫర్ మానిటరింగ్ డైఫ్రామ్ కాంట్రాక్ట్ అవుతుందా లేదా, అంటే ప్రాపర్గా ఉందా లేదా, అంటే డిసీజ్ ప్రాసెస్ ఇఫ్ ఇట్ ఈస్ ఇంప్రూవింగ్ నార్మల్గా ఏఏడిఏపీకి విల్ కమ్ డౌన్, లేదు డిసీజ్ ప్రాసెస్ వర్సనింగ్ ఏఏడిఏపీకి పెరుగుతూ ఉంటుంది. అంటే ఈవెన్ ఆన్ ఆఫ్టర్ యూ ఎక్స్టుబేట్ నాన్ ఇన్వేజివ్ కూడా తీసేసిన తర్వాత కూడా యూ కెన్ కంటిన్యూ మానిటరింగ్ విత్ దిస్ అని చెప్పి.
Okay, we'll shift to
sir.
You call her.
మ్యామ్ ఇది ఓన్లీ మ్యాకెట్కి మాత్రమే ఇది ఉంది, ఇంక వేరే వాళ్ళకి లేదు, అది వాళ్ళు పేటెంటెడ్ టెక్నాలజీ.
Calibrate. So now we are shifting to simpler part, which is high frequency ventilation. So what are the indications of high frequency ventilation? When do we give this? high oxygenation index of how much? 15, some books say 20, some books say 25, some books say we have to give nitric oxide at 25 or conventional. One is OI, second one is conventional ventilation is failing. When else do we give? Same thing. What else? When else we give? No. This is indication in terms of that is disease. We'll discuss about disease. When else you do? AADO2, PO2, FiO2 ratio. There are certain numbers. So with respect to what you said, there are disease conditions where we prefer. One is CDH, PPHN to give nitric oxide. Where else you give?
Air leaks.
Pulmonary hyperplasia. Once there is interstitial emphysema or air leak which has already happened, then we give. So as a whole, we have been trained in such a way that we have to use this high frequency mode of ventilation when the routine ventilation is failing as a rescue mode. That's why we all keep on saying these numbers and all. But this is lung protective mechanism. If there is air leak, pneumothorax, then we are putting the baby because it is protective, isn't it? So why shouldn't we give upfront? Yes, we can give upfront as an elective mode of ventilation. So baby comes, 25 weeker, 23 weeker, 400 grammer, 500 grammer, you give surfactant, directly put the baby on high frequency ventilation. And then as the baby improves, we can extubate directly. That can be done. So now, with respect to the parameters of high frequency ventilation, one is MAP, frequency, amplitude, MAP, and delta P, IE ratio. So IE ratio, don't worry much about it. So very little changes with IE ratio. So first, with respect to MAP, if you want to change oxygenation, two variables are MAP and FiO2. If you want to fiddle with CO2, delta P. Yeah. Come. So we are discussing about high frequency ventilation. Come here. You can come here also. We are discussing about high frequency ventilation. So indications of high frequency ventilation is, or else you can come here. Come. They've come all the way from Secunderabad duties. So the parameters that we use in MAP in high frequency are MAP, amplitude, frequency, then IE ratio and delta P. So if you want to change oxygenation, MAP and FiO2. If you want to change PCO2, we have delta P and frequency. So first thing what we do, if baby, in the scenarios that you have told, baby was on conventional mode of ventilation, not maintaining well, you shift the baby to HF. In that scenario, what do we do? How do we set MAP? MAP plus 2 we have to add. If the child baby is on some MAP, add plus 2 and set that. So this is how you set. Okay. Usually beyond 8, 9, 10, baby comes to high frequency. Okay, 14 minutes.
Oh, sir.
Then what do you set? Delta P. Delta P normally, how do we set? Yeah, double the MAP. So if it is 14, nearly about 30 we set. But clinical indicator is wiggling has to be seen. They say up to abdomen. They say even till yeah. So this is about the delta P. Now it is 14. So I'll keep it as 28. Okay. Then frequency. How much do we keep?
5 minutes more.
Frequency. Yeah. Normally it is 8 to 15. It is. But two numbers you remember. 8 and 10. 10 is for smaller babies, 8 is for bigger babies. That thing we keep here. Okay. Then what is FiO2? Based on whatever FiO2 that baby was having. There is a concept of recruitment de-recruitment and re-recruitment. Means you are inflating lungs, deflating and re-inflating. When you do this, amount of pressure that you require is less in the second recruitment. Recruitment, de-recruitment and re-recruitment, when we are doing this, amount of pressure that you require is less. That's why MAP you are keeping on higher side initially, decrease it, again increase, so at lesser pressures will be required. So this is what we set. How do we taper? Well, once the baby is fine, how do we come down? Most dangerous thing, we have to get rid of it. What is the most dangerous part here? MAP, heavy, causes damage to lungs. If baby is improving, decrease MAP first. Then delta B, yeah, MAP by 111. Delta P by 555 we decrease. And the last thing to be is FI out. Okay. Usually if it comes down less than 8, then we can get the baby out of. Okay. So now to volume targeted high frequency ventilation. Volume guarantee high frequency, which we discussed in the morning. Again, that is simple. So this is volume target. Just like in conventional mode of ventilation, we are keeping one set volume, and based on the clinical condition, pressures keep on varying based on the lungs condition to achieve this volume. If the lungs are bad, more pressures are given. If the lungs are good, less pressures are given, but this is maintained. Likewise here, amplitude across that map is the tidal volume, is offering the tidal volume. So what we are doing, long press here, off chain. So this is now off. Now when we do long press, it gets on. Now everything revolves around this. So we know that high frequency ventilation is a dead space ventilation. So normally it is 4 to 6. 6 is the tidal volume. For dead space is 1/3 of it. We keep it at around 2. Okay. So after that, what do we have to set? What will happen in this scenario? Tidal volume is set. Amplitude keeps on changing. It may be more or less. So after that, what do we have to do? Map. So tidal volume is set. So first map. Before here, now I am doing. Forget about that thing. Here, first map. Here also, as it is there. You're setting it at 14, 15, for example. Okay. Then you will be setting the tidal volume. Delta P, this is max. This is not delta P. This is P max. P max usually we keep it around 60s. Okay. So which means you have to achieve this tidal volume of 2, increase your pressures, but don't go beyond 60 is what you're telling. Okay. That's all. This is about so simple. You're doing only 3 things: setting map, tidal volume, and making sure that amplitude is not crossing that amplitude max. Okay. Now, maybe you do a blood gas, and once the blood gas is done, within half an hour, if it is normal, just leave it. If the baby's clinical condition improves, the amplitude keeps on coming down by itself. It will come down to 30s. That means lungs are fine, improved. What you have to do, you should only decrease the map. Only maps you have to decrease. This one will come down. So once you come down to 8, baby is fit for extubation. Okay. So it will auto wean by itself. We don't have to every time keep on changing frequencies and amplitude, and nothing has to be done. It will auto wean. And PCO2 levels also will be within normal limits. Frequencies, it will adjust by itself. Frequency, amplitude it is adjusting. Eventually tidal volume is getting adjusted. So map you're setting, tidal volume you're setting, amplitude max, that's all. It will auto wean by itself. So very safe, and we can use as elective mode of ventilation. Baby comes 600 grammer baby. We have even done for baby with non-invasive volume guarantee high frequency mode of ventilation. Also we have done. It is doable. So they do really well. We don't have to do any blood gas. There is one number which you have to see, this DCO2 which I was discussing. DCO2 is, it is tidal volume square into the frequency. So it has to be kept between 40 to 60. If it is on higher side, that means we are hypoventilating. If it is on lower side, we are hyperventilating. If it is kept between 40 to 60, we don't have to do even blood gas. If it is on higher side, try to increase the frequency. Frequency will adjust. So this is the only point that we have to monitor. Okay. So I think that is about it. Anything you want to ask? Any questions you want to ask?
Just like a constant, that
2 is constant. Very simple. You are setting this and sitting back. That's all. You don't have to do no blood gas. Nothing is required. And baby will improve by itself. Baby will improve, and baby will say, you are trying to come down on this. You come down to 30, then baby is improved. Maps, come down and remove. But in the conventional mode of conventional high frequency, routine high frequency, keep on changing all the things. Okay. Anything else? So quickly, our people have come. Quickly, we'll go to Nava again. Please come. So in 3 minutes, Nava again for new people. 2.5 minutes. No, these people are there.
So basically, Nava is neurally assisted ventilatory assist. Okay. So you have various type of triggers in ventilation. What is the triggers? What are the flow trigger, pressure trigger, something like that? Flow trigger, you have different types like flow sensor, like hot.
So I'll tell them. New people just entered into. Just entered into very fresh, newly born people. So when we are giving ventilation, routine ventilation, so baby is breathing, you are also ventilating. There is no coordination. There's no coordination. Baby is exhaling, ventilator is breathing in. Ulta also happens. So we are actually failing on ventilation. So to get rid of that coordination, discoordination or asynchrony, this thing is there. He's Group Prasad sir. He's from KIMS Cuddles Vizag. So what we do is we take this, put into the orogastric tube in the esophagus, and this has some electrode sensors. It will give its input to this system. This is attached to the ventilator. So whenever diaphragm is contracting, only then it gives breath. Whenever diaphragm is wanting to contract, only then maximum synchrony we will be able to achieve. So this is the background. Now you see.
Normally what happens is whenever a baby wants to breathe, impulse has to go from respiratory center to the perimeter to the diaphragm. Once the diaphragm contracts, diaphragm gets pulled over, then negative pressure is there, then the air comes. This air is detected by the flow sensor, which will support. That means there is so much of delay, like whenever baby wants to breathe, sometimes the flow sensor may not give, or sometimes patient falls, just like some water drop in the flow sensor, unnecessarily the ventilator cannot do. So the best trigger is like whenever baby wants to give the breath. That happens directly to put the chip in the brain, but that is not. So or else you can directly put some electrode over the diaphragm, that is also not possible. So what we do is through the mouth, you put the electrode there, you will directly catch the electric directly, and whenever
only in 6,000. Only in 6,000. 5,000, 4,000 rather. Only in 6,000 it comes. So Dantlo, they have one software which they will not open. We have to pay additional 2 lakh rupees. Then they'll unlock that software. Volume target. How much money you take to unlock your volume target mode of ventilation?
Volume is standard, sir.
No. High frequency volume target ventilation.
It is standardly doing.
Standardly in SLE 6,000 and 5,000. The difference is high frequency.
Yes, sir.
Volume targeting comes in this,
Yes,
in this,
one.
and not in that.
Not in that. And we recently stopped that. So no need of that. So now whatever SLE you are buying in that volume target will be there in HL.
And additionally, she also said, he was saying, there is something called as oxygenia. You were saying oxygenia. So what it does is, again, same software and all changing. You have to pay 2.5. So saturation, if it is falling, it will increase FiO2 automatically.
Anyone stand here and adjusting the FiO2, it will automatically set.
Done. Over.
hello. మేడం కూడా ఇస్తాను.
నేనేం చెప్పట్లేదు.
లేదు ఆడియో రావాలి.
కాదు మ్యామ్, యూట్యూబ్ లైవ్ పెట్టిన సెషన్ మ్యామ్. నేను చెప్పాను, నేను అపర్ణ మేడం
అపర్ణ మేడం కూడా ఇస్తాను.
నాకు ఎందుకు ఇచ్చారు ఇది? ఏం మాట్లాడట్లేదండి. దిస్ ఈజ్ మాన్యువల్ పంప్. అందుకే కదా సార్, లెస్ దెన్ 2 kgs కాంట్రాఇండికేటెడ్, లెస్ దెన్ 34 weeks ఇస్ కాంట్రాఇండికేటెడ్, రిలేటివ్ కాంట్రాఇండికేషన్స్. మేము ఫస్ట్ పిల్లలకి నో మ్యామ్.
Okay. So hello everyone, this is station on ECMO. I am Dr. Aparna, and my co-faculty in this station are Dr. Sindhu, Dr. Sahiti and Dr. Sonali. They are all neonatologists at various branches of KIMS. So how many of you have seen or actually worked on a baby who has been on ECMO? No? So it's something relatively new for most of you. I request you all to come a little bit more closer, but maybe leave the camera's view on. Okay, so you know that ECMO is extracorporeal membrane oxygenation. So which means extracorporeal means kya? Outside the body, and membrane oxygenation means it is a technique where you kind of artificially oxygenate carbon dioxide from the blood and then pump it back to the body. So since this has to be done outside, it needs a system where you can pressurize or pump blood, create some positive pressure and make it flow across the circuit. Now extracorporeal membrane oxygenation is of course ECMO. You have other extracorporeal therapies also where you may only, the purpose of the therapy to remove carbon dioxide, right? So that is called ECOR, extracorporeal removal. Cardiopulmonary bypass is also pulmonary extracorporeal, but the difference is it is done for a very only while the child is on a open heart surgery. Whereas ECMO is something that actually but for a sustained period. Also ECMO is a temporary, somebody cannot be on ECMO permanent. So ECMO is usually a temporary solution for a baby with a reversible cardiopulmonary issue or a lung issue, that is like or a reversible cardiac problem like myocarditis, drug poisoning in adults, beta blocker poisoning, calcium channel blocker poisoning, OPC poisoning. Or it is to a more permanent therapy like an organ transplant. Okay, but we only need to be sure that we are dealing with a pathology that is reversible. So that brings us to the first part, which is indications of ECMO. So in newborns, where all do we use ECMO? You need to be a little loud.
Severe PPHN, severe mass.
Okay. So a baby with a severe lung problem, she said meconium aspiration syndrome. You could have a baby with severe RDS, pneumonia, PPHN, where you are unable to oxygenate the baby even at high FiO2. So FiO2 100%, or you have tried inhaled nitric oxide, you are still unable to oxygenate, or you are unable to achieve adequate carbon dioxide levels. Right? So this is measured by various indices like oxygenation index, OI. What is OI? MAP into FiO2 divided by the postductal PaO2. Say MAP FiO2 is what you give to achieve oxygenation, and what you get back is PaO2. So that is oxygenation index. So you have various cutoffs based on OI, based on ADO2. There are numbers, books will give you those numbers. So I will not get into those details. HFO mein kitna OI, HFO plus nitric oxide or cardiac instability mein kitna OI, 40, 60, yes, you will get from the books. So this is one indication. Another broad indication is a baby with severe hemodynamic instability, like a cardiac cause, shock, where you have tried multiple inotropes, where you are on very high inotropic support, let's say maximum doses of 3 inotropes, and you are still not able to achieve the adequate cardiac output, as measured by blood pressure, as measured by urine output, as measured by elevated lactate, all these parameters. So broadly these are indications, and as you said, severe PPHN, and PPHN you can find in a variety of conditions, some parenchymal problems, some lung congenital anomalies like diaphragmatic hernia, severe pulmonary hypoplasia, alveocapillary dysplasia, but again remember to choose a reversible pathology. So CDH, you can operate and salvage the baby, then you can offer ECMO. But if you have a patient where you know that the lung growth is severely impaired and the baby may not survive without a more permanent solution like lung transplant, which may not be feasible and in that particular age group, then think about offering ECMO in babies like this. Also some contrast in babies who have severe neuroconium aspiration with HIE3, then you should think about offering ECMO. Or in a baby who had birth asphyxia, severe intracranial bleed, again think before offering ECMO with baby high risk of irreversible neurological disability. So this is about indications. Do you know that the first ECMO in the world was performed in a newborn? So it was. So the very first ECMO was performed in a newborn, I think it was in 1980s. But as of today, the number of new ECMOs has come down dramatically because of the improvement in all the respiratory therapies, surfactant area. We have optimized ventilatory modes, and hence the proportion of babies going on for ECMO in neonatal population has come down, although overall ECMO runs has increased across the world. So now we'll come to the parts of circuit. So ECMO circuit ka parts. So we start with the drainage cannula, right? So drainage cannula brings blood from the patient, and then you have to kind of pump it or pressurize it. So you come to the pump. There are multiple types of pumps. So pump, the operating pump is to pump blood in the circuit against this resistance, and it has to go against the afterload of the patient and reach the patient's blood. So this pump is a centrifugal pump. It works on the principle of creating a controlled vortex is what is. So it works on the centrifugal Bernoulli's principle. To be dependent on the preload, that is the patient's volume status, and based resistance, which is the afterload, right? So there are other types of pumps which are positive displacement pumps, where it's occlusive pump, where blood is physically kind of pushed or displaced. These are not dependent on the afterload, but then technically if there is any obstruction in the return cannula, this can even lead to perforation and leak, right? So this is the pump. Then pump, you have blood flowing into the oxygenator. So from here it goes to the oxygenator. So this is pre-oxygenator, post-oxygenator. This oxygenates the blood and removes carbon dioxide. This is membrane lung or the artificial lung. And then the blood, hence oxygenated and emanated, is pushed back to the baby by the return cannula. So return cannula is red in color and the drainage cannula is blue in color. Two types of ECMO you must have heard, VA and VV. So when you drain blood from a venous channel and pump to a vein, it's called VV ECMO. So when you do VV, it goes back to a vein and it still has to pass through the baby's native heart. So we are bypassing the lung, but we aren't bypassing the heart. So VV ECMO is going to be useful in a patient with bad lungs, ARDS, severe pneumonia, viral pneumonias, COVID, influenza, viral, bacterial, ARDS, VV ECMO is useful. So from vein back to vein. Instead, if your drainage line is from vein and your return line is an artery, it's called VA ECMO. So in VA ECMO, you are pumping oxygenated artery as well as lungs. So ECMO is something like parallel circulation. VV is something like series. So blood will first flow through the ECMO, it bypasses the lung, but it still goes to the heart and it's pumped by the native heart. So a patient with severe pneumonia, ARDS, but relatively preserved cardiac function, you may go for VV ECMO. In a baby with a cardiac instability, myocarditis, post-cardiac surgery, or if a baby with pneumonia also has hemodynamic involvement, also has severe shock, myocardial depression, then it's better to go for VA ECMO. In general, in newborns, VA ECMO is the preferred modality. Now, where do we cannulate? Which vessels are preferred? Less than 10 kilos, usually neck veins, IJV and common carotid, and cannulation generally is done in the, by the cardiothoracic surgeon in the OT under direct vision. One can also opt for Seldinger or semi-Seldinger technique, which can be blind or ultrasound guided, but more difficult in infants. For children weight more than 10 kilo, usually femoral and carotid axis is preserved. So if you are choosing femoral venous drainage line, the return line may be a carotid artery. Sometimes femoral is also done. So femoral vein and femoral artery. So VV versus VA, the difference is VV purely for lung condition, circulation is series, and VA ECMO bypasses both heart and lung. So it's like parallel circulation, and that is preferred when the child has both heart and lung failure or primarily a cardiac or a hemodynamic issue. Now settings in ECMO, this is the console. So primarily we have this RPM, can you come closer, which you can increase with this knob. Let them come, it's okay, you record what you can record, let them come. So RPM is this knob, it can be increased. So this is the rotations per minute for the pump. You can't directly change the flow, which will be displayed here in liters per minute. When you increase RPM, usually the flow should increase, although the flows are still going to be dependent on preload and the afterload of the patient, right? And then we have the blender here. The blender is the source of the sweep gas flow that will be coming to the oxygenator. So your oxygenator has a total of 3 entry, 3 exit, 1 for entry of blood, 1 for exit of blood. Then you have entry of warm water, this is for the heat exchanger, and exit of water. Third one will be entry of sweep gas from the blender for oxygenation and CO2 removal, and then the exit for the sweep gas. So you have 6 ports finally, 3 in and 3 out. Now also we measure some pressures while we are in ECMO. The first pressure which is called as P1 pressure is the pre-pump pressure. Pre-pump pressure is usually negative because this is pre-pump and the pump is actively trying to suck in the fluid and pass it to the rest of the circuit. This is going to be a negative pressure. Now conditions where it can become more negative, the P1 pressure can become more negative are hypovolemia or a block in the drainage catheter, the drainage catheter being displaced. So supposing it became too superficial or moved out of the vein, right? It came into a branch vein or a smaller vein, right? So you placed it in the IVC, but now it got gradually displaced, came to the ductus venosus. So then it might not be able to suck adequate volume of blood, and it starts showing more negative P1 pressure and the ECMO flows may come down. So this can lead to something called as shattering. The next pressure we measure is the pre-oxygenated. P2 is pre-oxygenator and P3 is post-oxygenated pressure. Rather than the absolute numbers, the difference between these two pressures, that is P2 minus P3, transmembrane pressure gradient, TMP, this is going to be more important. Usually the P2 pressure is soon after the pump is the highest pressure, most positive pressure. Then it passes through oxygenator, then comes P3, which is also positive. But if you see that the gradient between P2 to P3 is increasing, then what does it mean? Some problem in the oxygenator. There could be some clot or resistance, obstruction in the oxygenator. On the other hand, if P2, P3 are both increasing, P3 is also increasing and the flows are coming down, then it could mean some problem in the afterload. So either there could be obstruction in the return line or the baby's systemic vascular resistance increased. All these could be potential problems. So now while on ECMO, for improving the patient's oxygenation, we primarily can increase the FiO2 here on the blender, and we can increase the ECMO if the child is on VV ECMO. If the child is on VA ECMO, primarily you are going to monitor the hemodynamic parameters like mean arterial pressure, blood pressure, the mixed venous saturation, lactates. So if you have to optimize these parameters, again you will have to increase the flow. If we have to wash out more carbon dioxide, we actually work on the sweep gas flow. So if you increase sweep gas flow, the better will be the CO2 removal. Okay. So to improve saturation, you increase the flow of ECMO as well as the FiO2 on the blender, and to increase blood pressure and hemodynamics on VA ECMO, again we increase the flow. To wash out more carbon dioxide, we increase the sweep gas flow. Right?
How can this flow just rate itself?
Yeah, we can increase the flow, but if everything is fine, the flow also should increase. How much flow is optimal? In VA ECMO it's 80 to 100 ml per kg per minute, and VV it is usually 100 to 120. So for a 3 kilo newborn, imagine the regular flow that you want is 0.3 liters per minute or 300 ml per minute. Now Dr. Kalyan will be showing us a live ECMO. These are all some cannulae for you to just see. So these are, you have a mix of arterial and venous cannulae. These are pediatric cannulae here. This is a neonatal arterial cannula. This is 8 French cannula. This is the smallest one that is available. So usually 8 French, 10 French are the ones used in babies. Usually we prefer to have the drainage line French bigger than the return line, right? There is also a dual kind of cannula that is available, but although it is technically also more challenging, and the smallest size is 13 French. That is also not available in India. Okay. With VV ECMO, one of the common troubleshoot or problem that we have is if the cannula migrate too close to each other, we can have recirculation, wherein the oxygenated blood can be sucked back into the drainage line, and you can have ineffective saturations or ineffective oxygenation. The baby starts deteriorating, but you start seeing bright oxygenated blood in both the cannulae. This is one of the common problems in VV. It doesn't happen with VA because they are two different vessels. Whereas in VA, one of the common problems is LV stunning, because we increase the afterload of the native heart, and the ECMO flow is coming directly into, say, branch of the descending aorta or aortic arch. That increases the resistance to the heart. So children who are having decreased native heart function can develop further decrease in the LV function, and they can go for LV stunning. So with that brief overview, I think I'll hand over to I request you all to turn facing the camera, the screen. We have Dr. Kalyan, our pediatric intensivist, who will be showing you a live ECMO of a child in their PICU. Over to you, Kalyan.
So we have a patient who's 10-year-old presented with myocarditis and been onto VA ECMO. So for all practical purposes, with the current availability of the cannula sizes with us, most of the neonatal ECMOs or most of the ECMOs for less than 8 kilos would be going on to VA ECMO. It is because like the available cannula, if you put in two smaller cannula,
Welcome. Veena, hi. I never met you.
What we are discussing, we never met and మాట్లాడుకుంటున్నాం.
నేను కూడా అదే చెప్పా.
అవునా?
మీ గురించి బాగా తెలుసు కానీ మిమ్మల్ని చూడలేదని చెప్పా.
If you want ECMO station, they are doing a live demonstration from a pediatric, a live ECMO case. చూపిస్తున్నారు.
is inserted using the usual Seldinger technique, and here the venous blood going into the pump. This is called a cone, which works on an electromagnetic levitation. So the underlying magnet moves with the electromagnetic thing. The pump also moves. So this is the centrifugal mechanism. So now the blood goes to the oxygenator. This is the pre-oxygenator surface. So and it gets oxygenated, and that's the post-oxygenator area, and this is the blood that gets oxygenated. If you see that there is a good color change between the things, so venous became oxygenated, and now it is going back to the neck, where ultimately the cannula is in the arch of aorta. Okay, so that's basically the circuit. Here the blood flows in around the fibrils, and the gas exchange happens. So here, if you see this green line is the sweep gas line, or the oxygen tubing. So this is called a blender, where you are setting the FiO2 here. Here we have put in an FiO2 of around 80%, because we are on weaning flows, and this is the sweep gas. So sweep gas, this is in mils, this is in liters. Currently we are on around 2.5 liters of sweep gas, and that's the console. On the console, we change the RPMs, and liters per minute they change. So how it's going to change depends on, it is preload dependent and afterload sensitive. If your afterload is high, your LPMs will come down. If your preload is too low, you see chattering, and your flows also comes down. And whenever you are on ECMO, that means you are supporting both. On VA ECMO, you are supporting both heart and lung. On VV ECMO, you are supporting the lung. So the main ideology is to minimize this ventilator-induced lung injury. So there is something. This child is on currently weaning around 50 kilos. We are giving only 50 per kilo of the flows. So we are actually ventilating, and we are planning to come off tomorrow. So there is other settings on the rest. Pressures to be less than 25. PEEPs selection between 6 to 10 based on the disease. Rates of around 10 to 15, and the upper pressure, the delta pressures around 10. So one rough way to remember is 10, 10, 10. 10 of rates, 10 of PEEP, and 10 of delta P. This is for ARDS. For cardiac, it changes based on how bad the lungs are. And FiO2 for lung, for VV ECMO we keep on 21%, for VA ECMO around 30 to 40%. So that's the patient monitor. So here you are seeing a decent amount of VTCO2 trace, because there is some amount of native cardiac output. You are seeing a decent pulse pressure. That also says that native heart started pumping some. And this is the monitor where you measure the P1 and P2. So here we are measuring on P2 and P3. Here we are measuring only P2 at this point. So there are three areas of pressures. So one pressure line is P1 pressure, which is a negative pressure. Second is a P2, that is pre-oxygenator pressure, usually highest. And P3 is a post-oxygenator pressure. These pressures will actually let us know why the flows are coming down, what exactly is happening, why the oxygenator is not working well. If there is a huge difference between P2 and P3, that says that your oxygenator is at problem. If your arterial line is at problem, or line, like the return line is kinked or anything, all the pressures will go up. P2, P3 also goes up. So between the stays the same. Even ischemic or pneumothorax or pericardial effusion, cardiac tamponade, those things. This is roughly the thing. Here, one addition to this circuit is we have added a bridge on. So this is the venous line, and this is the arterial line, and between the two there is a connected, which is called a bridge. So bridge is one thing which we usually, as a practice, we start putting bridge right when we are cannulating, but bridge is basically for a weaning. So what we do is like when the patient is ready for clamp off, we'll clamp off the venous, We'll clamp off the artery and we'll let the flow going through the bridge. Now the bridge is clamped. We open the bridge. So whatever blood that runs in the circuit goes through the bridge and goes back. And patient is not getting any ECMO support. So like that we do the trial of between 1 to 6 hours, and the child is stable, the heart is tolerating. That is a point where we think of peak cannulation. Okay. So any questions I'm happy to take. KIMS Cuddles is a part. KIMS Cuddles is a part of recognized GSY ECMO Society of India fellowship course. So which is a hybrid course. I would encourage you guys to actually give the exam and get into this fellowship, and hopefully you'll also pass the exit exam with whatever the ECMO cases that we are doing. Thank you. Any questions?
Thank you, sir. This session, there are no more questions. You just get back to you for the next session. Thank you, sir.
Signal of madam.
Pulmonary end without the color. So that is how we measure. Okay. So then that is the thing. And then for looking at the arch. And only measuring the PD is not enough. We should put the Doppler also and measure. Actually, I just show the view. Arch view is like this. So right side of the right second intercostal space. So we have to see the arch. Here you can see an appreciation. Not very clear. So you can see the flow around that. For coarctation and all, we will see that. We will see the flow, color flow, and see if there is any restriction over there. This part. Normally the arch will come, and three branches will come from the arch from here. So here it is. And the baby is. This is the arch. This is the arch here. So normally for shortage of time I can't tell. This is the right pulmonary artery. This is the arch. From that three branches will be. So if you are able to see the proper arch and the proper flow around from the arch, then you can easily rule out the coarctation. So these are the views, and subcostal view, one last one you should know, is the basic. So which we do in the last. So we will just put the probe. There are two variations in this also. So here if you are putting the probe on the just below the xiphoid sternum. Here. Okay. So here we put it. Just below xiphoid sternum. So we can see the IVC, inferior vena cava, which is coming and opening into the, where it will open? Right atrium it will open. Here you can see the volume status of the IVC, and you can know what is the preload, whether the baby will be responding to the fluid bolus or not. Okay, so we have to measure. There are so many measurements over there. IVC collapsibility, distensibility, and all that. So that you can read up. And if you just tilt the probe towards the left side, you can see the aorta, longitudinal leg. So we are probe marker is towards the head of the baby. You can see the longitudinal view of the aorta. So the first branch which arises from the aorta is cilia,
normal in the diastolic flow. Okay, so that one we can see here, and also we can check for the UAC position, UVC position. So all these things. Normally UAC position should be 5 centimeters from this cilia. So that is the ideal position by location of the umbilical UAC catheter position from the hip. Okay, so that is about the view. And also one more in the subcostal view, if we rotate the probe and keep it towards the 3 o'clock position of the baby, we can know the situs solitus is correct or not. Okay, so here you can see like it's not very clear, but you can appreciate the echogenic texture of the liver. You can see the movement of the diaphragm, and vertebrae, the round structure which is just above the vertebra is the descending aorta, and the one which is to the right is the inferior vena cava, which is the collapsing structure. So that means the solitus is correct. Sometimes in SMA and all, here the SMA will be seen, and also if there is any reversal of the flow, that also we can see. Solitus is like liver is towards the right side and gastric shadow is towards the left side. This is the thing. And from here also there are many other views, but time shortage is there. Like we can see the inter and so many other things are there. So see here. So if you are just angling the probe towards the head of the baby, you will see 2 chambers. Now this is good to see the atria and to see the interatrial septum. So that 4-chamber view is not good to comment on interatrial septum, because the interatrial septum will look like it's cut off from there. It will not look, it's like proper. So here you cannot cut off. It's little bit cut off here. So subcostal view, so it's ASD. So you should not comment ASD on the based on the 4 chambers. So these are the things. Any doubts you can ask me, like going on and on.
No doubt, all things clear.
No doubt.
This time we are not clear with the echo. We all have no doubt. Okay.
Very short, same baby.
मैडम आप एक्सप्लेन कर
हाँ?
मेरे एक्सप्लेन यस सर
Anyone is okay.
I'll give the 2 mics
माइक का जरूरत नहीं है.
and audio पे
Okay, okay. Okay, half I'll tell, half you tell. PDA Aparna ने.
अभी तो ऑन नहीं किया है ना, it is on.
ठीक है.
Okay, we both go. Let's start.
We'll start.
Okay, all of you have came.
Baby, that baby will give this. No, it's not very clear, na.
No, it's okay. This baby is okay. We'll do that.
Coronary.
First. Go ahead. Father is there. We'll do this one. For that, if it is crying, then we use that. Okay. So all of you are doing echos at your centers. Centers are doing. Okay. So your good name?
Only 5 members in this batch.
Second year.
Okay. Your? Okay. Okay. You are consultant there or?
Register. Okay.
Dr. Praveen Nayak from KIMS Karnal.
Okay.
Fellow. Okay.
Yes,
Fellowship seats are there in Kurnool. Okay.
Good.
Sunil, KIMS Karnal fellow.
Okay.
Okay.
Dr. Cloud9, high-tech.
Okay. Register. Okay. So I am Dr. Aravinda. I am post fellowship only. 4 years I am working here. Sir is Dr. Amit. He is DRMD Neonatology. Recently has joined. So we'll be teaching you, like it's a short time for echo. Like it's like a full day workstation. It should be there for echo. But we'll try to just teach you like the basic, like what are all the views and how to identify PDA. What all you can measure in the echo views. Okay. So basic though.
Okay, I will tell the basics. Okay, so what we have to see in the echos. So right now, in 2024, the AP has come with the new guideline, the TNE. So TNE means what the cardiologist is doing. They are just seeing functioning, where the central lines, and if anything is required, necessary, just like if any effusion is there. But what we have to do, we have to see as a whole, just like all the functions, PDA, PPHN, need of fluid bolus is there or not. So we have to see as a whole of the echo. So for that, we have different views, so that different views are just meant to see heart side, so that you can just have a common idea or an integrated idea of the heart. So for that, we have there are different consultant or different persons who used to start from different types. But what we are doing, we used to start from the apical view, the apical 4-chamber view, what it's telling us. So that was just below the nipple, and lateral to that, to the nipple. So it is called apical view or apical view. After that, we have parasternal view. So in the parasternal, we have two views, long axis view and short axis view. In the long axis view, we have to keep the probe towards that right shoulder, and for short axis, we have to keep towards the left shoulder. So like that, 11 o'clock and 3 o'clock. After that, we have high parasternal views. In that, we have two views. One is for the PDA, one is for the arc of aorta. And then one more is there, it is called parasternal views. That was also called as crab view, to see the pulmonary veins. Apart from that, the fascinating view for the cardiologist is subcostal view. In that, you have to see the IVC, aorta, the 4-chamber, the ASD, VSD. One more is there in that you can see the situs view. So for doing any echos, first what we are doing is we are dealing with the preterms of the babies. So we have to maintain the asepsis, temperature, and baby should be comfortable. Either you should keep something in the mouth to just decrease the pain, because what we are doing, we are holding the probe, that weight is almost 100 grams. So it will just harm the baby. So you have to make the baby comfortable, make the baby warm, keep all the asepsis precautions, because the main cause of death is asepsis, not the cardiac. So maintain the asepsis whenever you are doing the echos. We'll just start the echos view. So this is the baby that we have brought from the NICU. We don't have any baby right now that having the PDA. We just tell you about the views that at least you get to know, so that you can just implement that in your institute. Okay, so first what they are telling, that you have to sanitize this. So we have different probes. This is the sector probe, 6S. So 6S sector probe. The sector probe used to cut like that. It will go red like that. This is linear probe. It goes like that. This is hockey stick. It is also linear probe. This is for the preterm baby, extreme preterm babies. So this S is somewhat frequency. So frequency leads to the resolution and the length. The more is the frequency, more the resolution. But the depth is low. So we want, since heart is the just nearby that cardiac case, so we just want to have lesser depth but more resolution. So this is having the more resolution, but depth is somewhat less. Okay, so we'll start that with the 6S sector probe. Okay, so I'm just cleaning that with this probe. So you have to clean as a whole, because all may get infected, and what you are doing, it will not help the baby, it will harm the baby. Okay, so this is the jelly. Whatever jelly you are using, you have to make it warm. You have to keep it there. In some, they have that warmer there. It doesn't have, so you have to keep it warm under the rain warmer. Just keep it like that, it will get warm. Okay, then you have to keep it like that. So this baby, so I told you apical view. This is the apical view, just below the nipple. Here you have to keep. See, no? Then this is the, you have to keep here around 4th ICS towards that right shoulder, partial long axis towards the left shoulder, short axis. High parasternal just below the sternum, and then suprasternal above the sternum, and subcostal is here. Okay, so I'm just keeping this. And for all other views, you have to keep the probe towards the right, but for the echo, you have to keep the probe towards the left. Okay, this is the probe marker. We all have probe markers. You see this? We have the probe markers. This has the probe marker. So this should be kept to the left. Okay, for the subcostal. So I'm keeping here. Just hold like the pen. If you're holding like that, hold like that. If you're doing like that, hold like that. So I'm just holding like that. I'm just keeping here. What I'm doing, With these fingers, I'm just supporting here. I'm just keeping like here. Just touching the baby, nothing else. Now you see, I will just let you know about the view first. You have to try to make it as straight as possible. Now you see. Now you see. So you have to, yeah, I will let you, don't worry. So you have to just first focus with that so that this septum should be straight to that, okay? This septum should be straight to that line, okay? And it should be bullet shaped, okay? You have to just make it somewhat a good view. I just want to make somewhat good view, okay? Like that I'm coming. And this fill at least 2/3 of your screen, okay? So now this is just like 4-chamber view or apical view. In that what we are seeing, this is the probe position. You see this? So what is assumed that it is left, so it should be left, 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 left. So it should be left atrium, left ventricle, then right atrium, right ventricle. But sometimes when there is a levocardia, so in that you have to just find out whether it is right or not. For that you have to see how the ventricles are. So usually the right ventricles having more tuberculations. You see that more tuberculations are there. And apart from that, you will see the tricuspid wall is somewhat more towards the apex. Okay, it is like that. So it is 4-chamber view. In that 4-chamber view, there are so many other measurements, just like if you are thinking of PDA, then you have to do some calculation beforehand. So for that, you have to put the Doppler at the mitral valve to see E by A ratio. So E by A means E is the early filling, A is the atrial contraction filling. So you have to keep just the Doppler at the mitral valve. So mitral valve, no? Now you see. Sorry. So sorry. So I'm just keeping here, just opening the mitral valve in a good way. I'm just keeping the Doppler at the mitral. Now you see, 2 is coming, no? So the one is E. So early filling. A1 is atrial contraction. Usually if PDA is there, then the E by A ratio is more than 1.5. If not, it is 1, like that. Apart from that, in that also you can see the IVRT. IVRT means isovolumetric dilatation time. So what happens? So this upper one is mitral valve, okay? This one is the systole, okay? So this is systole. So IVRT usually come before the starting of this opening of mitral valve. So this thing what you are feeling, you know, this from here to here is IVRT. Okay. So after contraction, so this is contracted, from here it is IVRT, like that. Okay. So you have to calculate IVRT. So if IVRT is less than 0.4, it is normal. If increased, it means the pulmonary flooding is there. There's more blood is coming. So they have taken more time. Okay. Apart from that, so from there you have to just go to the 5-chamber view. Just putting some more. So you see, now you see, so it is 4-chamber. I'm just opening, I'm just tilting my probe towards the right side, okay, right hip, you can tell. Now you see this, the aorta is getting opened. So in that you just put the color, okay. You see the blue is coming, so blue means away from the probe. So aorta blood is go away from that. Just keep the Doppler here. Just measure this. So when you calculate the cardiac output, there's a formula. So they have pi r square. This r is come from the right ventricular output diameter that will calculate in the plex view. Into the plex view, in that I will let you know what is there. So in that you get the d diameter. So you have to divide by 4, that is radius of that. So pi r square into the heart rate of the baby, what you are feeling from the monitor, heart rate, and then VTI. So you have to trace this VTI, so you have to just measure this, go to the mitral valve. So I will let you know, and again I am doing that, just opening that, just putting the color, and just keeping the Doppler, putting the trace, just freezing that, holding the measurement. You have to go in the aorta. In the aorta you will get LV out to trace. You see this? Just trace this from here. You have to go like that, like that. So you will get the VTI. You see this 8.66. So you have to calculate, put it there in the formula. You will get the ventricular output. Okay. I'm just capturing this. Okay. Then after that you have to calculate. If you are thinking of pulmonary hypertension, in that you have to calculate for the TR jet. For the TR jet, you have to see the tricuspid valve. So this is the tricuspid valve. So you have to first put the color and see where jet is there or not. So I'm just now you see. Just put the color first. Usually it will be red flow, but jet will be there, then it will be blue flow. Okay, just keep the Doppler just below the tricuspid valve. Okay, capture that. So the lower flow is TR jet. These are the clicks. These are normal things. So these jet are the TR jet. Anything more than 35, it is somewhat significant. So right now it is coming 20. It is normal. Okay. Apart from that, in the 4-chamber view, you can also see the diastolic function. For that, you have to calculate the TAPC. It means tricuspid valve upper. Okay. So with that, I'm just doing somewhat fast. Okay. So with that, you have to just put that same 4-chamber view. You have to keep the M mode at the tricuspid valve. Okay. So you will find like that picture. I'll just let you know. So just freeze that. You see this one, this one, this one. This is the systole, this is the diastole. You have to just measure that from here to here. Okay. So this will be 1.0. Anything more less than 4 mm. So it is 10 mm. Anything less than 4 mm is significant. It is leading to cardiac dysfunction of the baby. That shows. Apart from that, then you have to come to the plex view, that is parasternal. Just I'm keeping here. You see this? See this? So this one is the plex view. This is the left atrium. This is the mitral valve. This is the left ventricle. To just keep the M mode at the tricuspid junction to see that it's in flexion and flexion shortening. Okay. Just keep it like that. So what is getting opened now? This is getting opened. So this one is the mitral valve. So the maximum diameter is the diastole. The minimal is systole. So for that calculation, you have to just go the measurement, go the dimension. So they have, the diastole. It is diastole. Just take the maximum diameter of that. Okay. And then you have to go for the systole, the minimal diameter, whatever you are finding. You see this minimal diameter. No? Just calculate the minimal diameter. So you will get that 70%, 37%. So the normal value is 55 to 70% for EF. For FS, it is 25 to 50%. That is coming normal for this baby. Now in this same view, you can see the VSD also. Just put the color because this is the right ventricle, this is the left ventricle. So if any VSD will be there, you just put the color. If any mixing will be there of the color, but is only blue is going, no? So nothing mixing is there. If any break, any mixing will be there, it means VSD is there. In the same view, I told you to calculate the output of that. For that, you will just freeze that. So in that, so this is the diameter. This is the right ventricle diameter. So you have to just before that hinge, you have to calculate that. So this is the RVOT diameter. So for output calculation, you have to keep this one 0.51 centimeter pi r square into VTI into heart rate by birth weight. Keep it, measure this one, and that also give you LA by AO ratio. Same view, same view. Okay. So I'm keeping the same here. Just putting the M mode. I'm just putting the M mode just before the hinge of that, and it should be just in the center, the hinge point. Okay. Now you see that. So this one is the aorta. This one is the LA. So the machine having the same measurement. You just keep that LA by AO ratio. Just measure both of the things to keep the maximum. What the maximum it is. So this is maximum. And this is I am doing the maximum. So they will calculate by its own. It is 1.2, it is normal. And the more than 1.5 is significant. In that view, you have to also see the right ventricular input and output. So you have to keep the same here, same here. You see, in means inside, out means outside. You just over here. This is the IC. I will just show you. Just wait. I'm keeping the same first here. Now I'm keeping in. Okay. So this is in the IVC, right atrium, right ventricle. Now going out, to see the pulmonary artery, you just keep tilt like that. With the pulmonary arteries from the right ventricle. Okay. So now come to axis. I'm just keeping like that. So you have to just make it somewhat modification. Now you see. So this one is the aorta with the Mercedes-Benz sign, and this one is the pulmonary. Then you just hold to see the biventricular view. This is 5 small view, and from here you also calculate the circumflexion by keeping the when the just calculate the maximum and minimal. You get the values from here also circumflexion. Apart from that, if PDA view is not able to see, then from here you just do that pulmonary artery view and put the Doppler on the pulmonary artery. Okay, this is pulmonary artery is getting opened. Just put the Doppler here, just behind that. Okay, now you see this pulmonary artery is getting. So if the PDA will be there, some blood will come inside, and that leads to some flow here. So if this flow is more than 30%, this flow, it means PDA is significant. It is flooding in the pulmonary artery. Okay. Then after that, we have to go for the high parasternal. So I'm just keeping it straight towards the chin of the baby, high parasternal. Okay.
Normal parasternal at what level?
It is fourth.
Fourth.
Yeah, fourth. But it is not fixed for any babies. You have to make the changes, and then you get to know.
Because warmer is not
there.
there.
Kuch any mittens are there. Just making it somewhat faster. I'm just keeping it. So now the duct is now this is the arc is there. Arc is getting opened. I'll just some tail you have to keep it right to the sternum. Just do like that. Okay. Not coming in the good way. But it is like that one. You have to just keep it there. Just make it somewhat adjustment. You will get that. I'm just trying to do that. Okay, no problem. So in that, one more view is there to see for the TPVC or the veins are there or not. It's called crab view. For that, you have to pick high parasternal. The probe should be like that, like that. Yeah, horizontal. So in that, you will first find that. Just wait. Sorry. Yeah. So this one is the pulmonary artery. It is getting bifurcated. Here it is. Some air is coming. Now you see, this one is there, no? This is pulmonary artery. This is the aorta. This is the SVC. From just you have to tilt like that. So this will open up your left atrium. So you have to just put the color in that. Just widen your scalar. Just decrease your scalar because the pulmonary flow is somewhat low. So you have to just keep it 30 to 40. Now you see this flood coming. This is coming. Now this side you see. I am just opening that. Just wait. Yeah. Here it is coming once from here. Just want to freeze that. Just wait. Here you see, no? This one you see. This one some air is coming. So I just want to freeze. So it is like that. It is coming from here. It is coming from here. So 4 veins you can see here. Okay. So after that you just go to subcostal view. Here the first is towards his chin to see that IVC. So you will see the IVC. You will see the abdominal aorta. You will see the other chambers also in that view. Just keep it like that. Now you see this is IVC. Now you have to just make it straight. When you make it straight, you will find that aorta. So aorta, yeah, I'm just keeping it straight somewhat. Sorry that. You see, these are the aorta. These are the vertebrae. Now it is coming. Okay. So for C, you keep the Doppler here, either reversal or flow or absent diastolic flow. Apart from that, you have to just tilt here. You have to see the subcostal view to define whether it is ASD or PFO. Okay. So for that, you have to keep like that. Just keep it like that. So you have to see this one. This is the application. If the flap is there, that is PFO. If flap is not, it is ASD. Okay. And one more view is there in that only. It is when you keep like that, no, you will just. I'll show you. Yeah. So this is for situs view. You will find one of the vertebra here is not coming right now. This one from here, from above it is aorta. Above that, IVC. So if relation is there, it means it is situs. Okay. Yeah. That was duplicated. Like that you have to do. So it is the practice that you have to do. More and more you will do, you will get to learn. Okay. Any questions you can ask? Any queries you want to do, you can do. No one wants to do? Huh? Okay, no problem. Okay. Sorry. Done. Okay. ले लो. Okay, no? Done. I've just given you rest because, because you have spoken so much.
Thank you so much. So, as all of us know, that retinopathy of prematurity is one of the preventable cause of childhood blindness, and it has lot of impact on life. So, one of the most important thing is the communication with the parents. That whenever we are dealing a fragile premature child, one of the thing to mention along with the systemic condition is a possibility of an eye condition, which might require treatment in the future, and the need of multiple eye checkups in the future. So, jumping to the guidelines, the first is whom to screen. So, all infants below 34 week or 2 kg birth weight should get screened. So, what we would like to say is 1, 2, 3, 4. So, 3, 4 is 34 weeks, 2 is 2 kgs, and within 1 month of birth, they should get screened. Few babies who are having risk factors, even though the gestational age is 34 to 36 weeks, if they were on prolonged oxygen or they had systemic comorbidities, then they should get screened as well. Especially in a country like India, where we come across such cases routinely. Even though they are not extremely preterm, they still develop ROP. And if gestational age is unknown, then if the birth weight is less than 2000 gram or 2 kgs, you should screen. All these patients should be informed about the eye checkup during the time of discharge. Okay, they should not leave the campus. All should get discharged from your services without details of ROP appointment, which ideally includes date, time and location. Okay. The first examination has to be done within 30 days for all eligible babies. There are few special cases where if the gestational age is less than 28 weeks or birth weight is less than 1200 grams, then they should ideally be screened earlier, 2 to 3 weeks of life. If you are planning a discharge, and even if we have not reached that time, then also it is ideal to screen them. Okay. There is a possibility, especially with newer advances in retinal imaging, where we are going to start tele-ROP screening sooner or later. But one thing that should be conveyed to the parents, that within 30 days, 30 din roshni ke is the slogan that we keep on barking. Okay. So ideally, we should prepare the eye drops. I'll skip these details, and it should be done under a warmer with pulse oximeter monitoring. We treat type 1 ROP within 48 hours. That is ideal when they have zone 1 any stage with plus, or zone 1 or zone 2 stage 3 with plus. Primary laser and nowadays anti-VEGF has been the treatment of choice. But one thing that has to be ensured is if they are injected, then the follow-up will be longer. Okay, because the vascularization process slows down. So we have to sometimes screen them till post-menstrual age of 65, and even if it doesn't get vascularized by then they might need treatment. So that is something everyone should keep in mind. Usually we'll stop screening when it is fully vascularized, or if after anti-VEGF we have reached 65 PMA. Okay. And once again, it is very important that you should never discharge your patient without next visits, date, time, place, written and explained. Okay. So one of the do's and don'ts is you should enroll the babies for ROP screening during admission only. So you should compute the first exam date so that it never gets skipped. You should document the stage, and the next follow-up should also be informed to the parents,
and should also be entered in the register. If there is any issue with the screening, or if you are not able to find ophthalmologist, please contact us. We will try and arrange a retina specialist for screening. Don't just discharge the patient after writing that ROP screening and BERA is needed after a month of birth, without actually explaining them that what can actually go wrong. Okay? And do not stop follow-ups early, especially in anti-VEGF child. Okay? So this is the pro forma which we usually use, and we mention the follow-up date so that the parents know. So the key message is that you should, in India we have to screen broader, less than 34 weeks of gestation or 2000 gram birth weight, and 34 to 36 weeks if they are unstable. The first examination has to be done within 30 days, or if the baby is very high risk or very extremely preterm, 28 week and less than 1200 gram, then ideally at 3 weeks. There should be no discharge happening without the prior information to the parents regarding the ROP screening, ideally along with date, time and place written on it. You should have your own treatment pathway, which whoever is treating the ROP nearby, they should be available, and if not, please contact us, we will try and arrange it. On follow-up, please maintain a register and patient card so the next date can be entered and it will not get skipped. So there are few key performance indicator that you should you can use in your practice is percentage of eligible patients screened by day 30. Okay, and ideally it should not be less than 5%. Okay. So as we know, it's a preventable blindness, but timing is everything. If we are not treating those patients on time, then it can lead to lifetime of disability. Okay. So we at LV Prasad are trying to do as much as possible, but with your support, we'll be able to do more. Thank you.
Thank you, Dr. Dhanush. This was a last minute addition on the request of the LV Prasad team, but we really appreciate your initiative to create more and more awareness on this very important area, and I'm sure we are all kind of important stakeholders in the message that has been given by your team. Thanks to you and to Shubhadra ma'am for carrying forward this mission. We are now finishing the pre-lunch sessions. So lunch has been arranged behind the yoga hall, just right behind this for all the delegates. Faculty lunch has been arranged in the VC room, and we are running around half an hour behind schedule. We must have begun the afternoon sessions by I think 1:20. Right now it's around 1:35. So shall we hope to meet back at 2 o'clock so that we begin the next 4 talks, each for around 15 to 20 minutes. So that we wind up the talks by 3 and we begin the post-lunch workstations at 3 p.m. We have a lot of exciting talks as well as demonstrations waiting for us in the afternoon, including therapeutic hypothermia, NIRS and amplitude integrated EEG. We have renal replacement therapy as a whole dedicated workstation, interpretation of MRI, and LISA, less invasive surfactant administration. And much more coming in, which all the young neonatal, I think, enthusiasts should know. So please don't miss out on these sessions. Washrooms are there opposite the yoga hall, just beside the library. There is one washroom even right behind the admin block, and one of our volunteers can assist. And if you have any other queries, we are around to assist. So shall we break for lunch, and maybe we can take a quick snap this way so that we have the whole group, and we'll reassemble at 2 p.m. post lunch. Can we have one photograph of the whole group? Dr. Dhanush, would you like to say something?
So few posters regarding ROP are available at the desk. You guys can collect it and use it in your own hospital. Thank you.
Please also join us for the photograph.
20%, which is very, very high. So there is a lot of sodium loss in the fetal period. But coming to the term babies, it is less than 2%. That is that is what we see, the fractional excretion of sodium. But in preterm, it is higher. So the sodium losses are higher in a preterm newborn. So the neonates, because of loss of sodiums, there is always a positive potassium balance. So that according to the definition, we say that hyperkalemia is more than 5.5 in pediatric age group. But in infants, depending on the prematurity, the value ranges from 6 and 6.5 hyperkalemia. So bicarbonate threshold. So what does our kidney do when we have a bicarb threshold of like suppose say in term infants we have 21 millimoles. So whenever the threshold is set at 21 millimoles, the excess bicarb is lost in the tubules. But the setting of this threshold is very, very important. So in adults we say 24 is the setting, the threshold, renal threshold. In term it is 21, in preterm it is only 18. So once the bicarbonate reaches more than 18 millimoles, there is a urinary loss of bicarbonate. That is why there is a kind of acidosis in newborn period, especially in preterm children. So coming to the topic of neonatal kidney injury, so the modified KDIGO guidelines is what we are routinely following now. This has combined creatinine raise as well as the urine output with the criteria, which it is divided into stage 0, 1, 2 and 3, and initiation of renal replacement therapy as stage 3. So the causes of newborn AKI. So pre-renal, that is the hypovolemic state. That is where we see in hemorrhage, hypoxic ischemia because of the shielding reflux, in sepsis because of the diversion of the cardiac output to the major organs, and any cardiac condition where the output is defective, there is polycythemia. In such cases, we see pre-renal AKI where the urea to creatinine ratio is quite higher. The ureas are quite higher than the creatinine. And coming to the intrinsic AKI, this is where there is injury in the tubules and the glomeruli. So that is why we see the raise in the creatinine. Whenever there is a tubular injury, we see raise in the creatinines. So that is acute tubular necrosis, any drug-induced kidney injury, vascular lesions causing decreased urine output, vascular lesions causing decreased blood flow to the kidneys, cystic renal diseases, they are all intrinsic renal AKI. Coming to the post-renal AKI, this is because of the backward pressure. That is, there is obstructive pathology because of which we have acute kidney injury. And acutely occurred AKI, once we relieve the pressure, the urea and creatinine also normalizes in post-renal cases. That is in the acute phase. Once we do not relieve the pressure, this post-renal AKI may also cause intrinsic AKI, same with the pre-renal. So the pre-renal AKI also can convert it into intrinsic AKI if not managed at time, appropriately. So coming to the renal replacement therapy, insertion we will be teaching at the workstations, but now I will tell you briefly about the dialysis mechanisms and how do we write a prescription. So the peritoneal dialysis, the main peritoneum acts as a semi-permeable membrane. It is like our dialyzer. That is what we say. So here the methods are three. One is diffusion, osmosis and ultrafiltration. So coming to diffusion, we see here, diffusion is nothing but high concentration to low concentration. Movement of solutes through high concentration to low concentration is diffusion. That is for smaller molecules like urea, creatinine. That clearance occurs in the diffusion methods. Coming to osmosis, it is nothing but shift of the fluid from high concentration to low concentration. And coming to ultrafiltration, it is pressure driven. So whenever there is increased blood flow in the vessels, so the water is pushed out of the vessel. That is nothing but ultrafiltration. So the same principles are used in hemodialysis. The filter acts, the hemodialyzer. The dialyzer acts as a membrane, but in peritoneal dialysis, the peritoneal membrane itself acts as a semi-permeable membrane or our dialyzer. So what are the indications? We see there is uremia, refractory hyperkalemia, metabolic acidosis, fluid overload or volume overload, or to make provision for fluids or blood products in an oliguric renal failure. So we say that, if we see the indication, there is never mentioned about creatinine. It is more of urea, because more of urea. Uremic symptoms are the indicator for any initiation of renal replacement therapy. So here is the here is the pictorial representation. So we have a catheter here in a neonate, we put it in the subumbilical region. We have a catheter connected to a three-way pipe from where we have inlet and we have also an outlet. So this is how the circuit looks like, which we will be showing on the workstations as well. So coming to PD prescription. So the first main important thing is type and concentration of the dialysis fluid. So here we can use the commercially available preparation which we have is 1.7% of dextrose containing peritoneal dialysis fluid, which we can also increase the concentration to 2.5% by adding 25% dextrose. And is it the regularly available peritoneal dialysis fluid contain lactate. In cases where there is acute liver failure or the child is in severe sepsis where the liver is also involved, we manually prepare the bicarb based fluid which can be used. So the type and concentration of dextrose is very, very important for ultrafiltration. So the concentration of dextrose is very important for the shift of fluid. So that is the first thing. Second thing is the volume. We initially start with 10 to 20 ml per kg of volume with an in time of 5 to 10 minutes. So before the fill volume, the most important thing which we have to make sure is to make the fluid warm, either by using a spotlight or to wrapping up with the cloth, so that there is decreasing the pain. So whenever you infuse a cold fluid into the peritoneal cavity, it causes a lot of pain, especially in pediatric children. They are very, very irritable, crying, and they can tell, but in newborn period they keep moving depending on the age of the child. So making the fluid warm by spotlight or keeping it under the warmer is very, very important. So fill volume. The first thing which we have to see is 10 to 20 ml per kg we initially start, and we can increase it to 20 to 30 ml per kg depending on the clearance, depending on the ultrafiltration, depending on the raise of the parameters. So the in time is 5 to 10. So you have connected, you have on, you let the volume, the 10 ml per kg fluid to go into the abdomen in 5 to 10 minutes. So coming to the length in abdomen, that is the dwell time. How does the dwell time act? So as we know that in diffusion from high concentration to low concentration, there is shift of solute. So you are introducing a fluid with no urea creatinine molecules. So the urea and creatinine from our blood through the semi-permeable membrane drain into the peritoneal cavity into the fluid. So if you put the, if you use like short dwell time, the clearance is more because there is a lot of gradient. If you keep the dwell time more, suppose if you increase the dwell time, the concentration is going to be the same, or over a period the peritoneal cavity solute concentration will increase. So sometimes it may seep back. So ideal selection of dwell time is very, very important. So number of cycles. So we have seen the dwell time as 20 to 30 minutes is what we advise. And first few cycles we run with this prescription depending on the clearance. So you want more ultrafiltration, so we increase the dwell time, we make the cycles shorter. You want more clearance, so more than ultrafiltration you want clearance, we put a little longer dwell time. And coming to the out time, so you let the fluid sit in the abdomen, and then there is a out time, that is you open the valve and let the fluid drain into the measuring bag. So usually we say out time of 10 to 20 ml. So sometimes what happens, because there is a positive balance, we tend to increase our out time. It is not necessary, you have to continue with the cycles. Even though you get a positive balance, you need to continue with the cycles. If 6 cycles persistently you get a positive balance, then we increase the volume or increase the concentration of the fluid. So coming to the number of cycles, that is how many cycles we have, coming to the number of cycles, how many cycles we have planned, till now how many cycles we have done. The documentation is very, very important, and duration of each cycle, that is the in time, dwell time and out time is the duration of each cycle. So each cycle we usually say around 40 minutes depending on our prescription, like you want more clearance of solute clearance or more ultrafiltration, we plan our cycles, shorter cycles, longer cycles, more dwell time. That is how we modify the prescription. And total treatment time, usually 48 to 72 hours we run the peritoneal dialysis in case there is no, there is a good flow of fluid out. And can we add anything to the dialysis solution? So first few cycles, because it is acute kidney injury, sometimes hyperkalemia may be there. In such cases, we run potassium free cycles in the first few cycles, but heparin must be added from bag 1 itself. So 500 units of heparin per liter is added, so that this prevents clotting, fibrin strands clotting the circuit also. So these can be added. Because the dialysis we also have dextrose, sometimes hyperglycemia may be there. So this, so in the dialysis solution itself we can add insulin too. So you can add insulin, potassium and heparin depending on the so heparin and insulin depending on the reports, heparin in all cycles, potassium depending on the number of cycles. So antibiotic, renal correction should be done, and it should be seen whether the drug is getting cleared in the peritoneal dialysis. So in such cases we give supplemental doses. So here the idea of adding potassium of 2 to 4 milliequivalents is to prevent, if there is it should be equivalent to our serum levels and to prevent leaching into the peritoneal cavity. So what are the modifications we can do? In pulmonary edema, where there is fluid overload and the lungs are with fluid, so we do shorter dwell time, and we can also increase the dialysate fluid. So the concentration of dialysate fluid is mainly important for the ultrafiltration, that is for the fluid removal. In such cases we go for shorter dwell time and concentrated dialysate fluid. In hypoxia, unable to metabolize lactate, in that bicarbonate containing PD should be made manually, which I will be telling in the next slide. Severe metabolic acidosis also, bicarbonate based PD can be used with shorter dwell time. So how do we make a bicarbonate based PD fluid? So we take a solution A which has 440 ml of 5% dextrose and 60 ml of sodium bicarbonate. Of this mixture, this is a 500 ml mixture. Of this mixture, we take 250 ml and add it with 500 ml of saline, normal saline. We get a 750 ml of solution C, which contains 140 milliequivalent per liter sodium, 40 milliequivalent per liter of bicarbonate with dextrose of 1.5 grams. So you can increase the dextrose concentration in solution C also. So monitoring we do, because the child is in the NICU, pulse rate, blood pressures with strict input-output chart and weight records if possible. Color of the peritoneal fluid, fibrin threads and PD fluid, in the PD fluid should be monitored. Electrolytes and sugars every 12th hourly. Blood urea and creatinine once a day. And in case the child is spiking fever, the color is altered and the abdomen you feel is rigid, we send peritoneal fluid for analysis. More than 100 cells is called, we see this called peritonitis. In such cases we send for culture, gram stain, cell count and cell type, and we can add with gram positive and gram negative coverage. So there are relative contraindications. There is severe systemic hypotension, there is necrotizing enterocolitis, bleeding diastasis, VP shunt in situ, diaphragmatic hernia, or any child who underwent abdominal surgeries. So these are the relative contraindications. So in these children, what do we do? The child landed up in AKI because of severe sepsis, but we are unable to do PD. Next, what are we going to do? In such cases, we do something called as continuous renal replacement therapy, that is CRRT. Now with the filters available with 0.2 surface area, we are able to do CRRTs freely, like comfortably in newborn term infants, and there are studies which show that the youngest child which we put on is 600 grams, but the outcomes were not very promising. In our unit, we have tried on 1.4 kg child, but it was severe sepsis and child landed up in DIC, but otherwise the lactate levels were improving. So coming to CRRT, so coming to any renal replacement therapy, we divide it into intermittent, hybrid and continuous. That is nothing but the duration and the clearance, how well the clearance is occurring. So in intermittent, we have intermittent hemodialysis or isolated ultrafiltration, which we do for a shorter duration, that is minimum of 4 hours and maximum of 4 hours and minimum of 2 hours depending on the age and the number of cycles in this child. Coming to hybrid, that is SLED, S-L-E-D, that is sustained low efficiency daily dialysis, or SLED plus F, that is with filtration. This nowadays we are calling as PIRRT also. So it is little longer duration. It is less efficacious than IHD, the clearance wise, but it is better than CRRT as per clearance. In continuous method, we have CVVH, CVVHD, CVVHDF and SCUF, which I will be telling again. So it is for a longer duration, for more than 24 hours is where we use CRRT. So what are the principles of CRRT? We have diffusive clearance, which we already spoke, that is high concentration to low concentration clearance. Here the small molecules are usually cleared, that is urea, creatinine. There is something called as convective clearance, which we only see in CRRT. This is nothing but there is something called as solvent drag. So whenever there is ultrafiltration, that is because of the pressure we are pushing the fluid out. That is nothing but removal of fluid, that is ultrafiltration. So along with the fluid, there is some mid-size molecules shift also, that is called convective clearance. That is nothing but CVVHD, CVVHF or CVVHV. So here what we see, we can see the clearance of lactates, albumins, ammonias, such clearance we see in the convective clearance. So this is the schematic diagram. So C1 is the blood component and dialysate. So there is shift of fluid from high concentration to low concentration. That is the first image. The second image is the ultrafiltration, that is movement against the pressure gradient. So because of which from the blood the ultrafiltrate or the fluid is being removed in the ultrafiltrate. And coming to the convection, that is along with the fluid a solute clearance is also occurring, and in this convection clearance we add post and pre-replacement, that is we add the replacement fluid, because here even though we don't require ultrafiltration, this principle itself requires fluid removal. So we add replacement, it can be added pre-filter or post-filter, that is pre-pump or post-pump replacement fluid. And coming to absorption, so here there are very large molecules which are just adherent to the dialysis filter. So any child who is very sick, who is very hypotensive, there is congestive cardiac failure with fluid overload, with multi-organ dysfunction, hyperammonemias in children, and severe sepsis, CRRT is the best choice in such children. Here what happens in convection clearance, a lot of interleukins, cytokines and all be removed. So that is very, very helpful and beneficial in children with severe sepsis. So the modalities are slow continuous ultrafiltration, that is we are just removing the water. Child has fluid overload, in such cases we go for SCUF, that is slow continuous ultrafiltration, where we connect in the circuit and just remove the fluid. Here we have, next we have CVVH, that is continuous veno-venous hemofiltration. Here only convection current is used, that is along with the push of fluid, there is solvent drag also. This is more useful for cytokines, interleukins, clearance, and even in ammonias and lactates also. So CVVH, CVVHF is also the similar mechanism where convection clearance is used. Coming to CVVHD, it is nothing but the general dialysis which we use, but in a slow process. CVVHDF is the superior of all, which has all the components. We are removing fluid, solute, we are doing dialysis also. So this is what I have explained previously. So here if you see the SCUF, you have the axis line. Here we have the blood going into the filter, then we have a return and we are just removing the fluid. But here it is in the CVVHF, that is convection clearance. So here, because even though we don't want, we have to remove the ultrafiltration. So that is why we are replacing it, pre-pump and post-pump. So pre-pump if you add, the convection clearance is more and it also prolongs our filter life. So coming to the CVVHDF, here we see the dialysate. So dialysate runs in the opposite direction of the blood. There is gradient, there is concentration gradient, because of which we see there is clearance. And CVVHDF, here we have replacement, dialysate running, and we have removal of effluent also. So CVVHDF is always most superior, and that is what we start with. So these are the machines which we use. But in neonatal period, Baxter Prismaflex is the only machine which we can use. Children who are above 30 kgs, 5008 Fresenius machine also can be used. So in the West, we have exclusive neonatal CRRT machines like Carpidem and NIRS, where even in preterm, in preterm children and with body surface area of 0.1 and less than 1 kg can be comfortably used. They are yet to come to India. So these are the things which are required. We have a 6.5 French catheter which we will be showing you, and we have anticoagulation with heparin and citrate. The filters which we commonly use is HF20, that is 0.2 body surface area. There is another filter called M60, that is 0.6 surface area. Replacement fluids, we generally go for lactate free multi-big bags because it has multiple options of K0, K2 and K4. So the bags are very important. Those are the bags with which we can use the replacement fluid and also as a dialysate fluid. All this will be shown in the workstations too. So the same schematic diagram which I have spoken before. So coming to the complication, line-related sepsis is very commonly what we see, one of the most common complication. So air embolism. So in the circuit, if there is any air trapping or sometimes the system gives the alarm, but in case sometimes air embolism is also one. Platelet consumption, blood loss, electrolyte imbalance, hypothermias and effect of anticoagulants are the frequently seen complications. So coming to the prescription writing, so first thing is filter, that is HF20 in the neonatal period. Modalities is depending on the case, depending on the clinical condition, what we have to choose. Is it CVVH, HD, HDF or SCUF? So if you choose CVV HDF, from there you can change to any other mode. But if you choose CVVH, you can't convert the machine to CVV HDF. So always better to choose CVV HDF. And coming to effluent volume, the dose is usually 2000 to 3000 ml per meter square, and this effluent volume will be divided into 2:1 ratio, 2 times the replacement fluid and once the dialysate fluid. So the replacement fluid, whichever we get the 2 times, is divided as 85% pre-pump and 15% post-pump. In many of the cases in severe sepsis where liver is involved, there is deranged coagulopathy. In such cases, we prefer, we just give saline flushes and we put in more of pre-pump so that we can increase the filter life, because the circuits itself are quite expensive. Each circuit is usually 30,000. So once you open, it is 30,000 per filter run. So coming to the blood flow rate is 3 to 5 ml per kg. The minimal setting which we can do is 25, sorry, here is a mistake, it's 25 ml per minute. Ultrafiltration depending on the hemodynamics, from 0.5 to 2 ml per kg we can go. Any child, IHD, CRRT or any mechanism, the maximum ultrafiltration we can remove is 10 ml per kg per hour. That is the golden rule, you can't remove more than that. So anticoagulation can be heparin or citrate, but we mostly follow heparin or heparin free, where we give saline flushes and we remove the same amount of fluid, and we do monitoring and renal drug adjustment. So a lot of drugs get cleared in the CRRT, especially in CVV HDF. So supplemental doses are mandatory and to be given. So here I am just briefly telling a case of how do we write. A 10-year-old neonate weighing 3 kgs presented with sepsis, the same case which we have seen in our unit also. Acute kidney injury with oliguria and fluid overload. Investigation showed AKI, elevated urea, creatinine, but normal coagulation profile, but requiring multiple inotrope support and ventilation because of the sepsis. So here we used HF20 CRRT Baxter machine, that is the Prismaflex, and the modality which we chose is CVV HDF. So because the child is a 3 kg child, so the blood flow we have put as very minimal, that is 25 ml per minute, and effluent volume. So we have taken as 2000 ml, that is 500 ml of got the total effluent volume. This we have divided into 2:1. So 2 times, that is 332 ml is the replacement fluid and 135 ml is the dialysate volume. So in the in the 332 ml, it should be divided as 85% and 85% and 15%. I'm sorry, here the pre-dilution and post-dilution are given wrong. So this 330 ml will be dilated, is divided into 85%. So almost 250 plus ml we give it as pre-pump, that is pre-dilution before the filter, and 120 ml we give it as post-dilution. And 135 ml we are giving it as dialysate fluid. Heparin, because the coagulation profile is normal, 10 units per kg is the per hour is the regular dose. So that is what we are giving per hour in a 3 kg child, that is 30 units per hour, and ultrafiltration is 5 ml per hour is what we are removing. So the difference between PD, IHD and CRRT. So PD also can be given as a continuous method. It can be done for 48 to 72 hours, but coming to IHD is 4 to 6 hours only, and we don't do IHD normally in the newborn period because the circuit volume is more. So there is a lot of blood volume in the circuit itself. So that compromises the hemodynamics in the neonatal period. So we prefer CRRT more because the circuit volume is lesser than IHD. Along with that, it is a slow process. So the hemodynamics are maintained while we are doing CRRT. So coming to technical difficulty, CRRT is more difficult and PD can be done in the resource setting areas also. So as I have already spoken, influence on hemodynamics, PD doesn't cause much other than if you are leaving it for a long time, there is a shift of fluid into the intravascular space. IHD, yes, because I told you there is a lot of blood volume removing and the blood flow rates are quite high. Here blood flow can be as low as 25, but in a IHD machine the blood flow rate is 80 ml per hour, which cannot be done in a neonatal period. And coming to CRRT, so the hemodynamics, it doesn't change much, that is why we are preferring it more. So control over fluid removal is more in IHD and CRRT and is very, very poor in PD. So possible catheter related issues are there in all the three modalities, and availability, PD is readily available where CRRT only few centers are having, and anticoagulation usually in PD is not very necessary, but in CRRT and IHD it is necessary usually to maintain the circuit basically, but sometimes without anticoagulation also we can go ahead with CRRT, that is by giving saline flushes, but that will compromise the life of the filter. So just 2 minutes. So and solute removal, it is maximum with CRRT and IHD when compared to PD, and the rapid clearance occurs in IHD. So for clearance wise, IHD is the most important and more efficient one. Then comes CRRT, then only comes the peritoneal dialysis. And to ease of use in neonate, PD is always preferred. But in our unit, we are doing CRRT also very comfortably. These are 2 neonates which we have done, there are studies about how the dosing, how efficient they were, and what were the outcomes. So thank you. I know I have taken a lot of, thank you.
Thank you, Dr. Monica.
Any doubts?
Talk on renal replacement therapy. Any doubts? If there are no further doubts, we'll go on to the next talk. It is by Dr. Vishwanath, DRNB Neonatology, consultant neonatologist from KIMS, Cuddles, Kondapur. Dr. Vishwanath is going to talk on newer modalities of monitoring, AEG and NIRS.
Okay, good afternoon everyone. So today I'll be discussing neuromonitoring tools in NICU, basically amplitude, EEG and NIRS. So my objectives, I'll keep it simple. We'll just see how the basic working principle of amplitude EEG and NIRS and a few bedside applications. So because want of time, we won't be discussing much about the evidence related to both. So amplitude EEG, it is a bedside continuously monitored cerebral trends. Basically it gives the cerebral function, neurophysiological function at bedside. And unlike Conventional EEG, which has 20 leads, amplitude EEG has limited electrodes, like 2 or 4. So it's a limited channel tracing. And the instrument which is used to monitor this EEG is called as cerebral function monitor. So let's understand how the recording is done. So we have something called as electrodes. There are various electrodes. One is hydrogel electrodes, and there are metal cup electrodes, and then there are invasive needle-like electrodes. So all of them have their pitfalls. But from now we have moved on from one channel electrodes to two channel electrode. Okay. I think pointer is not working. So two channel electrodes. So we keep it on the scalp. So we prefer certain areas in neonates, which are usually the centroparietal areas, because it is very near to the the cerebrum and okay, fine. So we prefer certain areas in neonates, which is usually the centroparietal area, because it is close to the cerebrum, and it is more affected in the common condition like hypoxic ischemic injury. So you can see the scalp electrode placement. Conventionally, the right hand side we give it even numbers, and the left hand sides are odd numbers, and the areas of the scalp like frontal, central, parietal and occipital are represented by F, C, P and O. So there is something called as a ground electrode represented by Z, if you can see. So that is zero electrode. It helps to eliminate the artifacts. So this is usual placement of electrodes on the scalp. You can see the central electrode on the forehead. It helps in elimination of artifacts, and then there you can see the centro and the parietal region. We have kept 2 electrodes. So this is the usual placement, and these are the hydrogel electrodes which we have placed. So if we go into the methodology of amplitude integration, there are signals from the electrodes which are captured by the bandpass filters. And the function of this bandpass filter is it enhances the frequencies between 2 Hz and 15 Hz. And the frequencies above 2 and below 2 and above 15 are usually attenuated. And the amplitudes which is less than 10 microvolts are displayed on the linear scale, and more than 10 are represented as logarithmic scale. Hence we label it as semi-logarithmic display. The lowest amplitude is represented at the lower border, and the highest amplitude is detected as the upper border. So it is usually a time compressed. We will see the display graph how it is seen. The 6 centimeter represents 1 hour time scale. So here you can see on the top here the y-axis you can see the amplitude EEG represented in microvolts, and this is the x-axis, and these two this represents 6 centimeters box, which is 1 hour timeline, and this is the right and this is the left, and here is the voltage you can see. Okay. So there you can see something called as, the 2 channel which we commonly follow, and it is represented as semi-logarithmic display. And this is the raw EEG where you can see it is represented on the linear scale. You can continuously see the raw EEG. And here something ohm is represented, which is the resistance. So if you see amplitude EEG, the graphs looks like something like this. Okay. So the upper border is the highest voltage, the lower border is the lowest voltage, and we call it as bandwidth or the trace. Okay. So there are many approaches to interpret this amplitude EEG. Most of them are qualitative. There are few quantitative developed into SCORE. Which we commonly use is this Hellstrom-Westers. There are other scoring systems as well. So when we interpret amplitude EEG, the qualitative interpretation we look for background pattern, we look for sleep-wake cycle, and if there is any seizure activity. So basically, when you are talking about amplitude EEG, we have to talk in terms of all these three. How is the background pattern? What is the sleep-wake cycle? And if any seizure activity you are able to see. So the background pattern is basically voltage based, and you see based on the lower margin and the upper margin. Okay, you label them as either the background activity is normal, moderate, abnormal, or suppressed. So if the lower margin is more than 5 and the upper margin is more than 10, it is normal. Moderate abnormal is lower margin is less than 5 and upper margin is above 10 and below 25. And it is suppressed if both upper and lower margins are less than 5 and less than 10 respectively. So the background activity, there is a pattern which we follow to classify them. Okay, so the pattern are usually continuous normal, discontinuous normal. It can be continuous low voltage. There can be burst suppression, and there can be a flat trace. So all this background pattern is based on the margins, upper and lower margin. In continuous normal, it is lower margin above 5, upper margin is between 10 to 25. In discontinuous normal, it is less than 5, and upper margin, it is more than 10. Difference between continuous and discontinuous is based on the lower margin. Okay, and the continuous low voltage, the lower margin is around 0 to 2, and upper margin is less than 5. And in burst suppression, the lower margin is around 0, and upper margin usually shoots up above 25. And based on the number of bursts in 1 hour, like if the bursts are more than 100, it is burst plus, and if it is less than 100, it is burst minus. Isoelectric trace, it is usually, the lower margin is at 0 microvolts and upper margin is around 0 to 2. So then we have to comment on the sleep-wake cycle after the background pattern. Sleep-wake cycle refers to a cyclical fluctuations in the amplitude. It usually represents the physiological state when the neonate goes from awake to quiet sleep to active sleep. And there is a sinusoidal pattern we will see in the subsequent slides. It is usually seen on the lower margins. If the bandwidth is wider, it represents the discontinuous activity in the quiet sleep, and narrow bandwidth represents the continuous activity when the neonate is awake. So this gives the appearance of a sinusoidal wave. The sleep-wake cycle, based on this sinusoidal pattern, we have to classify as absent, immature, and developed, how well they are classified. Then the third aspect comes about the seizure activity. Seizure activity is any abrupt rise above 25 microvolts, touching up to 100, and in some instances it goes up to 120 also. So it is usually followed by a period of decrease in amplitude. So these three patterns based on which we interpret EEG as background activity, how is the sleep-wake cycle, and the seizure activity. So for your understanding, you see the display of amplitude EEG. The lower margin is around 5. The upper margin is between 10 and 25. But clearly you can see there is no sinusoidal wave pattern. So there is no sleep-wake cycle, and there are no voltage activity which is going up to 100. So there is no seizure. So this is continuous normal voltage, but without sleep-wake cycle. Here you can see little bit of sinusoidal wave pattern. The lower margin is having some sinusoidal pattern. So there is some sleep-wake cycle. So this is continuous normal voltage with sleep-wake cycle. In discontinuous normal voltage, you see the lower margin is below 5 and the upper margin is going above 10, 25, around 50. So this is discontinuous normal voltage. Low voltage, the lower margin is around 0 and the upper margin is also less than 5. So this is continuous low voltage. In burst suppression, the upper margin shoots up to 100, and based on the number of bursts in an hour, it is burst plus, or the lower one burst minus. So less than 100 bursts in a minute. Isoelectric or flat trace means there is no cerebral activity. Both the upper margins and lower margins are around 0 to 2 microvolts. So after understanding this amplitude EEG, we always interpret as the background activity, the sleep-wake cycle, and the presence of seizures. So these three parameters helps us to monitor neonates in various disease conditions, especially neonates transitioning after delivery and neonates with hypoxic insult, be it term baby or preterm. And now it has been widely used in the recovery phase of therapeutic hypothermia. It carries a lot of prognostic significance. I think the evidence we'll discuss later some other time. But it has a good prognostic value in recovery phase of therapeutic hypothermia, and the detection of seizures and the management, introduction of drugs or stopping of anti-seizure medications, and also in the prediction of neurodevelopmental outcome. So there are few EEG patterns which have an unfavorable outcome and few EEG patterns which have favorable outcome. Like if there is normal background activity, the presence of sleep-wake cycle within 36 hours after birth, or the return of sleep-wake cycle during cooling early has a good prognostic significance. And few unfavorable outcomes like continuous low voltage activity and presence of multiple seizures, absence of sleep-wake cycles and status epilepticus, it carries an unfavorable outcome. There are many pitfalls to amplitude EEG because it detects signals from a very small area of brain, and it is a time like we said, it is a time compressed activity which can miss few cerebral seizures or activities. And the interpretation of raw EEG, which requires knowledge about conventional EEG, and there are many internal and external factors like, there may be impedance issues with impedance and the type of electrodes we are using, neonate is moving, so then it all interferes with the amplitude EEG. Now coming to NIRS, let's understand how the NIRS works. The basic principle, this is also a non-invasive tool. It represents a percentage of saturated hemoglobin in the targeted tissue. So when any targeted tissue is subjected to near infrared, when the near infrared interacts with the hemoglobin, it is either absorbed, reflected, scattered or transmitted. So the reflected, scattered and the transmitted light remains constant irrespective of the tissue. But the hemoglobin, which is it basically depends on the absorption, differential absorption of the near infrared. So the principle is that there is differential absorption of infrared rays when they pass to a targeted tissue. And this is some algorithm which is into the device, which is the modified Beer-Lambert law. So if you see on y-axis there is absorption coefficient, and in the x-axis there is wavelength. So the near infrared wavelength is somewhere around 700 to 900. And during this bandwidth, there is a differential absorption of oxy and deoxyhemoglobin. So this difference is captured by the NIRS monitor. So if you see, we call it as regional saturation. So the regional saturation is the oxyhemoglobin by oxyhemoglobin plus deoxyhemoglobin. So this is regional saturation, which is displayed on the NIRS monitor. So how does it work? If you can see, for example, this is the sensor where there is a light emitting diode, and it is detected by a superficial detector and a deep detector. The superficial one receives the wavelength from the superficial tissues, and the deep detector receives wavelength from both superficial and the deep. Okay, so RSO2 is a weighted average. It includes both venules, artery and capillaries. There are many commercial available devices available, of which the prominent are Invos, O3 and Oxyprem, which uses various algorithm to display the regional saturation. When compared to pulse oximetry, NIRS is not pulse synchronized. It is a weighted average of artery, veins and capillaries, and it gives a rough estimate of both oxygen supply and the demand. And whereas the pulse oximetry is pulse synchronized, it shows only the arterial oxygen saturation and helps in understanding the oxygen supply only. So the site selection is based on the region. You can see NIRS probe is applied to the forehead, and it can be applied to the splanchnic region, and also it can be applied to the renal, the kidneys and the peripheral tissues also, like forearm, calf, upper arm and the leg. The major limitation for now, not later on, because we don't have a specific cutoff for regional saturations, but there are many studies which shows regional saturations of the cerebrum, renal and the splanchnic circulation. So these are all the reference values in term and preterm. This is one of the largest study which was done in preterm, almost 999 preterms, less than 32 weeks, and cerebral regional oxygen saturation reference cutoffs were given from 24 to 26, 26 to 28, then 28 to 30 and 30 to 32. So they gave a cutoff of regional saturation. So the bedside application in term neonates to understand the regional saturation in cerebrum, kidneys and the splanchnic, and the transition after birth, and especially in neonates with HI which have a higher regional saturation during the initial few hours of hypoxic ischemia. And nowadays all the procedures, pre-operative and the intraoperative congenital heart disease is based on NIRS monitoring. In preterm also, the most commonly used NIRS is for IVH, where the initial regional saturation increases, which is followed by later on decrease, and then encephalopathy of prematurity. PDA is a very important area where NIRS is being used nowadays, and also the need for red cell transfusion and the response to red blood cell transfusions. So these are all the bedside applications of NIRS. So the clinical outcomes with what we see is it helps in guiding the respiratory and supplementary oxygen support, especially after birth. There are many studies where standard care was given to the neonate based on pulse oximetry, and then the other arm was guided by NIRS monitoring, and the PEEP and FiO2 were controlled based on NIRS values. So it helps in guidance of respiratory and supplementary oxygen, and also it helped to reduce the burden of cerebral hypo and hyperoxia both, and detection of early brain injury and congenital heart disease. It helps in the management of anemia and IVH and white matter injury in preterm. So there are limitations, like we don't have the large normative data for NIRS regional saturations, and issues with some optical probes and the algorithms which the various devices uses, and there are some interpatient variability, and sometimes it has been observed that in the same area there are different readings, so that also is a limitation with NIRS. So with this I conclude. Thank you.
Okay, so good afternoon. I think all are sleepy right now after the post-lunch. But this topic is somewhat different because both of the things, AEG and NIRS, is the future of NICU. So at least if you have learned sleep wave cycle, the upper limit and lower limit of that EEG or AEG, and the NIRS, how they have interpreted and where it is applied, because it is going to change the NICU treatment for the future. Now just coming to a new topic. Thank you, Vishwanath sir. Wait. Any confusion, any doubts from sir? Anyone ask? Nothing is there. So no confusion, no learning. Okay, no problem. We will now proceed further to the talk. Now we have the topic on PPHN from Dr. Naveed sir from the KIMS Kurnool. He is consultant there. So this topic is also so much important because for the term MS, all the babies, we are suffering with the PPHN. So just have some insight on the PPHN. Thank you, sir.
Thank you, sir. Thank you, everyone. I'm Dr. Naveed. I'm working as Neonatal consultant at KIMS Kurnool. First of all, I want to thank the organizers for giving me an opportunity to talk here. My topic today is what's new in the management of PPHN. The outline of my talk is first we'll start with background and incidents, then go through the diagnosis, then we'll talk basically about few principles of management, including ventilation and surfactant, phenotype-based approach, and role of pulmonary vasodilators in managing PPHN. Then we'll talk about rescue and emerging therapies, a few slides about ECMO, and the proposed clinical pathway for managing babies with PPHN. So as we all know, it was first reported by Gersony et al. In 1969 as persistent fetal circulation. PPHN is defined as failure of pulmonary vascular resistance to decrease after delivery, incidence being 2 per 1,000 live births. It does carry significant morbidity and mortality even in this new age. And that is why prompt diagnosis followed by early aggressive treatment is very important, and that is going to affect the outcome of the babies. So we all have seen this slide since student days. In fetal circulation, two shunts that are important for us after birth is the PFO and the PDA. Generally, it's right to left shunt before birth, and that should reverse to left right shunting or close off after birth, and that doesn't happen in severe PPHN. And that what causes the hypoxia and complications of PPHN. So causes, there are multiple reasons why PPHN can be the effect of multiple diagnoses. Parenchymal lung diseases, most common of them being meconium aspiration syndrome, can have congenital pneumonias, HMDs, and sepsis and birth asphyxia. Developmental lung abnormalities, genetic abnormalities, and sometimes prenatal constriction of ductus arteriosus and maternal drug exposure have all been associated with PPHN in the newborn. So coming to diagnosis, the common thing we come across is labile oxygen saturations, which raises the suspicion of PPHN in a baby with respiratory distress. Hypoxia that is out of proportion to the degree of lung disease, which is self-explanatory. You can have a mild lung disease, but child is very hypoxic. Another bedside test that we usually do is differential saturations, checking the right limb saturation with the leg saturations, and the difference indicates that there is some shunting happening across PDA. So echocardiogram is the gold standard, both for diagnosis and to rule out any other congenital heart diseases. I'm not going to go through the findings, it's a big topic on its own. So principles of treatment. So first thing, as I said before, early prompt diagnosis followed by aggressive treatment is the key. The aim of our treatment is to reduce the pulmonary vascular resistance, at the same time increase the systemic blood pressure so as to match the pulmonary pressures and reverse the shunts. The aim is to improve oxygenation, but at the same time avoid oxygen toxicity because it worsens the PPHN. Then restore cardiopulmonary transition, at the same time avoid lung injury. Coming to oxygen saturations, in the olden days we used to think about giving very high saturations to these babies, maintaining 98 to 100, but nowadays following more and more studies, we have concluded that the saturation should be aimed to 90 to 97%, and with the aim to maintain between 92 to 95, that should be good enough. PaO2 levels to maintain between 60 to 80 mm of mercury. Any higher saturations will not, like PaO2 going above 100 is going to still worsen the situation but not help them. And so you have to avoid both hypoxia as well as hyperoxia, because both are going to worsen your pulmonary vascular resistance. So coming to ventilation, volume ventilation is the best. If you are doing with conventional ventilation, volume ventilation is the best. Then adequate PEEP to open up the lungs, relatively low PIP, and maintaining the normocarbia. Again, previously we used to aim for very low carbon dioxide levels so as to make the pH alkaline, but that has gone out of the window now. So either we maintain normocarbia, or sometimes you may have to allow some permissive hypercapnia. Regarding conventional or HFO ventilation, studies have not shown much difference between the two modes of ventilation. However, if you are needing very high mean airway pressures, we generally switch over to high frequency ventilation, particularly if you are going to use inhaled nitric oxide. Studies have shown that HFOV with INO is more effective than conventional ventilation with INO. And we monitor with oxygen saturation index or oxygenation index, depending on we have arterial line or not. Surfactant use does help to improve the oxygenation, particularly in conditions like meconium aspiration syndromes, pneumonia or sepsis, particularly when the OI is going above 15. Cardiovascular support, we should aim to reverse these shunts that are happening right to left shunt. So you have to maximize, optimize your cardiac function and aim for normal to high blood pressures. So it's depends on how the baby's condition is, depending on the blood pressure and the cardiac function. If the both blood pressure and cardiac function is normal, you can just monitor the situation and do symptomatic management. If the blood pressures are low with normal cardiac function, you can go ahead with vasopressors like vasopressin and norepinephrine. If BP is normal but has cardiac dysfunction, you generally prefer milrinone, dobutamine or epinephrine. If the blood pressures are low and there is cardiac dysfunction, again you have to use norepinephrine or vasopressin. These are the babies that are going to end up with more problems and may need ECMO. So other supportive care is also very important because you have to correct the metabolic derangements, hypoglycemias, hypocalcemias or acidosis. We have to maintain normal pH, which are all going to worsen your pulmonary hypertension. Sometimes you may have to sedate the baby so that they cooperate with the ventilation better, and briefly you may have to paralyze the babies as well, because it does reduce oxygen consumption and improve the baby's hypoxia. So to sum up from ventilation and supportive care point of view, we maintain saturations of around 90 to 95 with a PaO2 of 60 to 80. Normocapnia is ideal. If needed, we can allow some permissive hypercapnia. Adequate lung expansion, normal pH and the blood gas, normal to high blood pressures depending on phenotypic situation, and correct other metabolic rearrangements. And a brief talk about pulmonary vasodilators now. So various pulmonary vasodilators are available for us. Cyclic GMP pathway, the nitric oxide and sildenafil. Cyclic AMP pathway, milrinone and prostacyclins. Rho kinase pathways, bosentan, and other vasodilators that are ROS pathway and vasopressin and adenosine. So we'll go through a few of them which are available to us in our day-to-day care. First, inhaled nitric oxide. As we know, it is the most significant advancement in PPHN management. It's a selective pulmonary vasodilator, and its use is supported by several large trials, and it improves oxygenation, reduces the need for ECMO, with numbers needed to need being 5.3, but it does not reduce mortality or neurodevelopmental outcomes. Eligibility criteria, as we know, generally it's more than 34 weeks and less than 14 weeks postnatal age, the baby to be in hypoxic respiratory failure and oxygenation index being more than 20. Contraindications: if there is severe LV dysfunction or congenital heart disease with duct dependent right to left shunts or TAPVC, we won't be able to use nitric oxide therapy. General starting point is usually 20 parts per million. If needed, if the baby is not responding, some units or some clinicians use 40 or up to 80, but usually 20 is the starting point, and most of us use 20 parts per million. Babies that are going to respond usually do so within the first 60 minutes of starting the therapy, which is indicated by a PaO2 rise by 20 mm of mercury or reduction in oxygen index by 20%. So if the baby does not respond, you can discontinue nitric oxide therapy abruptly. But if the baby has responded, we will continue and go ahead with gradual weaning. As the baby improves and FiO2 requirements come below 60%, you can start weaning nitric in parts of 5 parts per million every 2 to 4 hours. And when you reach 5, you start reducing in steps of 1 until you reach 1 parts per million, at which point you would continue for 6 hours. Most of the times we are already on sildenafil, but if you are not, it is advisable to just preload with sildenafil before starting stopping nitric, because you can have some rebound increase in pulmonary pressures after stopping nitric. Generally, a rise of up to 15% rise in FiO2 is acceptable after stopping the nitric. General duration is usually 4 to 5 days. So monitoring, we generally monitor with blood gases. Platelet count is very important because it does cause drop in platelet and platelet dysfunction. Continuous monitoring of nitric oxide and NO levels is very important. Generally, after doing blood gas, we do a blood gas 60 minutes after starting the therapy, which is used to define the response to treatment. And generally, when you are weaning, before and after each step in weaning, we will do a blood gas. And in the case of any clinical deterioration. Methemoglobin levels generally need to be monitored when you are using nitric at very high levels, which is generally 40 or above parts per million. Non-invasive nitric oxide is also one possibility, although I have not personally used it. But there are literature suggesting we can use with CPAP or HFNC, but we probably will need suitable equipment to provide nitric in a non-invasive form. But if we can, it does avoid intubation. The second most common drug that we use in our day-to-day unit is sildenafil, which is a phospho-PGE5 inhibitor. So the risk is it's not a selective pulmonary vasodilator like nitric, so you may have some hypotension, might have to use vasopressors along with sildenafil. So both IV and oral forms are available. Oral form being 1 to 3 milligrams per kg every 6 hourly. The third one commonly used is milrinone, which is a cyclic AMP pathway PDE3 inhibitor. It causes vascular smooth muscle relaxation. Along with that, reducing pulmonary pressures, it has additional benefit of improving your LV function. So it has both inotropic as well as lucitropic effect. It is useful in PPHN when there is associated LV dysfunction. And particularly when nitric is contraindicated in such cases, you can make use of milrinone. Vasopressin, another drug which is very effective but less commonly used by us because it's mostly used in adults, and now more and more neonatal units are using vasopressin. It is a potent vasoconstrictor, so improves the blood pressure. At low doses, it stimulates the endothelial V1 receptors in the lungs, causing the release of nitric oxide and causing pulmonary vascular dilatation. It is very useful when the baby is not responding to nitric or when there is hypotension despite conventional inotropes. So few newer drugs which we come across in literature but not in regular use. Riociguat, it stimulates a soluble cyclic guanylate cyclase, acts on cyclic GMP pathway. That is, it works like nitric oxide to improve the cyclic GMP levels. So in a baby with low nitric oxide levels, like hypoxic babies and all, riociguat is very helpful. Again, has been used in adults or in pediatric age groups, less commonly used in neonates, but it's something that can be easily available. Bosentan, another drug which we hear commonly but not much used in neonates. There is a lot of literature for children and adult age groups. It is a ATA inhibitor. Again, studies have shown in neonatal age group at least that it is not as effective as sildenafil, but it is better than placebo to reduce pulmonary artery hypertension. So it can be used as an additive therapy to along with other pulmonary vasodilators. Treprostinil, it is a prostacyclin analog. It is an IV preparation. Can be used as an adjunct therapy to inhale nitric oxide. Again, neonatal data is not available, just case studies and few reports are available, but not large studies. It is more effective than oral sildenafil. Few studies are there from China. More effective than oral sildenafil to reduce pulmonary artery hypertension, and it does give additive effect when used with inhaled nitric oxide, and it also helps to wean off ECMO for a non-responder. Then inhaled ipoprostenol or iloprost. It is an inhaled form, so can be used like nitric oxide. thereby it is a selective pulmonary vasodilator with very minimal side effects. Again, not much data available, but it's something all these drugs that might come into use in the next few years. ROCK inhibitors, Fasudil is the only drug that is available. From neonatal point of view, it is only in preclinical stage. So the significance of this drug is that not only reduces the pulmonary artery hypertension, but also inhibits arteriolar remodeling that happens in pulmonary arterioles due to PAH, and also reduces the right ventricular hypertrophy. So last resort is ECMO, but we can use it in babies who are more than 34 weeks and weight more than 2 kgs with reversible lung disease and no large IVH. Those are the criteria for ECMO. We have discussed a lot about it this morning, so we won't be discussing much. The important thing is ECMO is not a replacement for early optimized therapy. So early optimized therapy in the neonatal unit before waiting for ECMO or transfer for ECMO is very important. That will decide our outcome. So the last slide, just a simple clinical pathway. To maintain saturations of around 90 to 97%, PaO2 of around 60 to 80 with normocapnia. Depending on the case, we may be using surfactant, sedation, or correction of any metabolic derangements. You assess the circulation. If the right to left shunt is not significant, you may just be using inotropes and vasopressors and giving ventilatory supports. If there is significant right to left shunt which is indicating severe pulmonary arterial hypertension, you will have to use pulmonary vasodilators. The first or foremost important one is inhaled nitric oxide, and other additive things will be sildenafil, milrinone, vasopressin, and prostacyclines. Then assess for response. If the oxygenation improves, you will be weaning vasodilators. If there is no improvement after using pulmonary vasodilators, we will consider ECMO. Thank you.
Thank you, Navi sir. So any queries for the PPHN? I think what I have learned in my residency for the PPHN, if you find any baby with the PPHN, the more important thing is the supportive care. So what we are doing, we are just keeping the baby in either in the isolation room or in the room where there is no light, decrease the pain, at least as much as you can, and then normalize the CO2, oxygenation, and all the things. So it is the supportive care which helps more, and it is the magical for the PPHN baby. Now, since we have done all the acute cases till now, so we are moving to most of the important topic, that is the feeding of the baby. So after curing the baby from all the acute things, we have the topic as recent changes in the preterm nutrition from the Dr. Ridhima. She is consultant at the KIMS Secunderabad. Now, hand over to Ridhima, please.
Good afternoon, everyone. Today I'm going to discuss the most debated and important topic, that is recent changes in preterm nutrition. And this timer is making me really, putting a pressure on me to finish faster. I'll try to do my best. So, coming to the introduction, the preterm birth leads to the nutritional emergency in an infant. And in utero, fetus receives a constant supply of glucose at 6 to 8 mg per kg per minute, protein of 4 gram per kg per day, and lipid of 3 gram per kg per day. So the energy stores in fetus at 24 weeks is only 19 kilocalories, whereas compared to term babies, it is around 3000 kilocalories. As you can see, the water percentage is reducing from 24 weeks to 40 weeks, and the calorie requirement is also increasing. So 24 to 28 weeks, they are critically underprivileged, and for these babies, we have to go aggressively in nutrition. So we'll go with the case scenario. This is a 28-weeker preterm infant with birth weight of 730 grams with AEDF in antenatal scan, born via elective section, admitted in NICU, started on CPAP, and lines are placed. So the orders are to start TPN at aminoin of 3.5 and lipid of 2.5 and JR of 6. So these are a group of residents who are quietly criticizing consultant, saying that previously we used to start at lower doses and now why are we starting at such higher doses? So according to guidelines and especially ESPGHAN, the European guidelines, they have quoted to start protein at 3.5 to 4 gram per kg with maximum of 4.5 if the growth is suboptimal, and also to monitor plasma urea regularly to check on the protein intake. And if the urea levels are lower, we have to hike on the protein. The other recommendations are, according to Espegan, the fluid rates has also increased from 150 to 180, and the energy is also on higher level, there's 115 to 160 kilocalorie. Proteins, as we already discussed, and fat is 4.8 to 8.1 gram per kg per day. So this baby, after starting TPN, the orders are to coat the oral cavity with expressed EBM or colostrum. So what are the excuses to withhold enteral feed? One is dreaded fear of NEC or any perinatal depression or UVC or any umbilical lines, and mechanical ventilation or shock or inotropic support. But all these are not evidence-based. So how will this small amount of colostrum help the baby is the question. So the oral coating of colostrum, it is applied evenly in the oral mucosa using either syringe or cotton swab or oral applicator, and the immune effect is achieved by absorption of through oral mucosa. It helps in reduction in sepsis and also helps in colonization of beneficial bacteria. So the evidence says, this is a meta-analysis of 11 RCTs in preterm infants less than 32 weeks, and it has shown to significantly reduce NEC, late onset sepsis, PAP, time to reach full enteral feeds, and duration of hospital stay. So conclusion is OAC can be used as a part of routine care in preterm infant. And the Espegan says, though it is safe and theoretically attractive for both emotional and immunological point of view, there is no clinical benefit for this. And no recommendation can be made for and against the use of for the oral colostrum. So this baby, after oral colostrum, the orders are tube feeds 2 ml 8th hourly. And we are wondering that how will 2 ml 8th hourly help this baby, whether it will fill the baby's tummy. So these preterm babies have an immature gastrointestinal tract, both morphologically and functionally. They have a sparse motility, incomplete barrier function, and immature immunological defense system. And there is a hormone secretion and motility which is stimulated by ingested milk. So delay in initiation of enteral feed can cause diminishing the functional adaptation of preterm gut, delaying the maturation of enzymes, intestinal atrophy, and even decreasing the intestinal weight and size. As you can see, the enteral feeding versus TPN, the intestines, there's villus atrophy and also decrease in the size. And also the gut hormone secretion is better if enteral feeding is started earlier. So this is also called as trophic feeding. It helps in stimulating the development of immature GI tract of preterm infants. It is an unfortified human milk, hypocaloric for somatic growth, and it is non-nutritive nutrition. And the Cochrane says there is no incidence of NEC and mortality if we start trophic feeds less than 4 days of age. And the Espegan guidelines have quoted that there is no clear beneficial effect for this enteral fasting or minimal enteral feeds, but recommendations are to start small feeds as soon as possible, especially in most of the preterm infants, and advanced feeds if they're clinically tolerating. Even the NNF guidelines say early trophic feeding started within 24 hours of life is recommended in preterm LBW infants, including those with IUGR and ELBW. And the delayed introduction of enteral feeds have shown slight reduction in risk of feed intolerance, but it has increased the risk of invasive infection also, according to Cochrane. There is the new concept, this is total enteral nutrition, and the rationale is to promote gut maturation, hormone secretion, and motility. It also supports early growth and brain development. This is a study by Sushma Madam in 2018, and early total enteral feeds has shown earlier time to reach full enteral feeds, reduction in the feed intolerance episodes, sepsis, and even NEC. Even Cochrane has quoted that the early total enteral nutrition is safe with no increase in risk of NEC. So next is, after starting minimal enteral feeds, what type of milk to be given. So if mother milk is not there, what is the next option? So Espegan has quoted that fresh mother milk, it contains high amount of immunoactive and trophic factors. So we strongly recommend mother's milk as the first choice for feeding in preterm infants. Even the other guidelines like AMP and NNF have quoted first line is mother milk, and if mother milk is not available, then pasteurized donor human milk is this next option. And what are the enablers for mother's milk in NICU, especially in preterm infants? One is the number of milk expressions on day 1, number of night expressions, volume of mother milk on day 3, day 7 and 2 weeks, and also the number of maternal visits. So all these help in increasing the mother's milk for preterm infants, and the barriers are ELBW and IUGR. And the other modalities like KIMS and NNS can also increase the mother milk for preterm infants. So the same baby, we have started feeds of 2 ml second hourly. Now from here, how should we advance feeds from here? So there is a Cochrane review showing slow advancement versus fast advancement. Slow is 15 to 20 ml per kg versus 30 to 40 ml per kg per day. And it has shown little or no effect on risk of NEC or mortality prior to discharge, but may slightly increase the risk for feed intolerance. This is a landmark trial, SIFT trial. They have enrolled 2,800 infants born less than 32 weeks and less than 1,500 grams. And they have given increment of 30 ml per kg in one arm, and another arm it is 18 ml per kg. And they have seen there is no significant difference in late onset sepsis or NEC in both the groups. And the median duration to reach full enteral feeds and was better in the 30 ml per kg group. So the guidelines say the faster feeding progression does not increase the risk of NEC or late or mortality, and it also helps in reducing the time for full enteral feed and length of hospital stay. So daily increment of 18 to 30 ml per kg is recommended. And NNF quotes 30 to 40 ml per kg is recommended in stable preterm VLBW infants. So the next is, so once we have started feeds, now how do we progress? Like, should we give every 2 hourly or 3 hourly or hourly? So the Cochrane says the difference between 1 or 2 or 3 hourly, there is no difference in reaching full enteral feed, but however, it might take a longer time for regaining birth weight in 2 hourly feeding. And there's another concept called continuous versus bolus feeding, where there is no difference in the risk of NEC, regaining birth weight or reaching full feeds, but is higher risk of contamination or nutrient loss in continuous feeding. So there is no rationale to use it routinely. And even NNF also doesn't recommend continuous feeding for preterm babies. So this baby, we have we have given feeds faster, and baby has reached full feeds of 160. So is 160 ml per kg full feed, or can we go beyond this? So the Cochrane view says that they have compared 2 arms, more than 200 and less than 180, and they have seen those babies who have received more than 200 ml per kg in stable preterm babies, the weight gain had improved better in these babies as compared to other arm, and there was no effect of NEC or and little effect on linear growth. So after reaching full feeds of 170 ml per kg, the baby is actually on 90% of donor milk. And baby is actually gaining very less weight, 8 grams per kg per day, as opposed to 15 to 20 grams per kg per day. So why do you think this baby is not in the catch-up phase of growth? So this donor human milk can be used as a substitute for mother milk when only mother milk is not available. But you see the donor human milk, the bioactive factors like lactoferrin, IgA and everything is reduced by 50%. And therefore the growth in babies who receive donor human milk is less as compared to mother milk. So fortified pasteurized donor human milk is recommended instead of preterm formula to reduce NEC rates. But in case of insufficient mom only, then we have to recommend donor human milk. So why is this fortification recommended? This is the preterm protein value in preterm milk. So you can see after 2 weeks, the protein content of preterm milk is reduced. This is the period for fortification, and fortification is recommended for catch-up growth. So there are many types of fortification. One is standard and individualized. Standard is multi-component fortification, though it is practical, but they have seen that many of the VLBW infants have suboptimal growth. Another is individualized. It can be either adjustable or targeted. Adjustable fortification is based on the blood urea nitrogen levels. So we monitor weekly this blood urea nitrogen levels, and targeted fortification is based on the human milk analyzer. So we recommend so according to SPGN guidelines, they have recommended the use of multi-component fortification to increase the nutrient content, and they have recommended to start this fortification once the baby has reached 40 to 100 ml per kg, and individual fortification can also be used. But there is insufficient evidence on human milk fortification. Even the NNF guidelines have also quoted similar one, but they have used the weight cutoff of less than 1800 grams, and the enteral feed, the baby should reach at least 50 to 80 ml per kg. The WHO recommends fortification for only those babies who are not gaining weight despite adequate feeding. So once the baby is, now after fortification, the baby is gaining weight well, that is 18 gram or 20 gram per kg per day, and now baby shifted to KMC ward before discharge. So now mother is having a question whether my baby will have normal intelligence or will there be any shortcomings because of prematurity. So you see these preterm babies, they have immaturity of immune system, immaturity of skin, and also cerebral tissue, like the decrease in brain volume. They have increase in nutritional needs, decrease in astrocytes and synapses formation, and also there is immaturity of GI tract. So, and they're also prone to these morbidities like NEC, sepsis, chronic lung disease or BPD. So because of this, they have global undernutrition, which causes faltering of growth and reduction in head circumference, which in turn leads to decrease in brain volume, decreased neurogenesis, myelin production, synapse formation. So they also have specific nutrient deficiencies also, which altogether affect the neurodevelopment of the preterm baby. On the other part, the beneficial nutrients of human milk like immunoglobulins, lactoferrin, HMOs or microbiome, and lipids, these help in synaptogenesis and helps in the preterm neurodevelopment. So this breast milk has this long chain polyunsaturated fatty acids or HMO or antioxidants, which help in, there's a dose dependent reduction of BPD, NEC as well as sepsis if babies are on mother milk completely. So they have done studies to see that the first 2 weeks nutrition is very important for the long-term neurodevelopment, and these babies who went aggressively on nutrition first 2 weeks, they had better brain growth and accelerated white matter maturation after 2 years. And they have also compared at 5 years of age, and these children had better cognitive and motor outcomes, those who had exclusively mother milk fed in first 2 weeks of life. So the other supplements are the probiotics, which should be initiated as early as day 1 of life and should be continued till 36 to 37 weeks or until discharge, especially in NIC units who have high baseline incidence of NEC. And you can see that there is a reduction of late onset sepsis, mortality and NEC in these babies who are started on probiotics early in life. The other recommendation for supplements are oral iron supplementation should be started at dose of 2 to 4 mg per kg, 2 to 4 weeks of life to 12 months of age. And even vitamin D supplementation should be started at 400 to 1000 international units per day, up to 6 months of age. The SPGN also quotes the same thing. Vitamin D doses around 400 to 700 international units per kg per day, and calcium and phosphorus is around 120 to 200, and phosphorus of 75 to 100 mg per kg per day. So the take-home message is the preterm birth is a nutritional emergency, and for these babies, mother milk is best. Even though donor milk is present, but both of them need to be fortified, and faster feed advancement or higher volume or 2 to 3 hourly feed, all are safe. And to initiate colostrum administration within 4 hours of life to help these babies. Thank you.
Thank you so much, ma'am, for your insightful information. I request Dr. Swapna ma'am onto the stage. I request Dr. Srilata ma'am. Dr. Lingareddy sir onto the stage. Dr. Aparna ma'am.
Good evening, everybody. Myself, Dr. Swapna, Secretary of NNF Telangana State and also the HOD of Department of Neonatology at Nilofer Hospital. We are very thankful for all of you for coming and attending this workshop. And on behalf of the organizing committee, our special thanks to KIMS, the entire team of KIMS for coming forward and organizing this workshop. For the first time, we have KIMS Hospital has come forward to conduct in a different shape, that is recent advances in neonatology. And almost every time, Dr. Aparna Madam, our special thanks to Aparna Madam, whenever we wanted to do any program from NNF, she'll be the first to come and associate with us. Very special thanks to her, and also thanks to the entire team for organizing. I think you would have been exposed to various equipments, recent advances in various fields of ventilation, nutrition. So keep interacting them. I think you have still 6 more workstations to complete. Please come and attend the conference. We have tomorrow on Saturday and Sunday at Yashoda Hospital, iTech City. We have also IS Rao quiz on the Sunday evening. So tomorrow on both the days we have other quiz also with exciting prizes. Please come and make this event useful for you, all of us. Thank you.
Thank you, ma'am.
Thank you, Dr. Swapna, for the opportunity to do the workshop. And many thanks to our team. The workshop was possible only because of all the consultants who have all kind of gathered together, not only from Kondapur, Secunderabad, and from Gachibowli branches in Hyderabad, but we have had the neonatologists working in Guntur, from Kurnool, from Vizag, Nashik, and of course Dr. Linga Reddy and faculty outside KIMS who have always been our close associates who have also been part of the workshop. Thank you so much. I request Dr. Swapna, Dr. Srilata, and Dr. Linga Reddy sir, all of them EB members and the Secretary of NNF, to kindly give away certificates to some of the faculty whom we could not felicitate in the morning. Dr. Ridhima, Consultant Neonatologist at KIMS Cuddles, Secunderabad.
So I request all the faculty to come for the dinner tomorrow, the same venue at Yashoda Hospital.
Dr. Ridhima, Dr. Satish, Consultant Neonatologist and Pediatrician from KIMS Cuddles, Secunderabad. Dr. Maunika, Consultant Pediatric Nephrologist, KIMS Cuddles. Dr. Veena, KIMS Cuddles, Secunderabad. Dr. Aditi. Aditi. And may I request all the faculty to join us for one more group photo with our Secretary of TSNNF. May I request all the faculty, Sindhu, Maunika, Dr. Vishwa, Pranita, Dr. Seema, Dr. Navi, Dr. Mani, Dr. Sonali, Aravinda, Sonali, have actually a total of 6 workstations, but what I think we'll try and do is, I see that we have around 15 to 20 delegates left, so we'll probably divide you all into 2 groups so that So into 2 groups, we'll ask you to call out numbers 1 and 2, and probably that will help us to finish the rotations. So each rotation will comprise 3 workstations, so that the faculty will only repeat it 2 times. So one group can rotate through 3 stations here, station there on LISA, we have the next station on nitric oxide, and the third one on NIRS and AEG. We originally had 20 minutes for each station, but probably now in the interest of time, we'll try to finish one whole bunch of 3 stations in 40 to 45 minutes. The other rotation can include the other 3 workstations outside, which are therapeutic hypothermia in in one of our admin cabins inside. Then we have MRI interpretation, which will be in the VC room where you had ECMO in the morning, and the CRRT and peritoneal dialysis station in the library where you had echo in the morning. So can I request you all to, probably divide yourselves, how can we divide into 2 groups? So all the participants, can you just raise your hands? Just for one. We'll start from Surya 1. We should really thank, and that is Govardhan from Nirsivimab. Big thanks to him for being one of the sponsors for the show today. And they represent from Dr. Reddy's, and they are providing RSV immunoglobulin for preterm babies for prevention of RSV. Thank you, Govardhan, for your support. Big round of applause to you. So for our volunteers, Rohini's team, please note, group 1 will stay in the hall. In one go, they will finish LISA first, nitric oxide next, and NIRS AEG last. Time is 45 minutes jointly. Group 2 will go first to PD CRRT in library room, then VC room for MRI, and lastly TH therapeutic hypothermia in Dr. Sudhakar's room. Then they will swap. Each cycle 45 minutes, we will finish 1.5 hours from now. Thank you.
PPD in babies, but prophylactic surfactant is also given in babies of less than 26 weeks who require less than 26 weeks and less than 28 weeks who require positive pressure ventilations. These babies are chosen who requires in the delivery room baby required PPV, that baby's prophylactic surfactant is given and less than 26 weeks. Remaining everyone it's a rescue surfactant. It could be early rescue or late rescue. Early rescue is preferable. Okay, clear. So whom to give we have decided, and how to give also we decided. Next thing is how to give is we are going to give through the LISA. So what surfactant to be given next? Why? It is here. Very good. Less volume. Okay. So what is Curosur for? Sir, at theory we'll talk it later. First let's go with the procedure. So what all things required with the LISA, for LISA? Manual forceps, okay. Next. Very good, laryngoscope. As per the surfactant requirement, same thing. Glove, under strict aseptic conditions which we wear for the everything, and laryngoscope, yes. If in my unit when I gave LISA, I haven't seen LISA catheter. So I have given through OG tube. So how to give OG tube? Through OG tube. See, even though now the OG tube is preferable, including very few of our units will have this LISA cath, right, Surfacath. So in the even OG tube. So how to take a decision of OG tube? What to do prior to, like if you are heard a thing like you are getting a 30-weeker from the peripheries or 30-weeker delivery is expected, keep one OG tube, 6-number OG tube in the freezer. So how many hours priorly we should put? 2 hours. 2 hours prior to administration, put the OG tube in the refrigerator. Okay, freeze it. First thing. Okay, if you have a LISA cath, which is very good. If you don't have, OG tube is also better. Same. You can say that. Okay. Next thing is, so choosing the OG tube has been prepared, and then surfactant. So how many minutes away we can keep the surfactant outside the freezer? When to remove the surfactant from the fridge? When can we keep? Till what time? See, we can warm the surfactant in hands for about 8 minutes. Okay, keep under the room air for about 20 minutes. Okay, not more than 30 minutes. Why? Not more than 30 minutes. Why? Don't put on. This is the usual thing everyone does. Don't put under a warmer. Why? Again, why? Why? See, for anything which we need to have some reason. Otherwise, we don't remember. First of all, if there is no reason, we don't remember. So don't keep under the warmer. Don't shake the surfactant. First of all, either warm it under your palms or keep in the room air for about 20 minutes. Why? If you keep more than 30 minutes, the viscosity of the surfactant will increase. So the thick it will become like. So when you are giving the surfactant, either it will be regurgitated, it will be tough to give it. So the viscosity will be altered. So it should not be more than 30 minutes in the room air. Okay, next. So how to give?
The thing is, one more thing I would like to add to Madam's point. Whom you are not supposed to give this LISA. Basically, baby should be breathing well. If baby is not breathing well, you are not supposed to give any LISA technique. LISA technique essentially involves breathing to be there for the baby. Okay, and few institutes they administer caffeine also, basically. Okay, caffeine to make sure that baby is regularly breathing. Okay, after administration of caffeine only, LISA can be given. And one more thing I would like to add, like why did ma'am say that you need to freeze the tube? What is the importance behind that? Stiffness. Stiffness, yes. So this is something like the classes what we have learned in our earlier days, expansion of solids, liquids and gases. In that, if you freeze it, it will be stiff because most of the OG tubes, they tend to collapse and all these things will be there. So make sure that we keep the OG tube in refrigeration. Okay, and as ma'am said, surfactant should not be vigorously shaken. Okay, when you are actually warming the surfactant, you should rub against your palms, but you should not shake it up and down. Okay, as ma'am said, that will get viscosity will get denatured. Okay.
So that is how. So now we came to know what to use, whom all to be selected. So okay, and why we are not preferable like more than 34 weeks and all? Baby will be too vigorous, right? Not at all cooperate. Just imagine for intubation, do the babies cooperate? No, it will be tough for us. So to the LISA, they won't be much cooperate. So less than 34 weeks is preferable in that case. Less than 30 weeks is more preferable. And second thing is, so we have chosen the baby. Now we are prepared for the LISA, to give LISA. And For the LISA, as I told you, either OG tube or LISA catheter. So where to cut the, if you are trying to give the OG tube, where to cut? Where to cut? So the measurement is same with the ET tube, that is 6 plus weight, that doesn't change. Okay, based on that we have our own OG tube length measurements, right? 1 centimeter beyond that measurement, put a mark. Why? To guide us towards the vocal cords. So if you put a black mark or with a marker, when we are inserting, we will have that mark should cause. We are just inserting the catheter 1 centimeter below the vocal cords. That's it. Understood? Just 1 centimeter below the vocal cords. Okay, so that it will be equally distributed in both the lungs. It will not go to single lung. If you go deep or if you put up, it will not. It will be regurgitation. Surfactant will be regurgitated, or if you put too deep, it will go to a single lung ventilation. So it should be the OG tube should be as measured, 20 centimeters approximately, and 20 number approximately 1 centimeter beyond that, make a mark with black one so that it will be a guide to put on the vocal cords. Okay, then with it, so decide. Now let's start with the procedure. Can we open this? To ask. We'll open. If we ask, they'll say no. Then. See, it is stiff. You can hold and feel and see. It is stiff. Okay. So intubation to be done in the opposite side, right? So which surfactant again? Next question. Which surfactant to be used? So we can use OG tube, we can use LISA cath, or we can use 2 number ET tube also. Okay. Which number? So should we sedate the baby? Why no? Yes, we want the baby to be spontaneous breath, but we don't want baby to move also, no? Like, it should be in a balance mode. Some units, they do sedate the baby with the alloxin and all, where the spontaneous respiratory efforts are preserved. But the risk of brady and desaturations will be there. We should keep atropine ready for all the babies whoever we go to the LISA and sedation. So, naloxone. On hand, sorry. Naloxone. So based upon the tube size, it is as easy as intubation because it is very tough. I mean, it's very stiff. So it is as easy as intubation. No, they will do it. They will do by hands on. So next, which is very, very important, which is lacking in this mannequin is CPAP. Make sure that your CPAP is intact and it is fixed tightly. So it should not displaced. That is very, very important because that is only providing us to distribution of the surfactant. If the CPAP is not delivered properly, the surfactant distribution won't be clear. RAM scanner comfort levels based on the comfort levels.
Because in CPAPs, most of the times we use either Hudson's or RAMs. Because if you are using a mask type of a CPAP apparatus, that interface, that will obstruct your intubation basically. So it's better to use RAM cannula. So it serves more as like a nasal trunks only. And second thing, what all devices can be used if you are not having LISA cath? One is OG tube, ma'am has already said it. Other than that,
it is visible anyways.
16 gauge angiocath can also be used. LISA
So there are different techniques. Different methods has been used and they have given. So one of the take care method which they have used as several 16 French angiocath has been used. These are all before the Surfactant came. After Surfactant came, everyone has been replaced with this or OG tube. So in the same way, it is 8 French tube, same as intubation, just intubate. So we should start the timer on as soon as we put a laryngoscope and put a cath, and then start giving surfactant as how we give surfactant. It should be given over 30 to 60 seconds, over 1 minute duration. Previously they used to put in infusion pumps, over 1 to 3 minutes they used to give, but 30 to 60 seconds usually recommendation in all the, whatever the recommendations is around 30 to 60 seconds. Slow infusion should be given the surfactant, okay? Not a liquids, because wafer C is there, no. That is the main difference. In a liquids, we have to distribute it with the PIP. Whereas here, anyways the distribution is happening it out. That's why we are giving in a slow pattern where the distribution will be there in the equally to the all alveoli. Okay? Huh? 2 minutes up in the play. Okay, fine. Anything else to add on? Ridhima?
Neosurf or any other surfactant, the volume of the surfactant will be more. So once you try Lisa method, there will be chances of regurgitation because of the So that's why madam has less than 34 weeks, we recommend, especially less than 30 weeks, because the weight will be less, so we recommend treatment for those cases.
What are the side effects? Last one, side effect are complications.
Displacement of the tube.
Okay. Regurgitations. So if the mouth is open, the leak will be more. So that's how CPAP, how the CPAP is. When the CPAP mouth is open, the leak will be there. So in the same way, the mouth is open, the leak will be more. So the mouth has to be completely closed, as we should deliver the completely good CPAP. That is the only thing which we required for the, mainly for the Lisa. Okay. Curasurf and Neosurf or Surfactant depends on your crowd, first of all. Because if you see the cost wise, the Curasurf will cost around 18, if you take a 2 kgs baby. Around 18,000 2 vials almost, because it's 1.5 to 2.5 ml, that is 200 mg per kg. So when you see that difference also, 200 mg per kg, if you're giving a good surfactant Curasurf, you should give 200 mg per kg. That gives you a better outcome compared with the 100 mg per kg. Okay, 100 mg per kg, you can give Surfactant which contains 100 mg per kg, that is 25 mg per ml we use, but if you are giving Procant Alpha which contains 80 mg per ml, 200 mg per kg is preferable. Then only the outcome would be better. Okay.
Saline, IV set we have to correct.
Not necessary to be IV set, doctor. You can directly also push in slowly with the syringe. With the syringe. This is not rated. No, see, that is also one more important point. One of the failure of Lisa will be hypothermia.
If you are using
so
basically,
that doesn't completely mean to hypothermia. We are not inducing to the body. We are just keeping the catheter inside the mucosa. Mucosa will not get contracted with the hypothermia. So if there is a hypothermia or if CRP is more than 10,
because it is so deep,
antisteroids are less, the Lisa failure will be more. So these are the prognostic factors. If there is good surfactant, good steroid coverage, good no infectious CRP less than 10, and a good amount of 200 mg per kg of surfactant.
Wherever your vocal cuts are there you will try to introduce.
If there is no hypothermia, the prognosis will be
insertion also. Most of the books what they say is lesser
the
gestation
definitely cut shell. How we list to 30
the
centimeters,
length
30 centimeters
below
list. Then we can
vocal
say
cord should be
with that only we can cut it.
taking a less than
And
28
then
week
stitches.
baby, the
That's why we
insertion
have to
depth
stiff
post
it,
vocal cord should
refrigerate
be
2 hours
1
priorly.
centimeter. Okay.
And
And 28
actually it is a measures question we have a list 30
it
centimeters
should be
and 31
1.5
and we have that list that we can same thing.
2 centimeters.
అది కట్ చేసుకోవడం అందుకే మార్కింగ్ దీంట్లో మార్కింగ్
this
ఇంపార్టెంట్
black marker.
బికాస్ 1 సెంటీమీటర్ బిలో ద vocal cord has to cross. Okay, that is regurgitate అయిపోతుంది అండ్ regurgitation number 1 if it goes to the single
have to
side also
arbitrarily go on
single lung ventilation
your
laga
insertion depth depends on that.
It is easy but start is tough. Like regurgitations, where there is enough amount of surfactant distribution under you may require second dose because the distribution won't be there, but it's around ఇది 1.5 ml or 2 ml per kg తీసుకున్నాం Procant Alpha, 2 kgs baby, 2 ml per kg will be around 4 ml. So it won't, if the regurgitation happens, if the FRC is not good, good CPAP is not there, the leak will be more.
Okay, 1.7
so that doesn't help us
almost
much more. One more dose
tube. So that way you can use this comfortably.
This is 5 centimeters, 10 centimeters and 15 centimeters and 20 centimeters. That is why we even, I say that 20 centimeters agar mark chesukovali, 1 centimeters below you need to have black marker.
Coffee is
same with the magle forceps you use, which is less. Yes, Sama. Here it's there. See, 5, 10, 15. From here, they have already measured and they have kept here. This dark black is it is 15. This is 20. Just to guide. That's it. Just to guide like this. అందుకే ఇంపార్టెంట్ వెళ్తుంది చేతితో కూడా వెళ్తుంది యాక్చువల్లీ few of us will do it hand only, to be frank. It is easier also ET tube only, but మీకు మంచి కన్వీనియంట్ కావాలంటే this will give you good convenience actually. If you try once with Michael forceps, you will not use hand. This is easy, like an IV can లో పెట్టినట్టుగా ఉంటుంది, so it will be easy. ఇది కూడా 10, ఇది 10 అమ్మా, ఇది 9.
733.
We have a single 6 French tube only. Almost it fits with for all the term. We don't usually use it. Late. That also it will be tough. How can you give a 4 kg baby? Can you imagine with this kind? మీరు ఇన్ఫ్యూజన్లో ఇచ్చారా డైరెక్ట్గా ఇచ్చారు? కాదు ఇన్ఫ్యూజన్ నుంచి ఇచ్చారు, పుష్ చేస్తారు. How was the outcome? అందుకే over very slowly 30 to 60 seconds as per any guidelines, but it would be better to give it around 1 to 2 minutes. అసలు ఇనిషియల్లీ దే యూజ్ రెడ్ catheter also. మనకి రెడ్ రబ్బర్ catheter ఉండే వాళ్ళకి, సన్న రెడ్ రబ్బర్ catheter. So they use that also. They use red rubber catheter initially. Starting OG tube, red rubber catheter, angiocath. So all this they have used. So requirement of mechanical ventilation, requirement of PIP in few cases, almost 10 to 15% people may require PIP with angiocath. So then that time we need to remove and give angiocath, because they may develop with. So most of the side effects, most of the complications occur. I have done some study with near infrared rays spectroscopy, NIRS study chese. They told that most of the side effects, most of the complications of LISA is because of the laryngoscope, because it will stimulate the vocal cords, vagus and then cause bradycardia compared with the LISA. So tube kanna laryngoscope is more complicated ani direct insert like, but it is a bit of tough. Scope use chestam, forceps use cheyam. Without scope we can't see vocal cords, no re. ikkada busy ala
మీరు ట్రై చేశారా మ్యామ్ ఇక్కడ
Gachipalli we have given but one babies, 2 babies, 2 years అయింది మాది ఏం పెట్టి 2 babies, ఒక బేబీకి ఫెయిల్ అయింది, 3 babies ట్రై చేస్తే 2 babies yes సేమ్ సర్టిఫికేట్.
సెకండ్ డోస్ సర్ఫాక్టెంట్ అప్పుడు ఎట్లా ఉంది మ్యామ్ అవుట్కమ్స్? ఏమన్నా సెకండ్ డోస్ రిక్వైర్మెంట్ ఉంది?
లీసాకి లేకుండా సార్, వీ హ్యావ్ గివెన్ అరౌండ్ 29 వీకర్ బేబీకి ఇచ్చాం. సెకండ్ డోస్
సార్ యువరాజ్ హూ ఇస్ ఎక్స్ప్లెయిన్, మీరు ఎక్స్ప్లెయిన్ కొద్దిగా ఇక్కడ యూషేప్ చేస్తే కొద్దిగా ఎవరు కనబడుతుంది,
మీ పక్కకు వచ్చేస్తా సరే. వాళ్ళది ఈజీగా ఉంది, మీదే ఈజీ ఆపరేటింగ్.
జస్ట్ ఒకటే కనెక్షన్ రెడీ స్టార్ట్ చేసి
ప్రైస్ డబల్ అయిపోతుంది.
నో సార్, మీకు ప్రైస్ కూడా ఏంటంటే దీంట్లో మీకు రీఫిల్లింగ్ వచ్చి క్యాలిబ్రేషన్స్ అన్నీ రెగ్యులర్గా ఉండేది. దీంట్లో ఏంటంటే మీకు రీఫిల్లింగ్ ఒక సిలిండర్ మీకు దగ్గర 16,000 దాకా పడుతుంది. దీంట్లో మీకు 65,000 రూపీస్. That we are claiming on 80 ppm. So if you are calculating with 20 ppm, then 1000 will go to the 1200, almost nearby. So మీరు 1200 ఒకవేళ చేసుకున్నా కానీ ఒక కేస్ మీరు ఒకవేళ 3 days 4 days దాకా యూజ్ చేస్తున్నా కానీ ఆల్మోస్ట్ యూ కెన్ ఈజీలీ యూ కెన్ డూ మోర్ దెన్ లైక్ 15 cases దాకా యూజ్ చేసుకోవచ్చు.
దాని తర్వాత ఏం చేయాలి?
We need to replace this film.
How much it cost?
Sir, this cost you 65,000 rupees.
అక్కడికే వస్తుంది కదా?
లేదు సార్,
cylinder filling will cost around 30,000. What I know is
One time.
8,000, 8 to 10,000. 8 to
10, 10 15,000, 10, 15,000
10,000
like.
to the
Students waiting for students.
They are here only. You can all bring your cups of tea, the delegates, and just come in because they have already moved to their second table. So we'll have to keep time.
You have to throw it out if you doesn't
Please come
use it
closer.
within 1 month or 3 months.
This validity will be for 45.
Subbarati and Maitri and
రేపు మనం యూజ్ చేయకపోతే వేస్ట్ అయిపోతుంది.
16,000 మళ్ళీ
ఇట్లా చేయాలి జీరో క్యాలిక్యులేషన్. ఎవరెవరు యూజ్ చేశారు నైట్రిక్? ఎనీ ఆఫ్ యూ యూస్డ్? విచ్ వన్ యూ యూస్డ్? Inosis.
How many of you are using Geonaut? You are using Geonaut.
You work here?
Okay. So
this is the same brand but different
settings
model,
are
I
also
think.
almost same. So it will be similar to Geonaut. Okay. This is a nitric oxide delivery system. Penelope from Sol group of industries. Sol is the company name. Okay. Indications for INO, criteria, everything we have learned in theory sessions, right? What are the indications for INO?
Oxygen index more than 20. More than 20. And
OI
severe
more than
PPHN and any pulmonary hemorrhage or meconium aspiration syndrome leading to severe CPHN.
Criteria to meet.
Like which babies can you use?
Which babies you can use,
The
which
PAH is
babies you
there?
cannot use. Less than 34 weeks, you cannot use. Baby should be more than 34 weeks, and echo should be done ideally, and congenital heart disease should be rolled out.
Showing we can use in the
If you don't have access to echo mission, then you can start the therapy based on OI. Or if PaO2 is less than 60, even with 100% FiO2 also, you can start the therapy. Okay, and not indicated in TAPVC. Okay. How do you start the INO therapy? For starting INO therapy, you will follow rule of 20. Okay, it will be given in standard books also, rule of 20. So OI should be more than 20, and the starting dose is 20 ppm. And one more 20 is response. So there should be increase in PaO2 by 20 mm of Hg within what period? Again 20. Okay, within 20 minutes, PaO2 should increase by 20 mm of Hg. Okay, so we'll first learn about the connections. This mission will have two connections. Okay, one is INO dosing pipe, and another one is sampling cable. Okay, so through the dosing pipe, mission will deliver nitric oxide to the baby, to the ventilator circuit. Okay, ideally dosing pipe should be connected before the humidifier. Okay, so that the gases mixing will happen better in the humidifier. Ideally should be connected like that, but lack of this connecting pieces and all, we will connect. It's not available, but ideally it should be connected before the humidifier. And sampling tube, it should be connected as close to the TPs as possible. Okay, both should be connected to the inspiratory limb only. Okay, this is sampling tube. Through the dosing tube, you will give INO to into the circuits. Okay, through this sampling tube, you will collect the some part of the gases in the tube, and the mission will analyze the concentration of nitric oxide and any other toxic metabolites.
That's the role of a flow sensor. You know, it detects how much you are giving.
Just like to know how much nitrogen you are giving, nitric oxide. Okay. So So
that will give these three readings, NO, NO2 and O2 percentage. These three readings will come from that sample.
three sensors will be there. Okay. This is the extra tubing in this machine only. They are telling it's flow sensor to know the flow, ventilator flow. Okay. These uses will come to know. Okay. Next, how to start the NO.
Problems we'll have with this water trap, the water trap.
Troubleshooting. So we all know dose should be 20 ppm. You should start the therapy with 20 ppm, not more than 20 ppm. So how to start 20 ppm? Here calculator will be there. Let's assume ventilator flow is 10 liters per minute and the required dose is 10 ppm. Okay, you can increase 20 ppm. Okay, so roughly it will give the value how much flow you should keep. Here it is 204. So here you will have flow meters along with control knob. So using this control knob, you can see here how much flow you are giving. 200. Or roughly you can start with 200 ml per minute.
So oxygen flow is set.
No, oxygen, everything will be taken care by ventilator only.
Nitrous oxide will be
Only nitric oxide will be delivered with this machine. Here, forget about this part. Okay, that will confuse you. So, oxygen, you will not use this machine to deliver oxygen. Only ventilator only you will use. Okay. No other machine will have this setting. Don't look at that. Okay. So once you start 200 ml per minute flow, you should wait for some time. Minimum 5 to 10 minutes it will take to show the reading, how much ppm you are giving. Because nitric oxide should flow through this tubing, through the ventilator tubings, and it should come back through the sampling tube, and then it should analyze. That's why it will take some time, 5 to 10 minutes. After that only you titrate. Understand? So when will you stop nitric oxide? Immediately or
Rule of 60.
Rule of 60. If the baby is not responding or worsening, you can. If the baby is worsening, you can stop immediately. Otherwise, you will slowly taper. When will you start tapering? Using rule of 60. What is rule of 60? FiO2 less than 60.
AO2 more than 60.
With less than 60% FiO2, that should be maintained for a minimum of 60 minutes. After that only you will start tapering nitric oxide. So first thing to taper is FiO2 in the ventilator. After coming to 60% only you will touch the nitric oxide. Till then you won't touch the nitric oxide. Okay. So tapering same way. You will calculate the flow and titrate based on the readings. Okay. Coming to troubleshooting, most of the time you will get a common alarm like sampling tube is blocked. Okay, so sampling tube is connected after the humidifier. So most of the time the decondensated water will be blocking the tube. So make sure it is cleaned properly, and here water tap is there. It will collect the water, but sometimes this tube is very small caliber tube. You can see here. Okay, so most of the time it will be blocked. So you can use another tube or clear it.
It will be getting wet, right? It is a humidified air that is coming through it. So some condensation will happen in this and it might get blocked. So then you will get a sampling error. Then you will have to either change this one or see if the water is full here. All those troubleshooting you have to do. Nitric oxide. NO2.
Another metabolic product is nitrogen dioxide. So it is a toxic gas. The concentration should not increase more than 1 ppm. If it is increasing more than 1 ppm, either decrease the nitric oxide dose, or if it is very high, you can stop the therapy. Okay, alarm should be 1 ppm. In pediatric group, we can go to 2 ppm also. Neonates, it's 1 ppm. Okay. Methemoglobinemia, actually it should be monitored if you are using more than 40 ppm of nitric oxide only. Routine monitoring is not required. But if you clinically suspect that the baby may have methemoglobinemia, then you can monitor. Otherwise, no need to do routinely. Okay. More than 40, 60, that will be done during studies only, not for clinical use. Okay. Never go more than 20 ppm. The minimum distance should be the dosing line and sampling line. Minimum distance should be 30 centimeters.
It should be checked. Give that to me.
So here, this is dosing line. Nitrogen will come into the circuit through this line, and this is sampling line. Okay. Mission will collect the sample of the ventilatory gas and assess the doses. So this distance should be minimum of 30 minutes. More than 30 minutes.
30 centimeters.
30 centimeters, sorry. 30 centimeters.
Do you have any doubts? It's very, very simple machine to use. Just two connections you need to know, the calibration you need to know, NO2 you need to know. Yeah. This is only a rough guide for you, but once you start it, you adjust here. See, we got 204 now, you try it for 200 and wait for some time, 5-10 minutes. You will reach a number here. If it's slightly more, reduce it, slightly less, increase it. It takes time to adjust. But to start with, you need some rough guide that will help you.
This is an advanced machine. You no need to titrate. You can just set the ppm whatever you want by clicking the automatic dosage. You can click the 20 ppm and you start the dosage. This flow sensor will take care of its cost because
This is the extra benefit they have.
Yeah, but this is a differential flow sensor. Yeah, this machine is costing triple that machine. So it's coming around 50 lakhs. So this will take care of the part. This will synchronize with the ventilator.
Naveen.
Whenever the people it will take this flow sensor will take care of the spots and it will deliver the ppm what you have set continuously. Papering also you don't need to titrate. You just click. If you want 19, you can click 19. Manually, yeah, automatically.
So one is for it's like fine tuning, and here you can see 10 to 120 only, flow of 10 to 120 ml per minute. Here if you want to go more above that flow, that
ఆన్ చేయగానే ఫస్ట్ ఇది స్టార్ట్ అయిపోతుంది ఒకటి ఎండ్ అయిపోయాక ఇంకోటి స్టార్ట్ అవుతుంది.
Once you come down on the dose, you have to titrate 10 ml also. For that it will be
హౌ మచ్ టైం లెఫ్ట్ అంతా ఇక్కడ వస్తూ ఉంటుంది. 20 ppm you have to set.
Automatically it adjusts the flow. It will
జస్ట్ ఈ డయల్ అడ్జస్ట్మెంట్స్తో చేస్తూ ఉంటాం అక్కడ జీనాక్స్లో. జస్ట్ కీప్ ఇంక్రీజింగ్ అండ్ డిక్రీజింగ్ అండ్ సీ ద నంబర్ హియర్. వీళ్ళు చెప్పేది ఏమంటే ఇది కొత్త దీంట్లో ఈ ఫెసిలిటీ ఉంది అంటున్నారు.
how much అంటే ఇది ఎలా పెట్టాలి, like it should be turned on completely or what?
నవీన్
స్టార్టింగ్ 200
ఎట్లా ఆన్ చేసి పెట్టాలి స్టార్టింగ్?
ఈ మెషిన్లో ఎక్స్ట్రా బెనిఫిట్ ఏంటి దీనివల్ల?
This is a fully automatic machine, ma'am. So you have seen Geonox, no, or another machine. You need to do the titration. If you want to achieve 20 ppm, you need to adjust this flow. But here, this is connected with the ventilator flow sensor. We can directly give the dose. You can see automatic mode. Click it.
Madam's question is,
Yeah.
I want to adjust. How do I do?
That's why I'm showing you. So once you click this, click. You want 20 ppm. Keep 20. Give it OK. The machine will automatically deliver 20 ppm.
Okay, so we need not touch that.
We don't touch this one.
No need.
So then why is even it can be given?
This is for emergency mode, ma'am. Whenever this automatic mode failed, it will automatically switch to manual mode. So at that time, to taper it, that thing will work.
So we have both manual mode and manual mode.
Yes.
So they have doubled price itself. Double price, huh?
Basically, it's for only demo purpose.
Yeah, this is a demo machine. Right now, AIG is using this machine here. AIG is.
This one takes from the air end. You don't need cylinder.
So, ma'am, this is a cylinderless technology. So, actually, we have a cartridge inside the machine. This cartridge. So, the life of the cartridge is 1000 running hours. So, after that, we need to replace it.
Cylinder dependency లేదు, మనీ సేవింగ్ కంటే కూడా సిలిండర్ డిపెండెన్సీ లేదు.
We'll set the PPM. We'll set the PPM.
Filters అవన్నీ
అదొకటి స్పేర్ ఒకటి పెట్టుకోవాలి, ఒక స్పేర్ పెట్టుకోవాలి సడన్గా చెడిపోయినా.
This one in the aromatic is there on the upper aroma. This will be connected to the humidifier chamber, inspiratory lip, and this will be connected to the Y-piece of a baby. This is the sampling taking one, and this sampling will be shown here. So just we need to give a start. That's it. So once we give a start, this generates a high voltage of electricity. So then all the gases are formed with the help of this filter. The NO2 will be eradicated and only NO will be taken and delivered to the baby.
You won't have problems with high NO2 here.
Sorry, sir?
You won't have problems with high NO2 in this machine.
No. No NO2 will be detected, sir. Because this is normally in industrial cylinder. So in that you will be having a NO2. So appudu meer akkada calculations kani anni kuda chesukovalsi vastadi. So sometimes if NO reading is more, you have to reduce the PPM of NO.
Yeah.
Otherwise you have to shut down the, sometimes even you have to shut down the therapy also. But in this machine there is no increasing of NO2. Only NO will be delivered. And the purity which is delivering to the baby, that we can show you with analyzer also. It is not with this, but we can show you with analyzer, because most of you will be having a doubt whether it is delivering a NO2. It is already continuously monitoring the NO and NO2. The sensors are already we are having a sensors also, NO and NO2 sensor also. They are already exposed to the system, so it will monitor there also, and it is calibrated with the cylinder only. So it has to maintain the integrity and the purity. And then afterwards, you can see the independent gas analyzer from state-of-the-art company.
What?
That whatever the claim on the machine is similar as the analyzer, with the uncertainty of
What problems can we have with this?
With this?
Troubleshooting problems.
Troubleshooting, sir. Sir, easy make to 60,000. 60. Total unit costing 30 lakhs. 30. No. లేదు madam. This one will be not delivering to the towards the venti, right?
Measure how much
and
you are
this
giving.
is delivering to the baby side.
No. This is giving nitric. That is measuring nitric. How much you are giving.
వెంటిలేటర్ గ్యాసెస్ మిక్స్ అవుతుంది కదా.
దీంట్లో లాగానే ఇక్కడ 2 ఉన్నాయి కదా, ఇక్కడ 2 లైక్ ఫ్లో సెన్స్.
దీంట్లో ఏంటంటే మేడం ఈజీ ఫర్ ట్రాన్స్పోర్టేషన్ ఒకటి ఉంటుంది. నెక్స్ట్ వన్ నో హెడేక్ ఆఫ్ రీఫిల్లింగ్ ఆఫ్ దిస్ థింగ్. నార్మల్ సిలిండర్ ఏంటంటే మీకు నైట్ టైంలో ఒకవేళ అయిపోయినా కానీ ఇబ్బందిగా ఉంటుంది. సో కనెక్షన్ టైంలో నో ఆఫ్ క్యాలిబ్రేషన్. So yearly once we need a calibration for this machine, that we do from our engineer will come to your on-site and we will do the calibration.
The troubleshooting ఏమేమి రావచ్చు?
Sir, troubleshooting ఇప్పటి వరకు అయితే ఇక్కడ కూడా రాలేదు.
ఎంత ఆటోమేటిక్ ఉంటే అంత ప్రాబ్లమ్స్ వస్తాయి.
లేదు సార్,
అది మాన్యువల్ తగ్గిపోయింది. సో ఇప్పుడు అంతా ఆటోమేటిక్ ఉంది కదా సిస్టమ్, ప్రాబ్లమ్స్ ఎక్కడ రావచ్చు?
అదే సార్ నేను చెప్పేది. అంటే ఇప్పటి వరకు మేము చూస్తున్న దాంట్లో కూడా ఆల్మోస్ట్ 8 months నుంచి we have done more than even if I take the other hospitals, so like Ranchilo, doctor are use చేస్తున్నారు. They have done more than 1,000 hours. Till now, no troubleshooting that we got. 16,000.
15,000.
So ఒక పేషెంట్కి సపోజ్ 5 days పడుతుంది
మోస్ట్ ఆఫ్ ద టైమ్స్ 5 days వాడితే కూడా అయిపోదు, బికాస్ యూ స్టార్ట్ వీనింగ్ కదా. 20 మీద పెట్టాం, సెకండ్ డే థర్డ్ డే నుంచి వీనింగ్ స్టార్ట్ చేస్తే వస్తుంది. 2 patients or 1.5 patient వరకు అయితే వాడచ్చు. ఐ థింక్ మోర్ దెన్ ద కాస్ట్ ఇట్స్ ద కంఫర్ట్. సిలిండర్ అయిపోయింది తెచ్చుకోవాలి, సిలిండర్ అయిపోయింది.
ఆల్మోస్ట్ ఇఫ్ యూ ఆర్ యూజింగ్ లైక్ 3 days మీరు ఏదైతే అన్నారో, ఒకవేళ దాన్ని మనం క్యాల్కులేట్ చేసుకుంటే can do more than 12 patients easily.
40 days average వస్తుంది.
Sorry sir?
40 days.
ఇక్కడ పిక్చర్ ఉంది చూడు, ఇక్కడ పిక్చర్ ఉంది.
So
you are connecting the machine just after humidifier up. From there it comes to the baby. Again another your measuring.
సార్ ఇది ఒకటి హ్యూమిడిఫైర్ మేడం, ఇది కనెక్ట్ చేస్తున్నారు హ్యూమిడిఫైర్కి, అండ్ ఇది ఒకటి మీకు బేబీ సైడ్ కనెక్ట్ చేస్తున్నారు. బేబీ సైడ్
పెట్టలేదు బొమ్మలో.
ఇది ఇక్కడ నుంచి ఇటు పైకి ఆరో, ఇది పైకి ఒకటి కిందకి ఒకటి.
జస్ట్ ఈ హబ్ ముందు పెడతారేమో ఇక్కడ.
రైట్ అంతే సార్.
కనెక్ట్ చేసి చూపించండి ఆ మెషిన్.
సరే మ్యామ్,
కనెక్టెడ్ టు దిస్ ట్యూబింగ్.
నేను ఇప్పుడే కనెక్ట్ చేస్తాను. ఓకే. సో ఇది వచ్చేసి మేడం ఇక్కడ కనెక్ట్ చేస్తున్నాను ఇన్స్పిరేటర్. రైట్
కరెక్ట్
కరెక్ట్ అది ఏది ఎక్కడైనా కనెక్ట్ చేయొచ్చండి, లేదా మారిపోతుంది?
ఇన్స్పిరేటర్
ఇందులో ఎవరు తెలిసిన
ఇది సపరేట్ వేరే ఉంటుంది సార్. ఇది
కలర్ ఏమైనా పోటీ
కనెక్షన్ డిఫరెంట్.
అంటే మనం మర్చిపోయి అది ఇక్కడ పెట్టి
అది అలా సెట్ చేయాలి. అది అవ్వదు,
ఇక్కడ అవ్వదు,
ఇది అవ్వదు,
ఇవి ఉల్టా అయిపోతాయండి ఆ రెండు.
ఇది మీకు ఇది అవ్వదు సార్. ఇక్కడ హ్యూమిడిఫైర్కి ఇది కనెక్ట్ అవ్వదు.
అది ఇక్కడ వస్తుందా?
ఎస్ సార్, ఇక్కడ ఉంటుంది కదా. సో నార్మల్గా ఇది మీకు ఈ సర్క్యూట్ చిన్నగా ఉంటుంది కాబట్టి దీనికి మళ్ళీ వేరే కనెక్టర్స్ ఉంటుంది నార్మల్గా. సో ఇలాంటి కనెక్టర్స్ కావచ్చు, ఇంకా చిన్నవి కూడా ఉంటుంది. వీ హ్యావింగ్ అడాప్టర్స్ కదా. సో ఆ అడాప్టర్స్ తోటి మీరు ఇది కనెక్ట్ చేసేసుకొని ఇది కనెక్ట్ చేస్తున్నారు.
అది బిగ్ ప్రాబ్లం అవుతుంది కదా, అది వెతుక్కోవడం. మేము నైట్రిక్ పెట్టినప్పుడల్లా ఇవి వెతుక్కోవడం చావాలా. ఇది వెతికి ఇవి రెండు కావాలి కదా, ఒకటి దొరుకుతుంది ఒకటి దొరకదు, దొరికింది ఫిట్ కాదు.
ఇప్పుడు ఇది మీకు సపరేట్ మళ్ళీ టైం నేను చేస్తాను.
మీరు అది ఫిట్ చేసి చూపించండి.
అది రా.
సో ఇది ఇప్పుడు మీకు అసలు లూస్ ఉంది.
అదే అది ఎట్లా ఫిట్ చేయాలి?
ఎస్. సో ఈ రెండింటి మధ్యన ఇది ఏదైతే కనెక్ట్ చేస్తున్నామో ఇక్కడ, ఈ రెండింటికి అడాప్టర్ వస్తుంది.
అది ఎక్కడ
రబ్బరీ అడాప్టర్ వస్తుంది. నార్మల్గా మీకు బబుల్ సీట్ అవి రబ్బర్ అడాప్టర్స్ ఉంటుంది. సో మీకు ఏం లీకేజ్ అవ్వకుండా. సో ఆ అడాప్టర్స్ ఇక్కడ పెట్టేసుకుంటున్నాను.
అవి మీరు సప్లై చేస్తారా?
వీ కెన్ గివ్ యూ సార్, నో ఇష్యూస్. అది
చిన్న స్పేర్ పడుతుంది మొత్తం మెషిన్ ఆగి.
నో ఇష్యూస్, వీ విల్ గివ్ యూ దాట్, నో ఇష్యూస్. సో ఇది ఇలా కనెక్ట్ చేసేసుకొని యూస్ చేసుకుంటారు. అండ్ ఫ్రమ్ హియర్ ద శాంప్లింగ్ విల్ బి టేకెన్ అండ్ విల్ బి మెన్షన్. సో మీకు ఏంటంటే కనెక్షన్స్లో ఈజీగా ఉంటుంది. ఈవెన్ ఒక్కసారి సో మీకు పర్సెంటేజ్ అంటే ఈ ఫిల్టర్ అయిపోయిందా లేదా, మరి ఎన్నో సెన్సర్ అండ్ ఎన్నో సెన్సర్ అయిపోయిందా లేదా అనేది చూపించుకోవడానికి ఇక్కడ మీకు ఫిల్టర్ 69% అని చూపిస్తుంది. 69% ఇస్ లెఫ్ట్, ఇస్ రిమైనింగ్ వాస్ ఆల్రెడీ కన్సిడర్డ్. సో ఈ 69 కాస్త 10 వచ్చింది అనుకోండి, దిస్ ఇండికేషన్ విల్ టర్న్ టు రెడ్. సో ఆన్ కాల్ మీరు మాకు ఇన్ఫార్మ్ చేసిన బికాస్ మీరు సమ్ టైమ్స్ మేబీ ఇట్ టేక్స్ 1 year టు కంప్లీట్ దిస్, 1.5 year అవుతుంది. అప్పటి వరకు మీరు అది తీసుకొని మీ దగ్గర పెట్టేసుకుంటే దాంట్లో ఏమి.
వాట్ అబౌట్ ది సెన్సర్స్?
సెన్సర్స్ లైఫ్ ఈస్ 4000 రన్నింగ్ అవర్స్.
ఏది సెన్సర్? లాక్
బ్యాక్ సైడ్ ఉంటుంది, బట్ దిస్ విల్ బి లాక్డ్.
హౌ మచ్ దే కాస్ట్?
సేమ్ ప్రైస్,
60,000.
మీ దాంట్లో లేవు అట్లా సెన్సర్స్?
అది మీకు
This is not our kind of sensor.
95. We are using NSS. దాంట్లో కూడా సెన్సర్ ఉంది. యాక్చువల్ చేంజ్ దట్ ఈస్ 1 lakh అలా ఉంది.
ఇది ఎప్పుడు మార్చాల్సి
దిస్ ఇస్
వస్తుంది?
ద రీయూజబుల్ వన్ సార్. ఇది మీకు రీయూజబుల్ లేదు, మీకు ఒకవేళ కావాలనుకుంటే మీరు ఈటీఓ చేసుకొని యూజ్ చేసుకోవచ్చు. దిస్ ఇస్ రీయూజబుల్ సర్క్యూట్.
బట్ హౌ ఆఫెన్ డు వి నీడ్ టు రీప్లేస్ ఇట్? అంటే ఎన్ని రోజులకు చెడిపోవచ్చు?
సార్ మ్యాక్సిమం దే హ్యావ్ డన్ ఫర్ 7 to 8 బేబీస్. దాని తర్వాత రిప్లేస్ చేస్తున్నారు. దీని కాస్ట్ కూడా మీకు అరౌండ్ 3,000 to 4,000 రూపీస్.
మన ఫ్లో సెన్సర్స్ కొంటున్నట్టు 5,000-6,000.
ఎస్, ఇవి రెండు ట్విన్ సెన్సర్స్. ఇవి రెండు మీకు కంబైన్డ్ సెన్సర్, అంటే సపరేట్ అంటే ఒకటే సెన్సర్.
అంటే ఓకే, అంటే ఒక 4 సెషన్స్ యూజ్ చేశాను. ఓకే, 4 days 1000 hours అంటే
40 days. Near to 43 days.
43 days. Average 4 days and 10 patients.
10 patients.
10 patients కోసారి సెన్సార్ మార్చండి.
సెన్సార్ అవసరం
లోపల
ఇది మార్చాలి. 10 పేషెంట్స్కి ఒకసారి మారుస్తున్నారు. 10 అంటే 11 పేషెంట్స్ అనుకోండి. మీరు 20 ppm యూజ్ చేస్తున్నారు కాబట్టి 11 to 12 పేషెంట్స్ వస్తున్నారు. అంటే 12 యావరేజ్ తీసుకున్నా కానీ 12 మెంబర్స్ 12 బేబీస్కి ఒకసారి తీసేస్తే మీరు 60,000 రూపీస్కి ఒకసారి చేంజ్ చేస్తారు. అదే మీరు ఒకసారి సిలిండర్ని క్యాల్కులేట్ చేస్తున్నట్టయితే ఒక సిలిండర్ మీకు 15,000 15,000
మేడంకి సార్ సార్ మేడం అక్కడ good afternoon everyone. I am Dr. Vishwanath and madam is Dr. Veena. Both are consultant at KIMS. So this station will be in this station we'll be discussing about amplitude EEG and NIRS. Okay, for I think first 7-8 minutes we'll discuss amplitude EEG and then we'll shift to NIRS. So here you can see all the display screens. This is from NATO's, okay, a cerebral function monitor, and this is from VNG, and this is Elmica. Okay, so all three displays, if you see, the majority of the parameters are same. So here, for example, the gray. So the top one you can see, this is 2-channel tracing. Okay, here if you see there are 2 lines. So this is 2-channel tracing, and here it is the right side and the left side. Sorry, left side and the right side. Okay, this is what we called as trace, and on the y-axis you can see the microvolts amplitude 0, 5, 10, 25 and 100, and this is a time where 6 small boxes, like you can see white lines here, 1, 2, 3, 4, 5, 6. So 6 box constitutes 1 hour. Okay, and yeah, so the trace you can see, this is the lower border and this is the upper border. Okay, so here if you see the lower border is somewhere around 5 microvolts and the upper border is between 10 and 25 microvolts. Okay, so it is a continuous normal voltage. Okay, so this is a background trace. So interpreting amplitude EEG, you have to first see how is the background trace. So the background trace here is continuous. So when do you say it is discontinuous? You have to see where is the lower margin. If the lower margin is less than 5, then it is a discontinuous normal voltage. Okay, and continuous low voltage means when the lower margin is roughly around 0 to 2, okay, and the upper margin is below 5. So that is a continuous low voltage. You have that pattern. So I'll come to that. First we'll just finish the background activity. But this is, so interpreting amplitude EEG, you see first background pattern, then sleep wake cycle and presence of seizures. So in background pattern, you have continuous, you have discontinuous normal, you have continuous low voltage, you have burst, and you have isoelectric or flat trace. So continuous discontinuous is based on lower margin. Okay, continuous low voltage is both lower margin at 0 and upper margin less than 5. Burst would be
this is burst,
this is continuous low voltage. Burst, if you see, the lower margin is around 0 and the upper margin is going above around 25. Okay, so it is burst. Okay, above 25, and sometimes it goes up to 100 also. Okay, and based on number of bursts in a time frame in 1 hour, you have to label it as either plus or minus. So more than 100 spikes in an hour, it will be burst plus, and less than 100 spikes will be burst minus. Okay, and then isoelectric flat is this one here, you see, no activity. In continuous low voltage, there may be some spikes, but in isoelectric and flat rays there is no spike at all. Okay, so this is the background pattern. Now when you see second parameter, which is the sleep wake cycle, as madam was asking, so here you see as the neonate goes from one phase of quiet sleep to deep sleep and then awake, the lower border of the trace will have a sinusoidal pattern. You can just show. You see the lower border, here it is touching 5 and then it is going up and then it is again coming back to 5. So you will have a, in certain areas you will have a broader trace, in certain area you will have a narrow trace. Okay, so it means the neonate is having sleep wake cycle and it is a favorable outcome. Okay, it will have a favorable outcome. So this is sleep wake cycle. But if you see the sleep wake cycle maturity depends on the gestational age. So preterm neonates will have predominantly discontinuous and the sleep wake cycle will not be that well formed. Okay, like you will have in a trace at 20 centimeters will have at least 3 or 4 of sinusoidal wave pattern. Okay, that will be in term, but in preterm it won't be like this. Okay, hardly you can see 2 or 3 sinusoidal pattern in 20 centimeters trace. Okay, and then the third parameter is the detection of seizures. So seizures, as you can see, very typical. Here you can see, if I can just point here, you see there is abrupt rise in the lower margin and the upper margin. Here you can see both lower margin and the upper margin there is a rise, which is followed by again coming back to the baseline. Okay, so this is a seizure, the upper margin touching almost 100 here microvolts.
So
yeah,
this
is like a status epilepticus.
6 blocks is for 1 hour.
For 1
so,
hour,
So child had these many episodes of seizure.
Yeah.
So if child is having continuous seizure, so will it be above only?
Yeah, you will have multiple. If it will be more compact if there are repetitive seizures or status epilepticus. This much broad you won't see. It will be very narrow, and you will see multiple spikes. We have anything. I can show you if.
We also have this.
Yeah, I had put.
Because we stimulated for a higher number. This one
See, like this. Here the spikes are less than 100 in a 1 hour time frame. It will look like this. If it is more than 100, it will be completely. You won't see any gaps.
Okay, but
baseline
will not raise up.
Baseline.
If it is a seizure, baseline will
Baseline will go up, ma'am, and then it will come down immediately, and then the next seizure will start. So it will look like this.
Because
very
congestion,
compact,
you will not
very
see the
compact.
baseline very clearly. More
That
number
is
of
why
seizures
raw
will have to be
EEG
more
is more
congested.
important
Ah.
than seizure.
So for the seizures, no, we will have the repeated EEG.
So once you see this, then you have to corroborate with the lower raw EEGs. Okay. Why? Because up to 100 and sometimes beyond 100 also. Okay. 25 to 100 and even beyond 100. So if you see here, this is on a semi-logarithmic scale, less than 10 microvolts. And this is a linear scale. Okay. This is more than 10 microvolts and this is less than 10 microvolts, which is represented on a linear scale. So if you see the spike here, you can see the raw EEG will also, there will be a spike. Do we have?
So this above one is not a seizure, below one is the seizure we triggered over here. Here you can see the repeated pattern.
Here you see. Now, just put a normal this thing. Wait.
Normal pattern.
So this is like a pointer. If you touch here, it will show what was the corresponding raw EEG. Okay. So here you can see it is going up to probably suppose 5, 10, 15, around 15 it was going. Okay, which is okay. But if you see seizures, you see it is.
This is the line for that one.
This is the line for this one, no?
Yeah.
So you see it is going beyond 20. Okay. So corresponding raw EEGs, why is it not coming here?
No,
Because
we
we have,
adjust, if you adjust,
okay.
it will come like this. It will above one, the below one going above, no?
Right, okay. So this is the corresponding Caesar, raw EEG.
I'll just play that once.
Yeah, just play it so we'll get it. Here you can see some spikes are going above 100 like this.
So it will show whenever there is a lower basis merging up, no? That time you can see the spikes are going
Spikes are going up.
So that's it. The baby is having a right side seizures more. You can see it's called status.
So because here the left side it is more like here also discontinuous normal voltage it is without
baby is
sleep
having
wake
a
cycle.
right side
So seizures.
in the mouth.
So then you have to clinically imply it like what would be the cause. There can be a hemorrhage if it is a preterm baby, or even focal seizures will have unilateral involvement. So now next thing, you are clear with this now, understood? So now coming to technical aspects, so we have this is hydrogel electrodes, this is gold cup electrodes, and one more where is needle. This is needle. It is slightly invasive. You have to insert into the scalp. Okay. So beneath the skin. So here you see two channels. So usually we use C3 P3 and C4 P4. Okay. Even number for the right side and odd number for the left side would be somewhere here.
So this is basically a measuring scale for this particular plan. So what we do, you can see a ear tragus in the below. Above is the sagittal suture. So there is some markings over here. So both the side has an alphabet A, B, C, D, and Th. A, B, C, D, and Th is there. And we have a midpoint. So what do? We place it on a baby's ear tragus. This is ear tragus. We will have a sagittal suture over here. What we do, we match some letter over here, alphabet, and we match the same letter. Here you can see the sagittal suture is coming on D. So we adjust bit. So this is our midpoint where we position the electrode. This is central and this is parietal. So what we do, we mark it on both the sides and we position our electrodes, stick the electrodes on the body. So this we repeat on that side also, so that is our marking portion. I mean electrode position for that.
Width is this one.
Madam?
Width.
Yeah, width is the same. Yeah, this is the width. Yeah, that is the width.
This is same applicable for that electrodes also?
Yeah, the same thing. So we have different two types of scales. If the baby cell is small, then you can use this one, or small also you can use. So this is about the electrode positioning. We have three types of electrode as Sarah was mentioning. A cup electrode also you can use, that is a reusable one. And this one is a hydrogel electrode, which is for this particular electrode, if you are placing, you have to remove the hair so that the sensitivity will be attaching too much.
So one entity is called as impedance here.
Yeah.
Can you just show that?
This is the impedance.
Here you will have impedance. So here you can see all the 4 electrodes. Once impedance is high, based on which electrode impedance is high, this will light up.
Highlight up.
Green indicates there is no resistance. Yellow indicates there is some resistance. And if it turns red, then there's a very high impedance. Either issue with the baby or baby skin, or issue with the electrode itself. I mean, it's a reusable, then you have to change it. Or you have to check the connection to decrease the impedance. Impedance should be green, and after using for some time you can accept impedance till yellow. Okay. But red impedance we should not accept. It will interfere with the monitoring. Time up. Oh. Quickly we'll see NIRS. Come. So NIRS we have 2 devices here. One is oxyprem and one is Medtronic. So the principle all of you understood. It is based on the differential absorption of oxy and deoxyhemoglobin. Okay. So site you choose either cerebrum or your splanchnic or renal or any other peripheral tissue you can choose. Okay. So here the sensors. This oxyprem has this sensor and Meditronics has this sensor. So you can see what I was telling, that there is something called a light emitting diode, and then there is one proximal detector and the distal detector. Okay, this detects from superficial, this detects from both superficial and deep. And the differential absorption of oxy and deoxy will result in your regional saturation. So there are age-specific regional saturation cutoffs that you can see later on. It's a theoretical. So here, this you can place it on the cerebrum. You can either place on the one side, or you can use two sensors placed on both the sides. And splanchnic we put on epigastrium, and renal also we can put. So they have something called as two sensors can be used at a time. Okay, so both sides can also be used. So if you come to the display, both display more or less it's same. So here you see percentage saturation you can see. Okay, percentage I mean after entering the patient data, age and all, you will have this screen, right? So percentage saturation you can see, and then you have to enter the gestational age specific regional saturation like 55, 60. For cerebrum it is around 65, 70. You put it that, and then this yellow line will move to that cutoff. Okay, and then if you monitor it continuously, it will vary. Can you show? Can you connect and show? Just put it on hand and. Yeah, take it. I think see, the saturation now is 70, but cutoff we have kept is around 22, right? So that is the difference between pulse oximetry and your regional saturation. Yeah. So for peripheral tissues also it is around 65 to 70 only. So it is expressed as percentage. So you have what else? So I mean there is other Massimo is also there, and there are some other many are there where the time spent below the cutoff, like for example in preterm neonates we are more concerned with feed intolerance. Suppose for a 30 weeker we kept a regional cutoff of 65. So we'll get an estimate that in last 4 hours how much the neonate spent below the cutoff. Like in last 4 hours, if the majority of the time baby had spent below the cutoff, so then we have to anticipate that there may be feed intolerance, and then you can skip 1 or 2 feeds. So that way it can be useful. And in neonates with HIE, especially term neonates, initial few hours after birth asphyxia, it was seen that the regional saturations were very high. It means that the brain is not utilizing oxygen. Okay, so that's why bone.
It's not like directly the cerebral one.
No, this will be like cerebral regional saturation only of the cortex only. It will show.
The
So
sensor
initial
can detect up to a depth of 2.5 to 3
around 2
mm.
Okay.
So it can penetrate.
Yeah, it will penetrate. And then for initial few hours it was seen that brain, since there was a hypoxia, brain could not utilize any of the oxygen. So the regional saturation will be more. And as the blood supply and secondary energy failure sets in, the regional saturations come down. So too much of studies are going on this NIRS. Okay. So this is basic NIRS. Okay. అర్థమైందా?
క్లినికల్గా ఇంటర్ప్రిటేట్ చేసి మనం ఏం చేస్తాం?
అదే చెప్తున్నా కదా, క్లినికల్ అప్లికేషన్ ఏంటి అంటే సపోజ్ ఇప్పుడు టర్మ్ బేబీ డి నాట్ క్రై ఆఫ్టర్ బర్త్, HI moderate or severe ఉంది. So apart from now if you want to start therapeutic hypothermia, now we have objective cutoffs like pH, base excess, clinical staging, moderate or severe encephalopathy, then we start this thing. Now to prognosticate, we have to do MRI. Prognostications we have only based on MRI. Now, amplitude EEG is also a prognostic marker. so around 6 hours or 36 hours. If you see some sleep-wake cycles appearing, there are no seizures, there is continuous normal voltage, so it is a good prognosis. So beyond 36-48 hours, if the baby does not have sleep-wake cycle or there are continuous seizures, it indicates a poor prognosis. You don't have to wait till day 4, day 5 for MRI confirmation. The same thing with NIRS also. Like for initial few hours, if your regional saturations are quite high, okay, then it is a poor marker. Okay, same thing in preterm neonates also who have IVH and white matter injury, who have higher regional saturation, they have poor neurodevelopmental outcome later. Higher means, because higher means it is a weighted, predominantly it's venules. Okay, it is a combine of vein, artery and capillaries, but predominantly 70 to 85% it is of vein. So it means the tissue is not utilizing oxygen, it is coming directly into the, veins. So higher regional saturation means tissue tissue is not utilizing the oxygen. Okay. No, adult and pediatric are using a lot in our
ECUs, so during
cardiovascular
surgeries,
surgeries. They are using left, right and center for fluid guidance, for acute decompensation. Intra-op monitoring is very, yes. So intra-op, it's NIRS is mandatory for them. Okay. So based on the NIRS cutoff, they give bolus, they titrate inotropes. Ivi probes, just size difference untadi ante, but monitor will be more or less same only. Okay. Cost, I think you can ask people only.
5.5 lakhs, around 6 lakhs.
Yeah, they want technical specification and cost, it seems. You can. Yeah, now that's why this workshop, so that people start using NIRS and amplitude EEG. Yeah, it has to be kept because now amplitude EEG is one of the very early marker to prognosticate. You can tell the family that baby has a good prognosis. Yeah. NIRS is still in early stage, but amplitude EEG it's quite advanced now. Rainbow, I'm not sure. In Rainbow, are they using it? They are using. In a month, we receive around 4 to 5. 4 to 5 moderate to severe encephalopathy. We start therapeutic cooling in those babies. See, HI means there is some mild HI, moderate and severe. If you are asking about all the HI, then I think 8 to 10 we receive. Probably in that 4 to 5 are mild and rest 4 to 5 are moderate and severe. Around 4 in a month we keep, yeah. This month we had, I think, 4 or 5 babies we kept.
HI is it?
Yeah.
Is there a concern like HI?
Okay.
Wireless him.
bladder injury. అవి అవుతున్నాయి అంటే బవల్ పర్ఫరేషన్ అయిందంటే యూ సీ ద ఫీకల్ మ్యాటర్ ఇన్ టు ద పెరిటోనియల్ fluid or leaky diarrhea is also there, that you should evaluate. Bladder leak అయ్యి urine mix అయిందనుకో, how will we know? We will not know kada. So what do? We do serum creatinine and urinary creatinine anamata. I mean abdominal fluid creatinine and urinary creatinine. So if both are matching, it means it is urinary leak. That is how we see. Edi, but creatinine will be the same kada, dilution kada, serum creatinine kada ade. అది బ్లడ్ కాదు కదా డైల్యూట్ అవ్వడానికి, ఇట్ ఇస్ క్రియాటినిన్, ఇట్ విల్ నాట్ గెట్ డైల్యూటెడ్. ఏది? అవును, యూరిన్ మిక్స్ అవుతుంది. సో అప్పుడు ఏం చేయాలంటే మీరు పెరిటోనియల్ ఫ్లూయిడ్ అంతా బయటికి తీసేయాలి. వాట్ ఎవర్ ఇస్ లీకింగ్, వాట్ ఈస్ ద న్యూ ఫార్మేషన్ లిక్విడ్ ఇస్ హ్యాపెనింగ్, దట్ యూ షుడ్ సెండ్ ఇట్ ఫర్ క్రియాటినిన్. ఇన్ స్టాప్ చేయండి. ఇన్ స్టాప్ చేసి అప్పుడు ఏదైతే న్యూ లీక్ అవుతుంది అంటే ఇట్ ఈస్ బీన్ లీకింగ్ అన్నట్టు కదా. సో సమ్ పూల్ ఆఫ్ యూరిన్ విల్ బీ ఫార్మ్డ్ కదా, అప్పుడు యూ సెండ్ దట్ అండ్ యూరిన్. ఓకే, సో ఇది ప్రిజ్మాఫ్లెక్స్ మెషిన్ అనమాట. సో ఇది సిఆర్ఆర్టీ మెషిన్. దిస్ డస్ నాట్ రిక్వైర్ ఎనీ ఆర్ఓ, డైరెక్ట్గా మనం ప్లగిన్కి కనెక్ట్ చేసుకుని వీ కెన్ యూజ్ ఇట్. సో హియర్ యూ హ్యావ్, దిస్ ఇస్ ద ఫిల్టర్ సెట్. ఈ ట్యూబింగ్స్ అన్నీ కలిపి ఈ ఫిల్టర్లో సెట్ లాగానే వస్తాయి అన్నమాట. ఈ ట్యూబింగ్స్ అన్నీ కలిపి ఈ ఫిల్టర్లో యూ గెట్ ఇట్ యాజ్ అ సెట్. ఓకే, యూ విల్ లైక్ ఐహెచ్డీలో ఏమవుతుంది, యూ హ్యావ్ డయాలసెట్ సపరేట్లీ, యూ హ్యావ్ ట్యూబింగ్ సపరేట్లీ, బట్ ఇన్ సిఆర్ఆర్టీ ఇట్ ఈస్ నాట్ లైక్ దట్. యూ హ్యావ్ వన్ సర్కిట్ విచ్ యూ కనెక్ట్ from here to here. There it is only one circuit anamata, closed circuit antam dini. Okay na, these are four scales. This is for the effluent, that is what is coming out of the patient. This is pre blood pump. Okay, replacement fluid lo మనం చెప్పిన pre blood pump. ఇదేమో డయాలసేట్ ఏదైతే ఇస్తున్నామో, ఇదేమో పోస్ట్ పంప్. దీంట్లో we should choose a desired bag and hang it depending on our clinical case scenario. Sorry, సో క్లినికల్ కేస్ సినారియో బట్టి మన బ్యాగ్ ఏది కావాలి అని చూడాలి. సో యూ వాంట్ పొటాషియం, జీరో పొటాషియం, లాక్టేట్ ఫ్రీ, బైకార్బోనేట్ బ్యాగ్, అది కావాలా, లేకపోతే లాక్టేట్ ఉన్నా పర్వాలేదు, పొటాషియం ఉన్నా పర్వాలేదు, దాన్ని బట్టి వీ సీ ద చూస్ ద బ్యాగ్ అండ్ వీ సెలెక్ట్ ఇట్ అండ్ వీ హ్యాంగ్ ఇట్ హియర్. వీటికి తగ్గ పంప్సే ఈ 4 విచ్ ఆర్ రన్నింగ్ అనమాట. దెన్ దీస్ ఆర్ ప్రెషర్ పోర్ట్స్, సారీ దీస్ 3 ఆర్ ప్రెషర్ పోర్ట్స్. దిస్ ఇస్ ద ఎయిర్ చేంబర్ అనమాట, ఏరేషన్ చేంబర్. సో అలార్మ్ సిస్టమ్ సర్క్యూట్లో ఎక్కడైనా మనకి ఎయిర్ ఉన్నా, బ్లాక్ ఉన్నా, రెసిస్టెన్స్ టు ద ఫ్లో ఉన్నా, ఇట్ విల్ గివ్ అస్ ద అలార్మ్. దాన్ని బట్టి వీ షుడ్ డూ ద మోడిఫికేషన్స్. సో ఒక్కసారి సర్క్యూట్ క్లాట్ అయిందంటే యూ హ్యావ్ టు రిమూవ్ ద హోల్ సర్క్యూట్ అండ్ రీప్లేస్ ద న్యూ సర్క్యూట్, న్యూ సెట్. ఓకే, అండ్ దిస్ ఇస్ ద హెపారిన్ పంప్. సో ఇఫ్ యూ ఆర్ గివింగ్ హెపారిన్, వీ కనెక్ట్, వీ డైల్యూట్ ద హెపారిన్ అండ్ కీప్ ఇట్ హియర్. ఇఫ్ యూ వాంట్ టు డూ హెపారిన్ ఫ్రీ ఆర్ సిట్రేట్, సిట్రేట్లో కూడా మనకి ఇక్కడ ఆప్షన్ ఉంది. ఇది సిట్రేట్ కూడా వాడుకోవచ్చు యాంటీకోయాగులేట్ కింద. Sometimes we use heparin free, citrate free, that is normal saline flushes ఏ ఇస్తాం అనమాట. సో ఇక్కడ మనం సెట్ చేసుకోవాలి ఎంత, హౌ మచ్ యూ వాంట్ టు గివ్, హౌ మచ్ heparin do you want to give అనేది కూడా ఎవ్రీథింగ్ విల్ బీ సెట్ ఇన్ టు ద ప్రిస్క్రిప్షన్. సో దిస్ ఇస్ ద బ్లడ్ ఫ్లో, బ్లడ్ పంప్ అనమాట. సో 3 to 5 ml per kg is what we routinely start with depending on the hemodynamics of the child. Child is on severe inotropic support, then we start at the very minimal values of 3 ml per kg per minute, or the minimal in the system is 25 వరకు you can go down ml per minute. సో దాని తర్వాత ప్రీ బ్లడ్ పంప్, ఐ టోల్ యూ రీప్లేస్మెంట్లో ప్రీ బ్లడ్ పంప్ అండ్ పోస్ట్ బ్లడ్ పంప్ ఉంటుంది. సో టోటల్ ఎఫ్లూయెంట్ వాల్యూమ్ని మనం 2:1గా డివైడ్ చేస్తాము. 2 times ఇస్ రీప్లేస్మెంట్, 1 type ఇస్ డయాలిసిస్ అనమాట, డయాలిసిస్. సో ఏదైతే ఈ రీప్లేస్మెంట్ ఉంటుందో అది 85% ప్రీ పంప్, 15% పోస్ట్ పంప్గా డివైడ్ చేసుకుంటాం అనమాట. సో దట్ ఈస్ హౌ వీ యాడ్ ప్రీ పంప్, డయాలిసిస్ అండ్ రీప్లేస్మెంట్ ఫ్లూయిడ్. Then patient fluid removal is nothing but the ultrafiltration. How much water, how much fluid you want to remove. So all together is the effluent volume. So in this patient the effluent volume is 132 ml per effluent volume is 132 ml per hour. Effluent dose is only 3 ml per kg per hour. It is 50 kg child. But normally we start is 20 to 40 ml per kg per hour is our calculation anamata. We just kept the volumes anamata, just to keep it running. And filtration fraction is very important. Filtration fraction is the solute clearance. How much solute we are clearing is the filtration fraction, it should be less than 21%. Lesser the filtration fraction, more efficiently we are doing the clearance anede that meaning anamata. So these are the pressure systems. So access outflow manaki problem undi, filter దగ్గర మనకి ప్రెషర్ ప్రాబ్లం ఉంది, ఎఫ్లూయెంట్ రిమూవల్ పేషెంట్ ఫ్లూయిడ్ రిమూవల్లో మనకి ప్రాబ్లం ఉంది, ఐ మీన్ ప్రెషర్ ఇస్ మోర్, రెసిస్టెన్స్ ఇస్ దేర్, రిటర్న్ దట్ ఈస్ త్రూ ద ఫిల్టర్ అవుట్ పంప్ ఈస్ మనకి రెసిస్టెన్స్ ఉంది అంటే వీ సీ ద ప్రెషర్స్ హియర్ అండ్ దాన్ని బట్టి వీ విల్ సీ అంటే క్లాట్ అవుతుందా అవ్వబోతుందా, ఈజ్ ఇట్ అబౌట్ టు గెట్ క్లాటెడ్ ఆర్ ఈజ్ ఇట్ clotted, do we have to change the set, what is the efficacy anedi we will know by this, where is the issue anedi we will know by this. And because we are in the ICUs, they are always air conditioned, so to warm the blood going to the patient, we put the into the patient tube into this tubings so that it becomes warmer when it goes into the patient. Hypothermia adi prevent cheyadaniki. Okay na? So these are the bags anamata which I was talking about, kinda connect chestamani cheppam kada. So this is Prismasol and this is Bifazole. Prismasol is lactate based potassium free bag. Bifazole is also having it is having bicarbonate, ronditlo they have bicarbonate, but this is little lesser bicarbonate and but 4 potassium and lactate free. Okay, and this one we use it with citrate base. Citrate to manam vaadinappudu we use Bifazole because citrate also gets converted into bicarbonate, and bicarbonate is, that is why we use little lesser bicarbonate bag in this. Okay na, these are the bags, depending on the clinical case scenario we attach it into the system. And idi filter anamata, HF20 set ani ikkada rasundi, alaga we have M60, M100, M150 also. Depending on the body surface area, you always choose a lesser surface area filter anamata. You can see this is a neonatal filter, whole system circuit is there here. Okay na, అయిపోయింది 2 minutes. Okay, this is the 6.5 French dialysis catheter anamata. Central line pettinattu pettali, IJV lo gaani femoral lo gaani, depending on the age of the baby, diameter, mari total ga manam vein occlude cheyakunda chuskoవాలి anamata. Adi doubts in this? లేదండి, అది 4008 మెషిన్ ఉంటుంది అనమాట, అది వాడతాం, IHDకి వాడే మెషిన్ని వాడతాం. యా
plasma exchange. Yeah. So here what will happen in this, these two fluids will not be there. In this we will add the replacement solution like
FFPs or albumin.
Albumin we can give. So the total kit will be different. Whereas the as ma'am said 4000 AS, that is a open procedure. This is a complete closed procedure. And here we can find out the exact volume how much we are removing. There we need to calculate ourselves.
Manual calculation and manual filter, manual tubings అన్ని మాన్యువల్గా చేసుకోవాలి, ఇది క్లోజ్ సర్క్యూట్ ఉంటుంది. బట్ వీ యూజ్ 4008. ఎంత సర్క్యూట్ కాస్ట్ ఎంత అవుతుంది అది? 20,000. ఓకే. సో సమ్ టైమ్స్ వీ కెన్ యాడ్ ఆ బ్యాగ్స్లో ప్రకారం, సపోజ్ ఇట్ ఈస్ పొటాషియం ఫ్రీ K0 వాడుతున్నాము, డిపెండింగ్ ఆన్ ద సీరం పొటాషియం ఇంటూ ద బ్యాగ్స్ ఓన్లీ వీ కెన్ యూజ్ ద KCl వీ కెన్ యాడ్ ఇంటూ ద బ్యాగ్. ఇది potassium free. There are different bags also in the market. Our potassium levels batti we choose the bag. Surface area, body surface area batti. But in pediatrics, body surface area only we use. No, neonatal only one, F20, HF20. Then we have M60, 0.6, M100, 0.1, M150, 0.9, M100 is, 150 is 1.5. Auxiliaries is there, one more filter, that is mostly for sepsis, severe sepsis, cytokine clearance better ga untundi anamata. But adi kuda 1.5 body surface area. So body surface, what is the whole point is the circuit volume will change. How much blood you are able to take from the patient without disturbing the hemodynamics. Yes.
Which can remove cytokine, endotoxin, and you can do the CRR.
Usually we run it for 72 hours. That is the best time we get best clearance anamata. After that, even if it is running, we let it run, but best clearance is for 72 hours. Or in case if the it gets clotted, we will put a new set and we continue. But 72 hours is the best clearance rate.
Where? Which institute? Okay. Okay. So you're aspiring to be a neonatologist. इधर है ना? इधर है ना? Yeah, yeah. Under me, if somebody else is coming, or else if you want, I'll start. Yeah, fine. Okay, fine. So I think I'll quickly take. I have 15 minutes for this. So I won't go into the indications of, as a neonatologist, why MRI is so important is you need to interpret your own MRIs, because often GCMS, TMS, genetics will all take a lot of time, and MRI is an instant diagnosis. You can diagnose more than 100 neonatal metabolic disorders just from MRI. So we'll just touch on the basic sequences. So I won't go into the details of indications, contraindications. So before you interpret, make sure you know the clinical context, identify all the sequences and cuts. We'll also look into what are the sequences currently available and what are the basic sequences, and formulate a hypothesis accordingly. So if you have, and again in the pediatric setup, if you're suspecting an infection, do add contrast in the first visit to the MRI. So it should never happen that patient is shifted to the MRI, comes back and then sent again to the contrast. In the very first sitting, you do mention if you're suspecting an infection, add contrast right away. Especially in other adult pediatric conditions like demyelinations also, you need to add contrast. Focal seizures, you need to know inflammatory granuloma, most of them are contrast enhancing. You do add contrast in specific situation. So coming to, this is the main context for this MRI in neonates. So we have invulnerabilities of metabolism can be classified into two, small molecule and large molecule. Small molecule are micromolecular, they usually present in the first year of life. 95% of them present in the first year of life, especially organic acidemias, amino acidopathies, and mitochondrial disorders. All these present in the first few months of life when feed is introduced. So in this situation, the GCMS, TMS will take 5 to 6 days, and whole exome sequencing, even if you get a rapid, will take 12 days or 2 weeks. In that case, MRI will cleanse the diagnosis, and immediately you can change the diet or stop the feeds, or you can start special feed, and that will actually help a major difference in the outcomes of the patient. So I'll quickly go into the sequences. So this is just a picture to show how important the MRI is to see at the parenchymal resolution. On the right side, this is the MRI, and when compared to CT, CT is like you have only basic information. You look at bleeds, calcifications, and just cerebral edema, midline shift, obvious things. But MRI, it will give you a parenchymal resolution of a high depth. So these are must know. These are your fundamentals. You have to know this very well so that you'll understand other sequences well. So you have primarily 3 sequences: T1, T2, and flare. So how do you remember? T1 is basically called as anatomical sequence. So anatomical sequence, gray matter will look gray, white matter will look white. So I can't put the arrow. Can you see the arrow? Okay, anyway, on the left side if you see the white matter inside, so frontal white matter, occipital white matter, the white matter actually is looking white. When compared to the T2, it's opposite. But if you see how to identify T2 is basically ventricles, learn to identify the ventricles. Ventricles, frontal horn, occipital horn, they are white. So the mnemonic is ventricles will look white in T2. That's like World War II is the mnemonic. And flare is opposite of T1. See, there will be confusion because water is black in T1 and flare. So if your white matter is white, grey matter is grey, it is T1 because it is anatomical sequence. Flare will be opposite to T1. Okay. And these are the ఇది arrow mark రావట్లేదండి, you disconnect అయిందా mouse, or give me a laser. Okay, so these are the most important structures you have to know. Without this, interpreting an MRI will be impossible. So these are the major important parts you have to know. If you see the sky blue one, that is one of the most important white matter bundle, which is called the genu of corpus callosum. And if you see the pink one in the below, that's called the splenium of corpus callosum, orange or pinkish down. Okay, yeah. And the green structure is almost to say that is the most important. In the aroma రావట్లేదు దీంట్లో టచ్ ప్యానల్ రిక్వైర్డ్ అని వచ్చాను. స్లైడ్ వస్తుంది, అరోమా రావట్లేదు. లేజర్ ఇచ్చండి ఎక్కడ ఇంతకుముందు వచ్చింది. లేజర్ ఇవ్వండి, టైం లేదు, పాయింటర్ ఇవ్వండి. Okay, so the orange is splenium of corpus callosum, and what you see in the green structure is thalamus. So identify these structures, and the maroon one is caudate nucleus, and the blue one is putamen. So combinedly, putamen, caudate nucleus, and thalamus, with these identification of these organs, I think you can have at least 200 signs in neurometabolic. I'm not kidding, more than 200 signs. Because why is it so important is like these are highly metabolically active. For example, if there's a power cut in a state, the cities will be more affected than villages. Obviously, they utilize more power. In the same way, these are the deep nuclear structures are very highly dense in nuclei, so metabolically very active. So if there is a hypoxia or hypoglycemia or metabolic decompensation, these are the first parts which will be involved. So that is also a sign. Okay. So this one I was talking about, no? The point in here. Okay, never mind. So thalamus, bilateral thalamus, not only neonates in children also. ANIC is one condition, acute necrotizing encephalitis. In Leigh disease, mitochondrial cytopathy, thalamus will be affected. Organic acidemias, caudate nucleus and putamen will be the primary involvement. So these are the most important things. And the white matter, the upper white matter is called the frontal white matter, the posterior white matter is called the occipital white matter. So this is a picture again to differentiate the importance of CT and MRI. On the left side if you see CT, this child has, okay, the primary difference is you don't use the term densities in MRI. So in MRI you use the term intensities, hyperdensity and hypointensity. In CT you use the term hypodensity and hyperdensity. So in this if you see, and the left is right, if you see this is the, in a picture of MRI, that side is the left side, this side is the right side. So this child had right-sided MCA infarct. So that is MCA territory. So an MCA infarct will look like a hypodensity in the CT and compared to hyperintensity in MRI. Okay, what is that sequence? Is it T1, T2 or flare? On the right side picture. Why is it T2? Water is white, ventricles are white, so it's definitely T2. So if you see, there is an infarct which is taking up the hyperintensity. So why was flare invented? So in 1990s and 1980s when MRI was first invented, T1 and T2 were the only sequences. So then they thought, if you see, the ventricle is white, and beside that the hyperintensity is also white. So sometimes the periventricular structures can be not clearly seen because of the bright ventricle density. So that's why they thought they would subtract the ventricular intensities. So that came flare. If you see, the periventricular structures are so clearly seen in flare because the CSF intensity is reduced. So that's the advantage. So whatever looks clear on T2 looks much clearer on flare. So that's nothing but T2 shine through. This is again flare picture. So this is again important. Why is basically when the MRI came in the first 10-15 years, couple of 1 decade, these were the only sequences. If you remember in adults, thrombus, when there's a thrombus, the ideal time to do thrombolysis is within 6 hours, the golden period of thrombolysis. But MRI changes in flare and T2 will take at least 8 hours. So the golden time is over. In children, so they present late. For example, if the adult is coming to with stroke, we do an MRI. MRI is normal. We don't have evidence of stroke. So that's when they thought that we should do something else. We need to find a sequence which will pick up early. So then that came diffusion restriction. This is, I think, the most important sequence for any intensivist. So these two sequences need to be interpreted together. On the left side, this is called diffusion weighted imaging. On the right side, it's called ADC, apparent diffusion quotient. So both of them need to be interpreted together. So whatever appears bright on DWI should appear dark on ADC. So how do you pronounce it? I mean, how do you report it? You say that there's a hyperintensity on DWI with corresponding changes of low intensity on ADC. That's how you describe it. So why is it so important is the technology is different. The DWI basically detects the Brownian motion of the molecules of the water inside the cell. For example, if something happens, if ischemia happens, for example, this child has MC infarct. Suddenly there is a blood cut off. Ischemia is there. So cellular failure happens and the motion inside the molecules inside the cell stop. So that will be picked up as high signal. Not only ischemia, stroke, metabolic disorders, hypoglycemia, all of them acute changes will have bright picture. Very important. And the same territory will be dark on ADC. So that confirms that there is an acute ischemia. So this also tells you, for example, this event has happened recently or old. For example, somebody has recurrent stroke. For example, Moya syndrome is that you have recurrent strokes. If you do an MRI, some patients will have old infarcts and also new infarct which happen. New infarcts will have diffusion restriction. This will also tell you the timing of insult. Even in hypoxia, in hypoxic ischemic encephalopathy in babies, the ideal time to do MRI is day 4. Okay, day 4 because T2 and flare findings will also get very evident. But if you want, you can do it in day 1 also. Diffusion restriction will be there. So that's why, for example, if you're thinking hypoxia versus a metabolic disorder, you don't have to wait till day 4. You get on the day 1 itself if you're suspecting MSUD. Because earlier you diagnose, stop early free. Important is SWI. This is SWI sequencing. This is called susceptibility weighting imaging, SWI. So not all MRI machines will have this. Most good centers will have this. This is an additional sequence. Some people do it by default, but some people you have to specifically mention. This is called SWI. Or some people also call this GRE, gradient imaging. Yeah, so this will basically pick up beats and there will be a loss of signal. So that signal void which you see black color, that is a microbleed. So it will detect any paramagnetic substances. Oh God. Okay, so paramagnet in the sense iron, magnesium, manganese, copper. Even if you see Wilson's disease also SWI imaging will have bilateral deep nuclei involvement. So if you see MSUD, why is it so important in MRI? For example, if you see the typical picture of an MSUD, the baby will have normal perinatal transition. There will be history of autosomal recessive, consanguinity, 3rd degree consanguinity, all that will be there. On day 1, the baby will be fine. There will be a normal perinatal transition. And all of a sudden on day 3, when you start the feed, when you're about to shift the patient to the mother side, the child will have sudden metabolic decomposition, poor feeding, acidosis, and may have seizures on day 3. So at that time, if you send GCMS, TMS, it will take at least 5 hours, 5 days. And GCMS, TMS and exome sequencing will also take time. So at that time, baseline workup like ammonia lactate, ABG, VBG, and MRI will cleanse the diagnosis to even start the treatment. What is the characteristic feature of MSUD on MRI? Is there any clinical clues of MSUD? Okay, actually that is only theoretical, I think. I have never seen anybody. I have had many. I had the cases. It's there. 15. We had 15 case series of MSUD. The tomcat urine. All these are. But it's very weird that MSUD patient, the urine smell like socks to me. They have a typical maple syrup is supposed to smell sweet, or that was pungent odor. So I don't know. By smell we can't diagnose. Any other clues? So in the neonatal period, it's well and good if you at least diagnose what type of disorder you're dealing with. For example, baseline workup like ammonia, lactate, ketones. Then you can see if there is higher ammonia and with acidosis, without hypoglycemia, with hypoglycemia, with ketone bodies, without ketone bodies, you'll come to a small group of narrow down disorders. And in maple syrup urine disease, you have typical history like this, and you have this boxing type of seizures. They're called boxing seizures. They'll have cyclical movements which look like seizures. Sometimes they can be missed. If you do an EEG, you'll find the answer. So one more thing, we have seen various sequences, but we'll also see what are the other cuts. So normal sequences, what we see, these are all axial sequences. It's like cutting the onion in different slices at different levels. But if you see, this is the sagittal section. So sagittal section is very, very important to see corpus callosum. You see corpus callosum, there are more than 100 genetic syndromes which have abnormalities in corpus callosum. So if the structure of the corpus callosum is not properly formed, it's called corpus callosum dysgenesis. It's not properly formed, it's hypoplasia. It's not completely formed, it's agenesis. Splenium deformities, genu deformities, thinned out corpus callosum, and a lot of genetic syndromes which can be diagnosed antenatally also, very clearly seen on sagittal. Apart from that, if you see the midbrain, pons and middle, the brainstem will look absolutely clear on sagittal. The structures, for example, pontocerebellar hypoplasia, pons structure is bad, pontine glioma, sagittal, look at sagittal. And one more important thing is cerebellum. Cerebellum structure is very well appreciated in sagittal. I'll show you a difference. So this is a patient of ataxia telangiectasia with significant cerebellar atrophy. On the right side, if you see in the axial image, there is prominent folia. That is seen in axial, but sometimes it can be missed, but it is very evident on sagittal. You'll have cerebellar volume loss or prominent folia, the sign of cerebellar atrophy. And again, importance of flare imaging, why is it so important? Because the periventricular structures will look very clearly. So this is one of the conditions wherein periventricular structures are clearly seen on flares on dorsal fingers in multiple sclerosis. The periventricular structures will look very bright. So always flare is important to look at periventricular structures. In neonates, periventricular ooze, especially with hydrocephalus, look at flare. The moment you have flare, hyperintensities in the periventricular region, that means the child needs BP shunt. Okay, because there is periventricular ooze, interstitial edema. And introducing one more sequence, this is called the coronal sequence. So this is a very few conditions wherein you have to specifically look at coronal sequences, because if you see the medial temporal lobe is one of the structures wherein you have some pathology like medial temporal lobe sclerosis, some autoimmune limbic encephalitis. Yeah, they'll have temporal seizures. Coronal imaging is a best sequence to look at medial temporal lobe. Apart from that, all other structures are like, other sequences are preferred. This is only for that epilepsy. So this is one of the patients with medial temporal lobe sclerosis. If you see the temporal lobe is hyperintense on flare. I won't go into this is called functional MRI. We use rarely in epilepsy cases. This is called, no. So basically epilepsy protocol is different. Epilepsy protocol does not include this. So epilepsy protocol in pediatrics is not mandatory. Okay. So if you are suspecting few conditions like focal cortical dysplasia is like you need very thin slices to look at dysgeuria. But normal neurocysticercosis, tumors, hyperintensities, PVL changes, we don't need epilepsy protocol. Epilepsy protocol is thin slices, you only need in few conditions. But if your center has epilepsy protocol, if it has, send for it. But don't specifically tell them to go look for epilepsy protocol. It's not needed. If it's needed, you can do. Routinely, epilepsy protocol will not include this. This is functional MRI. Only few centers have it. Yeah, that is, no, temporal lobe, coronal section is there in all MRIs. You don't have to mention. So these are basic. All MRIs by default, they have to give coronal. Coronal, sagittal and axial. Okay. This is a new imaging, it's called DTI, diffusion tensor imaging. It's also used for epilepsies and other myelination disorders. I won't go into detail. I think one thing I want to emphasize for you on neonatologists, MR spectro is very important. There are more than 30 important peaks which you can see on MR spectro. So this is nothing but, I call it a non-invasive biopsy. You are not even going inside, but you know what is inside that particular lesion. So this is a normal peak. If you see, choline is the smallest peak, and after that you have creatinine and then you have Na. This is called the Hunter's line. So any discrepancies in this, it's abnormal. And not only this, you have other metabolites like, what is a metabolite which is deposited in maple syrup urine disease? Maple syrup is what? You have branch chain dehydrogenase deficiency, Yeah, so you'll have deposition of valine isoleucine. So there's specific peaks of valine isoleucine in metabolic MR spectrum. So when you are suspecting MSUD, do an MRI. MRI will have a classical picture. I'll show you the picture. It's called myelin splitting edema. You'll have the early myelinating structures will have diffusion restriction, along with MR spectro showing elevated levels of leucine isoleucine peak. MR spectro is very important. Not only that, lot of mitochondrial disorders which present early on with seizures, refractory in neonate will have lactate peak. MR spectro again is very important. So this is one of the pediatric conditions where you have lipid peak. Lipid peak indicates there is tuberculoma. So that is how you differentiate between neurocystic cirrhosis and tuberculoma. Yes. Okay, these are the various metabolites wherein we can be detected on MR spectro. I won't go into the details of MR angio. These are the various territories. I'll quickly show you MSUD. Anybody, what is this? What is the structure which is involved? Okay, identify the sequence on the left. Yeah, thalamus, perfect. Sequence T1, T2 flare. Okay, why do you say T1?
Water, fluid.
Fluid is black. So it can be T1 or flare. So what is it on the left side? See, the moment you see water white, it's T2. Water black, T1 or flare. Then you see anatomical. If the gray matter is gray, yeah, this is flare. Because the white matter is dark, no? Simple, no? So white matter is white, dark, and gray matter is gray, then it's T1. So this is flare. So again, flare showing thalamic. Anything abnormal in thalamus? Yeah, they're swollen, no? Yes. Very badly swollen, hyperintense. This is ANIC, acute necrotizing encephalopathy of childhood. You have double donut sign. So again, okay, this. Yeah, which part of corpuscle? Splenium. So there are a few viral infections which have hyperintensity in splenium. This is called, yeah, JE thalamus. JE and dengue will affect thalamus, but few viruses which have splenium, EBV, mycoplasma, this is called MERS, mild encephalitis with restricted diffusion of splenium. So again, this is one of the cases with temporal lobe involvement. Which virus affects temporal lobe? You see the left, yeah, left temporal lobe is the herpes simplex. Bilateral temporal lobes, again herpes is one of the DDs, and also limbic encephalitis. Autoimmune encephalitis will have bilateral limbic involvement. Okay, I'll just show you one. Okay, this is typical picture of MSUD. This is called the myelin splitting edema. So at birth you have early myelinating structures. In that you have that upper U is there, no? That is called the plic, posterior limb of internal capsule. The entire thalamus is hyperintense, along with occipital radiations. And if you see up that picture, C and B, the brainstem is involved, midbrain is involved, cerebellum is involved. So these are all early myelinating structures. All of them are involved in MSUD. So that's what we call myelin splitting edema. Wherever myelin is there, you'll have a diffusion restriction there. A very characteristic picture. There is no other diagnosis from this MR. It's typical MSUD. These are multiple tuberculomas. I think that will be enough. These are various metabolic conditions. So I was talking about, okay, this one I think you need to, anything abnormal in the second B picture? B. Anything abnormal? Yes. It looks very bright, no? Something looking very bright. Basal ganglion involvement, putamen and yeah, caudate and bilateral symmetry. Whenever you have symmetric bilateral basal ganglion node, it's always metabolic. Say viruses will not go symmetrical. Bilateral symmetrical is always metabolic. So this is a Leigh syndrome. Okay, very characteristic picture. And this one, this is a neonate. Can you identify this structure? This is called, this is not putamen, this is inner to putamen. Okay, and exactly, GP. So where do you have GP involvement in neonate? Correct, connectors. So it's called bind now. So these are the various grades of bind. So more the severity, the thicker and the clearer the picture of GP. Okay, I think these are leukodystrophies. This is tigroid appearance, MLD. I think I won't go into the details of this. Okay, thank you. Yeah, so no. In neonates, the first 1 week the kidneys are immature. The contrast is controversial. Yeah, plain MRI with MR spectrum if you're suspecting metabolic. And after 1 week of life, if you are suspecting a strong infection is there, you can do contrast. You need to document KFTs before that.
So in pediatric age group, what are the indications of plain MRI?
No, by default, anything if you're suspecting unprovoked seizures, ICSOL, raised ICP, all of them will need plain only. Only demyelinations, infections, inflammatory granulomas, which are known to have contrast uptake, you do contrast. So in that cases, you send the patient to the MRI, to talk to the technician. While the MRI is being done, if MRI is normal, don't add contrast. But if you see a ring enhancing, or inflammatory granuloma or an ICSOL, a tumor, brain abscess, you ask them to do contrast. Okay.
Thank you, sir.
కరెక్ట్ టైంలో అది దీంట్లో రావట్లేదు యారో అన్నీ అవుతాయి కరెక్ట్ టైంలోనే ల్యాప్టాప్ కూడా ఆఫ్ అయిపోయింది ఓ సారీ
లైవ్లో పోయింది ఇప్పుడు వెళ్తురా ఇంకోటి ఉందా ఓకే
So total duration of therapeutic hypothermia is 72 hours and the deworming will be deworming will that it is the rate which is okay, it is 0.5 cc per hour. So it was roughly around 7 to 8 hours at the deworming phase. Normally we are keeping the temperature at 5 to 34. Okay. The normal level. So this is basically we are doing all this thing while we are giving therapeutic hypothermia. Any perinatal event asphyxia if it is happening. No need. So if any perinatal event is happening, perinatal asphyxia is happening in any newborn. So for those newborns, starting therapeutic hypothermia in less than 6 hours of life, then it will, yes, so it will slow down actually. It will slow down, it will decrease the cerebral metabolism and it will reduce the free radical injury, which is very helpful in the long term. So we are doing yes, so that also we have to monitor. ECG we have to monitor because electrolyte disturbance can be there. So that is also very important. This is vital management. How we are doing. So normal investigation will start from the CT. We have to see any thrombocytopenia there, LFT, RFT. We have to see any PTR rise is there, so that we can manage in that point also. Then we have to document neurosonogram for the baby. If any bleed is there before starting only, then we can start. So IVH is there, severe IVH, intravenous bleed there, we cannot start the application. Then we have to see if severe PPHN is there, then also we don't start this. So because complications will be more, so it should not cause the mortality in the baby. We are doing for benefit of the baby, right? So we have to take into that consideration. That is there. Then complications. If
so we go on to the basic setup of the machine. You have seen hernia. So which machine? This one we are ready. Okay. So the idea remains the same. We are going to regulate.
mattress.
Okay, this mattress has water going inside it. The machine has a tank. Okay, so whenever is giving water here, now in the container we take okay, you have to come. So this is 50%. Also, this one has okay. The idea is that this tank has to be full. So anything beyond 50. So once we are filling up the tank, after that what we do is that we go here. Okay. While emptying, you will be connecting this here, because this is the outlet, this is the inlet for the tank. Always remember that. While emptying, you can't really put it here. Now you see this 3 modes, right? So we have our servo controlled mode, which is the one which we use. So what was the plan? How much temperature, how many hours? 72 hours. Your target is between 33 to 34, right? So 33.5 is what I set here. This is the target rectal temperature. So before starting this, what are the things that we want to do in the baby? Now you have decided, you saw the criteria, right? Your baby is falling into the criteria. There is moderate encephalopathy, your blood gets fits in, then you have a perinatal event which was there, all those things. Now you decided that I am going to take on therapeutic hypothermia. So first thing is that you will be putting in line, preferably a central line should be put in, so that we have minimal interruption when the baby is on the hypothermia part. You will be, if possible, put an art line as well, so that there is a continuous monitoring. Now it will not, it will come. Okay, so that things, you will send the bloods
You'll do a neurosonogram bedside, 2D echo bedside has to be done, all the monitors, everything connected, now we are ready, okay. The first thing that you do is you put the probes. So this is your rectal probe. Rectal probe will be inserted around 2 to 2.5 centimeter inside the rectum of the baby, okay, and you fix this on the thigh. Like if this is inside the rectum, you're at the thigh, so that there is minimum of movement on the probe part, and this we are connecting on the skin. But our target is this should be 33.5, not the skin. So we do that. Right now the machine will not give your servo mode because we don't have any baby attached to the probes. But this is what we set. See, this is 36, this will be 72, right?
We are giving over 72 hours, no? That's why we have to set
This has to be very properly checked, okay? Giving wrong hypothermia is worse than not giving one. Final rectal temperature, you want it to be 37, right? And you can go on to 7 hours, because the final thing, always remember, reheating it as 0.5 degree per hour, okay? So this is all set, this is your on. Right now your machine will give you alarm because this thing is not connected. Yeah, see, it will start saying that core temperature, something is wrong. It is not going to give you. So this is like a protective thing, okay? Now I am stopping this. We can see, you saw this, once we start cooling, no, suddenly the 4th button appeared, okay? Normally we were having only 3. Now the 4th one, warming, came in, okay? So technically the machine has 4 different these things. Right now let me show you on this. This is the mattress mode, no? I wanted to see how exactly it is getting cooled. Always remember that your rewarming is more dangerous than your hypothermia. But it will still monitor. In some time, it will show you, see, it is showing how much is the core, how much is the skin, how much is the mattress temperature right now, what have we set. You can see this water thing going on. You have a manual mode, you have a servo mode. Similarly, this is there. You never use the mattress mode. We never use the manual modes when you have baby. We have knots out here, so this will be completely wrapped around the baby. Make sure that you are changing the position of the baby, just to make sure that the skin remains intact, okay?
No, sometimes it can cause the necrosis issues,
Yeah.
skin issues. So we have to keep on changing the position of the baby. So that we have to take.
The baby will only the occipital
This is
area
head,
yeah.
this is body.
Only occipital area will be touched.
So normally
No,
this is little bigger size.
In the head part.
Head part only the occipital area will be there.
Yeah.
Some of them they do this, but generally not needed. See, your total body
When
cooling.
you are covering this, no, it will also get covered automatically. When baby
But this is how the hypothermia works. Now what we have to see is there should be minimal interruption. Unless there is something, the baby is really having very severe PPHN and all those things, and generally there are no real indications where we interrupt it.
means we have to give continuous, not like we started and then abruptly we have stopped. Attendants are not willing, so we have to first,
So this
whenever
is-
we are starting, yeah, you have to take consent, you have to inform parents that this is going to be happening, complications will obviously happen, so you have to take that high risk consent also.
So now, what are the complications that we anticipate in this baby? It has to go system wise, right? So head wise, what are we thinking? What can go wrong? Seizures can happen. Seizures can happen because of your perinatal asphyxia itself. Or it could be your cooling, but cooling generally has seizures in the rewarming. Very unlikely that your gradual cooling will do that. So that is there. Heart. So see, major organs that we are looking at here, which when we are talking about cooling, is your heart and lungs. So bradycardia, hypotension, how do we manage it? Your inotropic support. You don't flood the baby with fluids, getting cold.
What complications will you get?
With the heart.
So arrhythmias also can happen.
Arrhythmias.
Hypertension can happen.
Right. So those are all the and pulmonary hypertension. Now going on to lungs, there will be increased oxygen requirement, your work of breathing can increase. So along with that,
surfactant requirement.
so surfactant, secondary surfactant deficiency can come in, then you can get your pulmonary hemorrhages. Yeah, because your baby is completely cool, no? So we'll go into that afterwards in a little more detail. So this is happening, then we come on to your gut. So gut, again there is ischemia, because we know the vital organs, the blood gets shifted, so there will be a relative ischemia. But at the same time we give trophic feeds, we do not overfeed the baby at the time of this thing. Then kidneys, AKI, tubular necrosis can happen. So all those things have to be monitored. The most important thing which happens when you put a baby here is your metabolic derangements. Hyponatremia, hypokalemia, hypomagnesemia, hypocalcemia. So whenever your baby is on a therapeutic hypothermia and you get seizure, don't say that, okay, it was expected seizure. We have to follow the entire metabolic paneling and panel for this baby. What else? Immunity goes down. Immunity goes down. So these are the maximum, these are the easily correctable things. So your sepsis risk goes very high. So all of these things happen. The other thing is that your liver enzymes will start getting, your liver will get affected. That is the reason why we do our LFTs every day, no? Because whatever drugs you are giving, you will have to look at it that what is the exactly metabolic, what do you say, the metabolism of the drugs can get affected. So when we are starting our baby, we put in our lines, we put in our, we do the monitoring, we do all those things, and at the same time, most of the times we give sedation. We don't want the baby to struggle too much. But do make sure that on day 2 itself, we get the sedation out. Because your liver is affected, the drug might remain in the system for a little while. Okay, so we don't wait till 3rd day. SOS in between, generally not needed, but if required, then a muscle relaxant or something can be given. So blood monitoring on day 1, we'll do 6-hourly blood gases. Okay, we'll do our CBC because thrombocytopenia, as we spoke about. PTINR, your LFTs, your renal functions, basically your electrolytes and everything has to be properly checked.
NSG also. If any abnormality is there, then we have to monitor frequently. Otherwise, baseline we have to document NSG to DECO.
And if you have amplitude integrated EEG, then it will be connected to the baby directly.
So one is visible seizures we can see, but if it is not visible, then we have to monitor according to that also, because it can also cause the brain damage the baby. So we can start the antiphilippic for that, those kind
and then once the rewarming is done, then post rewarming other parameters, and then post seeing that only we make sure that we are now completely okay, because seizures should not be there, your pulmonary hypertension should not have worsened, and all those things are there. So coming to the crux of it again, so say if a baby is born right now, who has mother had say abruptio placenta, suddenly the baby got delivered, you are there for the delivery.
So that is again a medical legal because
See.
they can come again.
This is
after
how it will get
few years and they'll
down.
tell you have not done it properly.
See. And in case there is a baby who has not cried and you have attended and you feel this baby doesn't have a for therapy, it was there. अच्छा आपके पास है